MIS lumbar discectomy, followed by MIS canal stenosis, then MIS TLIF. And if time permits, we will do one vertebroplasty as well. And that will be followed by a question answer session. So we have kept this format. We want to be as interactive as possible. So please feel free to ask any questions anytime during surgeries or even during question answer session. And now I'll request Dr. Jinil Doshi to introduce all the faculties and we'll welcome them.
Hello everyone. First of all, I would like to introduce Dr. Vishal Kundnani sir. He's a chief spine surgeon working at Bombay Hospital, Beach Candy Hospital, Safi Hospital, Spine Clinic Mumbai. He has been trained at Korea, Singapore, UK, Japan, Australia, with his special interest in microendoscopic spine surgeries, minimal invasive spine surgery, cervical and CVJ cases, scoliosis surgery, especially navigation guided spine surgeries. Thank you, sir. And I request Dr. Ashish Desai to felicitate Vishal sir with a bouquet of flowers. Our second esteemed faculty is Dr. Umesh Srikantha. He is a neurosurgeon and spine surgeon practicing at Bangalore, working as a senior consultant neurosurgeon, head of spine services at Esta Hospitals, Bangalore. He has been trained at Hubli, with MCA neurosurgery from Nimhans and fellowship in MIS from South Korea. I would request Dr. Bhagwati sir to welcome Dr. Umesh sir. Next, I would like to introduce Dr. Niraj Vasavada sir. He is a spine surgeon working in Ahmedabad, presently as a head of Department of Spine Surgery and Director, Shelby Institute of Rehabilitation Sciences. He has been trained at Korea, Hong Kong, Germany, Italy, with special interest in adult deformities and MIS surgeries. I would request Dr. Anup sir to welcome Neeraj sir. Last and not least, I would like to introduce our own Dr. Luhana sir. He's a neurosurgeon and spine specialist working at Venus Superspeciality Hospital, Vadodara. He has been trained at US, Canada and Japan with a special interest in MIS surgeries, CVJ anomalies and application of intraoperative ultrasound in spine surgery. With this, I would like to welcome you all and let's start with our program. Our first case is ready in the OR. I will just give a brief introduction of our first case. A 40-year female presented with low back pain, right low limb pain with tingling for the last 4 months, with inability to stand more than 10 minutes, walk more than 500 meters. There are leg dominant symptoms. So like when it was back pain, on examination, the lumbar range of movement was restricted and painful. The right sciatic tenderness was positive. Right SLR is plus. Neurology is intact. We tried all the conservative measures, but there was no relief. That's why we have planned surgery. These are her dynamic X-rays, which showing there is no dynamic instability. There is a collapsed alpha S1D space. The MR shows alpha S1 right-sided paracentral with central disc herniation, causing significant alpha S1 nerve root compression. The axial scans, the axial scans showing significant alpha S1 right with a central bulge, causing significant neurocompression. We have planned minimal invasive microdiscectomy. In this case, the patient is ready in the OR And soon, Dr. Neeraj Vasavada sir will be operating this case.
The case is open for discussion. Anyone,
Yes.
any other comments how someone will deal differently?
Do you want the images?
Yeah, please can you have the image? What's the age of the patient?
The 40 year.
And he's tried a root block, right?
Not tried.
No?
No.
How many days of symptoms?
The 4 months.
4 month symptoms in a 48-year-old young guy with a L5S1 central and paracentral disc herniation. What are the facts? Anup, what would you do? I mean, would you also do tubular discectomy or micro discectomy, conventional discectomy, or an option of fusion is also there considering the retrolisthesis there?
No, I think the dynamic X-rays has demonstrated that there is no significant instability. One factor that I would take into account is the back pain of the patient. What is the component of back pain?
The back pain is not significant, sir.
Back pain is not significant.
Yeah.
So
just leg dominant symptoms.
So that patient will do well with a relief of the root compression. So we have multiple options there also. So either we will do a minimally invasive discectomy or a tubular discectomy, depending upon the surgeon's preference. So micro discectomy or microscopic discectomy has been the standard. And now I think people are more going towards the tubular route. So as a person who I've been doing more of microscopic discectomies, but recently I have adapted into the tube, and I see that the patient comfort is a lot more. And day one, they are much better. They don't have much of that back pain, post-surgical pain will not be there. So all these are valid options. I think, whichever is safe in your hands, you can go ahead.
So primarily, we are going to do only discectomy, and root decompression is the goal of it. And micro lumbar discectomy and micro tubular endoscopic discectomy is one way of it. Pratik, you have been working with Prasad, who's a pioneer in endoscopic surgery. How would he deal with it, and how would you deal with this case? Isn't endoscopy already running in your mind and you're thinking?
Patient has unilateral symptoms only, right side. So initially,
Yes.
root block can be tried, transforaminal block, and definitely if the root block cannot work, interlaminar endoscopy with over the top decompression, because we need to understand the this is last central disc with opposite side component as well. So
No.
so I'm just worried about the.
Because sometimes there may be a radiologically compressed root on the other side, which is not symptomatic today, particularly in this middle age group where there is a subclinical lateral recess stenosis. For example, if this patient had ligamentum hypertrophy on the left side also, would you decompress that without patient having symptoms, or we do decompression only when symptoms are there?
Normally, we need to address opposite side as well if the patient is not symptomatic. But understanding the degeneration natural history, we need to understand that after the decompression of the same root, there is maybe a chance of future compression of the opposite side now. So if the central large herniation and along with the annular
Bulge.
flap on the opposite
That's
side,
right.
then we need to understand that we have to address as well the opposite side of the.
Right. Umesh, your take on it. How would you?
So in all such disc prolapses, we have to identify where is the annular tear. So if you look at closely in the disc prolapse, the axial section, the middle image. So maybe can you give me the point?
Yes.
So maybe the symptoms are due to this fragment, which is compressing on the right nerve root, but the annular tear is central. So this is the acute part of the disc, the disc is still hydrated, and this is the annular tear through which the disc fragment, and you can see there is a small fragment on the other side as well. So you don't have to go over the top for these cases, but usually what I would do is just use a forward angle microdisc forceps and try to remove that fragment as well, though it is not causing any symptoms, but it's still an acute fragment, and this is a central annular tear. So the chances of recurrence, and it's quite a wide annular tear, as you can, the chances of recurrence are significantly higher.
So a high chance of recurrence. Does that add a concern of addition of fusion to this or no? Umesh?
No, not at this stage. So even though there is a central annular bulge, and even in large central disc prolapses, usually I don't do a fusion in the first instance itself. So most of these cases usually settle down. But of course, we have to counsel the patient that in such cases, the incidence of recurrence is slightly higher as compared to routine paracentral disc prolapse with a lateral annular tear. And in case if the recurrence is there, or if in the primary case itself there is some underlying factor, especially in such central disc prolapses, we often see, even in this patient, there is a small amount of retrolisthesis if you observe on the MRI. And if there is a significant angular instability, or if the retrolisthesis is slightly mobile, in those cases, probably, you need to counsel and maybe consider fusion. But many of these cases of retrolisthesis as well do not progress significantly. They do tend to have, chronic back pains, but otherwise they do not ultimately most of them will not require fusion procedure.
Thank you, Umesh. I think Minimal Invasive Spine Surgeons Association of India, or MISSAB as we term it, is one association which is an amalgamation of surgeons from various parts of the country and world, which plan these cases in minimal invasive manner with various options. And the whole idea of this case to come forward is to bring forward the options available to you. We heard Dr. Anup, who has been doing in past micro lumbar discectomy using microscope and maculoxy tractor. We also heard him just moving into tubular surgeries now, and we are going to see a demo of what we call tubular microendoscopic decompression. We have surgeons who do the same case surgically by endoscopic methods, either a transforaminal transiliac method when it's L5S1, or a full interlaminar. We have surgeons who do this full interlaminar, sometimes UBE, uniportal endoscopy. And at the same time now, the basic principles of this surgery remains the same, which, like Dr. Anup highlighted, Dr. Umesh and Dr. Luhana has mentioned, that this patient has leg pain, no back pain. He's a young guy without much instability, and the primary role is to get decompression done, which can be achieved by doing a primary discectomy. Fusion, though it has a limited role in disc cases, but there are certain indications, like it was highlighted, the component of back pain, dynamic instability, facet arthrosis is something that we need to consider before thinking about fusion in these cases. Also, if there is a facet effusion with or without obvious instability, sometimes fusion may be required in such patients to prevent further instability. Now, the highlight of discussion here was a broad annular tear, and this is something that radiologically will help you to understand the rate of recurrence. Again, has to play a very important role in counseling of such patients, because you're going to be doing a discectomy in such patients. Of course, you can do over the top if there is a symptom on the other side as well. But sometimes when there is only asymptomatic compression, you may rather not go over the top and do something from this side itself. Very important to understand is that the prognosis of such cases can have recurrence of disease, and something that has to be brought very clearly before surgery to the patients in counseling. Dr. Luhana, it's your patient. How do you counsel such patients about recurrence, infection, and progression of instability or persistence of back pain?
So I would clearly tell them that the goal of surgery is basically to get a relief from a leg pain. The component of back pain may persist, but for that, lifestyle modification, exercise, core strengthening exercise is important. The recurrence, I would say that 5 to 7% of a recurrent disc herniation. There's a small risk of a scar tissue around the root, and very less likely a risk of a discitis, which is like maybe 1 in 1,000. And the rate of progressive instability in a pure MIS microdiscectomy is very rare.
I think the message is very clear. Microendoscopic discectomy has a very predictable outcome of relief in leg pain, with very, very less chances of progression of instability, even in patients with frank stable degenlisthesis. And these patients often have a recurrence rate of 5 to 7%, like any other discectomy would have. And that is why a frank open counseling to the patient should be done about the recurrence rates. And also, the most important aspect of any discectomy surgery, like any other spine surgery, is about expected outcome. What should the patient expect immediately after the surgery? What is the course of rehabilitation of such patients? And this is something that may vary. Let's hear from the experts, how do they mobilize and what do they counsel? So, doctor, how much leg pain relief can I expect immediately after surgery, and when will I be back to my work?
So,
and then Umesh on.
Yeah, usually pain relieves immediately. Paresthesia, tingling may persist 4 to 6 weeks. Weakness may take time. At times, it may take up to 3 months, and if patient has complete foot drop, then there is a possibility that residual leg weakness will be there. So I mobilize the patient same evening. Usually patient get discharged next day or maybe 48 hours based on how much pain is there. So as soon as they get ambulatory climbing stairs, not needed IV analgesics, plan discharge.
Yeah, it's almost similar. So usually we counsel the patients that the leg pain relief is always significantly much better than the relief in back pain if they have any before the surgery. And leg pain also, some patients do complain of some memory pain, and they complain that there is still some tingling sensation for maybe a day or two, but it means it's not very significant anyways. So we also mobilize the patient anywhere between 3 to 4 hours after the surgical procedure, and the physiotherapist will be there for the first time when the patient gets up. They teach them the log roll technique and how to get up for the first few days, just to avoid any extra stress on the disc. On the first day, on the second day, we teach them basic core strengthening, basic abdominal indrawing, the leg movements, nerve stretch exercises. So we teach them those exercises in the initial thing, and we tell them to continue that for 1 week. And at the end of 1 week, means patients are discharged usually the next day. At the end of 1 week, when they come to the OPD, we inspect the wound. If everything is fine, we send them back to the physiotherapist, and they add a couple more exercises that they need to do. So until 1 week, we just tell them to just keep walking around as much as possible, as much as they are comfortable, not to get any stress or strain, and do these simple exercises like abdominal indrawing, leg raising, nerve stretch reflexes. At the end of 1 week, the physiotherapist will assess how the progress of the patient has been, and depending upon the age, depending upon the pre-op condition, several factors, they add a few more exercises that they continue for a few more weeks.
Thank you, Umesh. Yes, Anup, how do you mobilize your patients and what do you counsel about their pain relief?
It's almost the same. The discharge happens the next day. The very evening, I catheterize the patient, so they are up and going to the bathroom the same day itself. One more thing I would like, almost the same protocols. One more thing that I would like to add is that avoid bending, avoid squatting, and avoiding lifting weights. That I insist for them for a variable period of 1 to 2 months.
So the primary expectation of the patient is relief in pain. That is primarily there in the leg, and we should counsel our patient that the pain relief is immediate and near complete, but never complete. It is near complete. Paresthesia and motor weakness may take its own time to get better. However, this should be made absolutely clear to the patient that the primary goal of surgery is not motor recovery or relief in sensory paresthesias, but it is primarily the goal of surgery remains pain relief, which comes immediately. Rehabilitation may vary from center to center. However, there is no obvious need for prolonged bed rest post-operatively. All these patients can be mobilized the very same day depending on the pain scores of the patient post-operatively. Some of them may have the bearability and they will walk the very same day. But if a patient wants to take their own time for pain relief measures, it's absolutely okay for a couple of more days before the patient can come out of bed. The general tone measures and rehabilitation exercises remain the same, that within patients' pain limits, they can be promoted to come out of bed and rejoin their back, return to work, and all those things can be then supplemented with exercises and rehab program to prevent recurrence. So, Umesh, what if on day 1 post-operative during a rounds, patient says, my pain is only 50% better, or my pain still persists? How much worried you would be? Post-operative day 1, डॉक्टर साहब मेरे पैर का दर्द अभी भी सिर्फ आधा ही गया है या उतना मजा नहीं आया है.
So at times, whenever there is a significant root inflammation, then then probably I would be a little worried. On table, if there is a significant root inflammation you have seen, then probably it may take time to improve. And when I am sure intraoperative, where my pre-op imaging as well as clinical picture would match, in that case I would be okay. I would be okay, and I would just wait and see. At times, you expected significant disc on pre-op. On table, you don't find that fragment, you are not happy, and post-op patient complaining, then definitely you are worried. So it depends on your intraoperative perception.
So the surgeon knows at heart, at the back of his heart, every surgeon knows what is he dealing with. Post-operative persistence of leg pain or post-operative new onset or progressive leg pain is a matter to really be worried about. And the moment you know that post-operatively the patient is not got what you expected the patient to have, which is immediate and near complete pain relief. If the patient has not achieved immediate post-operatively, there is not achievable near total pain relief, it's a matter to worry about. And intraoperatively, your findings must really be able to tell you whether you dealt with an inflamed root resulting into post-operative edema, neuritis as a cause of this pain, or the amount of fragment that you removed was not matching with the MRI amount of fragment. And of course, there are other reasons of post-operative pain. Let's hear from Umesh. Umesh, post-operatively, day one, your patient complains of new onset leg pain. How would you deal with it?
Well, new onset leg pain is always something that needs to be evaluated, means leg pain that was not there pre-operatively. But also we should assess the character and the nature of the neck pain, severity, leg pain, severity, and then take a call. So if it is probably some kind of pain in the same nerve root, in the same distribution, dermatomal distribution. So maybe you can attribute it to intraoperative handling, if there was any kind of a nerve root excessive retraction. Those kind of stuff you need to again go back to your, intraoperative findings and then take a call whether, it is significant or whether, you can wait and watch. Of course, if it is like say for many times, not many times, means sometimes you see that the patient develops a new onset leg pain on the other side, especially if you have dealt with such a disc prolapse and you have not removed that small fragment that from the opposite side. So, and the patient complains of a leg pain post-operatively on the other side. Definitely it requires an evaluation.
Umesh, you beautifully mentioned the details about MRI, that you have to look on axial that T2 hyperintensity as well as hypointensity. So on table, your goal would be just to remove that fragment, or you take out that hump as well, like that. That will be a hump.
That's a very nice. I would like to remove that hump. I would like to remove that this one. I would like to remove that. So that's a chronic fragment, and that's it has got all the propensity to turn into an osteophyte and cause chronic back pain. So it's always better that we remove that hump. But what I would probably try to just shave it off rather than, usually what we do is we open this and we usually in this case particularly the fragment will be outside. But even if there is a small annular fibers that is covering the fragment there, you can see that annular defect there from there to there. So that is where the annulus is ending, and this is a fragment that is already completely extruded. And so you can directly enter into the fragment. It's important to remove this, but in case if it was still covered by an annulus, I would not try to make incision on this area and enter there, rather than that go like this.
And what tool you use for that hard annulus?
So it depends upon how hard it is. So in this particular case, I don't think it will be calcified or anything like that. So you can just pluck it with a disc forceps on many times. Sometimes we can just coagulate and see how much it shrinks. So sometimes if it is just a fibrous or a loose fragment, loose annular kind of a thing, it shrinks and then it becomes flat with the rest of the disc surface. So in those cases, you don't actually need to remove anything.
So now they are ready in operation theatre. Go to OT. Question? Anyone have any question? Any points to add, sir?
Nowadays, we get nerve conduction studies in few of the cases where there is an element of polyneuropathy, because that's very important in diabetic or other chronic illnesses. And we can explain the prognosis to the patient that you might have partial relief of pain.
In all cases you get NCV, or in some specific indications?
Only on clinical examination and history.
So if patient has more of a rest pain, paresthesia as at night, uncontrolled diabetes in history, long-standing history, in those cases NCV is must. That will be a prognostic. Vascular, definitely in all the cases.
The character of the pain, I think, is slightly different from in a compressive neuropathy as well as intrinsic neuropathy. So there you need to be very careful. So as Dr. Rakesh clearly mentioned, if there is any rest symptoms, paresthesias, burning, especially these patients, diabetic neuropathy patients, they complain of burning paresthesias, whereas the disc or prolapse or compressive neuropathy type of patients, usually they complain of more of tingling type of paresthesia. So that's a small difference. I think that we need to clearly evaluate.
Hi, Niraj.
Dr.
Good
Neeraj.
morning.
Yeah.
So while Neeraj comes in, may I take this opportunity to thank Minimal Invasive Spine Surgeons Association of Bharat, under the aegis of which we have organized this. May I also thank the organizing secretary of this meeting, Dr. Luhana, who has taken out the pains to organize this meeting and a wonderful audio visual that is being relayed. I also take this opportunity to thank the OrthoTV team, Dr. Ashok, Shyam and Niraj, who are relaying this meeting on OrthoTV and YouTube link of OrthoTV. Live feed is being available to all the delegates who are interested to watch it virtually from any part of the world. Thank you again. Neeraj, Vasavada, we are able to look at your screen. Over to you, back again. So Neeraj, while your level comes up, would you like to tell us about how are you going to proceed? What are your brief steps and your positioning that you have taken and your anesthesia measures?
Surgery. So the first thing is position is always known for me. Ask the level. I try to target the interior end plate of the disc. I put my needle on the opposite side. That is not area. And this more or less target on the interior end. On the Shyam. Can you see the Shyam? More or less, interior end plate, the lordosis process. How are we going to go? We will first mark the roughly I mark it around this lateral and first to target from the interlaminar laminar bias 1, and from there on will I'm just marking the level. I'll get back to you and take any questions.
Oh yes. So we have Umesh with us. While we'll have Umesh involved into this, the plan here is to do a tubular microendoscopic discectomy, and the pre-operative planning involves positioning, anesthesia, placement of the tube, reaching the intracanal pathology, which is access to the epidural area, reaching out to the disc, removing the disc fragment, and then closure. Right from positioning, let's hear what Umesh would do. Umesh, vertical bolsters or horizontal bolsters, and do you give a break to the table? Do you try to reverse the lordosis? How are your positioning tricks and anesthesia tricks to you?
So no, it's on a horizontal bolsters, one across the chest and one across the hip. So the standard positioning. That was what I used to do earlier, but nowadays we have the Allen table, so in that the positioning becomes quite simple, and we just position the shoulders as well as both the hips on separate holding points. But yeah, otherwise I also, as Dr. Neeraj also mentioned, I also try to preserve the natural curvature, natural lordosis of the patient, not try to bend the spine. We don't try to open up the interlaminar space as we earlier used to do. So preserve the lordosis as much as possible and try to work with that natural curvature itself. the other point is that even in the marking, so usually what we do is we just mark with the needle before we scrub the patient, and we just mark a small horizontal mark, and so that as we paint and drape, so immediately after that we already have the mark. We just make the incision paramedian, and then go deep down. Dr. Neeraj is going to demonstrate how to do that and how to do the sequential dilatation. And after that, we take a Shyam shot to confirm the position of our tube, so if that is okay. How many of you are doing MIS surgeries here? How many of you are exposed to MIS? Okay, 1, 3. So what is the basic principle in MIS? So can anybody say, doctor, can you say what is the basic?
So minimal skin incision, reduce blood loss, early rehabilitation. Symptomatic,
I understand.
the nerve root decompression, symptomatic.
So that is the end result, which you are going to achieve whether you are doing a conventional discectomy, endoscopic discectomy, tubular discectomy, anything. That end result decompression is achieved. So what is the basic principle in
preservation of posterior tension band,
which you do even in microlumbar discectomy? You don't remove the posterior tension band in a microlumbar discectomy.
That
right?
is the minimal invasive surgery.
No. That
Preservation
is
of posterior structures.
Okay.
Supraspinatus.
No, that anyways, even
Interspinatus.
when you do a microlumbar discectomy, you do expose only unilateral. You don't remove the spinous process. Sometimes even we create a facial flap to preserve the facial flap attachment to the midline. You don't even open in the midline, and then you just go through the muscle in a microlumbar disc, non-tubular. So what is this? What is it that you are trying to achieve in a minimally invasive spine? So minimally invasive surgery, basically there are two principles. Of course, in microlumbar discectomy, it is not correct, and as the doctor rightly told, it is preservation of posterior tension band, that is supraspinous, interspinous. So I always tend to believe, Dr. if we still have some time for the marking, so it is very important to understand what is the advantage of preserving this posterior tension band. We all say that there is an advantage of preserving the posterior tension band, right? So what is the advantage? Why do you want to preserve it so much?
So the stability. For biomechanics, like preserve tension band of the.
So that is not going to cause instability. Yeah.
With us, I have my neurosurgeon, Dr. and we have full team of people, audio people, and live. Okay, thank you very much for organizing. So I'm not sure if I'll take my while, but progressing for the midnight and from
Neeraj, would you like to please orient us with the head side, the foot side, and where you are standing?
The head side.
Okay.
My hand is on the head side.
Yes.
The leg side.
Caudal. Right.
Yes.
You are standing on the right side.
I'm standing on the right side of the.
We can see some markings you have made. Have you made it on Shyam?
So this is the midline.
Yes.
Roughly 1.5 meters pyramid.
Okay. Perfect.
The level mark.
Perfect.
The platform.
Yes, we can.
The level.
Perfect.
My incision is Orthopaedic. So the rough incision is around half an inch, 1 inch.
So 25 millimeter 25 millimeter incision, 18 millimeter tube, and the angulation as we see. For L5S1, what is very important to understand is that the L5S1 is a hyperlordotic segment of the lumbar spine. That means the disc is angulated in such a manner that it is pointing more cephaloid dorsally. That means it is going from up dorsally to down ventrally, and that is why your tube also has to come from little superior aspect. It cannot go the bang straight. So if you saw the Shyam image of the needle that Neeraj has put in, one must ensure that the needle is going from little superior towards in line with the disc, and that's very, very important to have a good exposure of the disc fragment. So how do you ensure that the angulation of the disc is and the tube is, so how do you ensure that the angulation of the disc is and the tube is in line?
So I make sure that the lower end plate of, like here, lower end plate of L5 vertebra is parallel to my superior end of tube. So the tube and the disc should be parallel. If there is an angulation, then there will be difficulty in visualizing, especially when there is a migrated fragment. So he is incising skin and fascia, and then you put a dilator in. You do the same way?
I generally avoid using finger dissection. I would rather use a first dilator, which is a 7 millimeter dilator of the tube. But yeah, I think this is also.
First dilator before, I realized that it's my job.
That's right. I think that the two basic principles of minimal invasive procedure, be it endoscopic, be it microendoscopic, be it tubular minimal invasive surgery, number one is to have least possible damage to muscular structure. The posterior musculature, which comprises of quadratus lumborum and multifidus, which provides stability to the spine, should not be disturbed, should not be cut, should not be stripped. You can at the max dissect between the fibers, and this dissection starts with minimal incision on the skin, minimal incision on the fascia, and without cutting it, without having a subperiosteal stripping of the muscle from the bone, you actually dissect between the fibers, you dilate the fibers with the help of sequential dilators, so that you don't have to really damage the muscle, cut the muscle, or destroy the muscle, because that is what decides how much back pain post-operatively patient will have, that is what decides how much fibrosis a patient will have, that is what decides how much early rehabilitation this patient will have, and how early a patient can return to work. So this basic principle of MIS is point number one. And point number two, as I say, is that the more muscle you damage, the more fibrosis, the more bleeding you create by using these tubular retractors, which are not only spreading the muscles apart, but they are also keeping the vessels apart. So your bleeding amount is also less, which occasionally can lead to a bigger problem. So I would say that there are only two enemies of minimal invasive surgery. One is bleeding, and second is the overhang of muscles that come into your vision. By using these tubular retractors, which are fixed to a flexible arm, both these things are taken care of very well. The skin incision, you achieve hemostasis with cautery, as you saw Neeraj doing it, and then you dissect through muscles in a sequential dilated manner that again keeps your muscle vessels away and spread out. That's what reduces the bleeding from muscles across at all, and you don't damage the muscle at all. Now the moment your tube and dilators go in sequentially, you keep tightening on the muscle, and that's how your vascularity of the field also goes down, and your muscles are also away from your vision out. Any comments so far? How have you guys been doing? Sir, I can see you must be doing these surgeries for very, very long time now. So how have you been doing these surgeries so far?
We are doing the same way as you have described. I have been doing last.
But you do tubular surgeries?
Yeah.
Oh, very good. Very good. So the same principle applies to the endoscopic surgeries as well, where the amount of incision and muscle damage is so minimal that you are able to do the same surgery, achieve the same target decompression. Yes, Neeraj, we can hear you. Yes.
So, as you were saying that you must dilator, I prefer to use my finger always. There are
Yes.
two advantages. One is I create a muscle dilator.
Right.
And my fingers get comical.
Right. And also
and the thing is, first dilators, most of them are always fixed.
Right.
So I think, that probably protect aspect of the dilator.
Very true. Very true.
The advantage is I have here.
Right. We can see the fascia.
The fascia you can.
Yeah. So can you again orient us about the
Yeah,
thing?
I'm doing that.
Yeah.
So, this is the head end. This is head end.
The forceps is on the head end.
This is head end. This is leg end. Left, right. This is the lumbodorsal fascia.
Right.
Here.
Yes.
I prefer not to use cauteries for this small bleeders. Sometimes of the just inside.
That's right.
Especially small bleeders would stop. I tend not to coagulate them. They are just can and we take the first dilator now.
Right.
So I have already created a space with my finger. My finger is more or less filling every landmark. And the interlaminar I already dissected the facet joint exam. So I think the space is created and I'll put my first dilator in. This is the docking point for this really at the lower border of the lamina, L5 lamina, and just just lateral to your spinolaminar joint. So this is classical for microdisc. You are doing over the top, you would want to go slightly more lateral, but here we are only doing microdisc. Make sure to have your proper angulation of your teeth because you need to go in the direction of the lordotic angle which your patient is having. Quite a hyperlordotic patient.
So what we are able to see on the screen is the dilators that are walking inside the in the wound, and we are also seeing the tube. Now it's very important that even before your incision comes up, a surgeon must ensure that the armamentarium for doing microendoscopic tubular decompression is complete on table, which involves a sequential set of dilators. So Neeraj, can you show us those dilators? We would like to see those dilators. It involves dilators right from 7 millimeter to 22 millimeters in sequence of 3 to 5 millimeters thickness. They are marked with the length. Yes. Yes. We would also like to see the adjustment of the table. We can also see your Shyam. Can you please highlight us what are we planning there? The camera can zoom out, please. Exactly. So this is what I was trying to highlight, that the mount of the OT light should never be on the just above the surgical wound, because this can sometimes prevent your microscope angulation. You should have a long cautery tip on the table, a small cautery tip. Can we see it on the surgical field, please? Yeah. A long cautery tip, long instruments, long suction tip, dilators of all dimension, tubes of all length. Sometimes you may have a 60 millimeter or a 70 millimeter tube, but the depth of the patient may be 50 millimeter or vice versa. So tubes of all length, dilators of all diameters, and also long cautery tip, long suction tip, and the ability to move the table to get lordosis of the patient, because sometimes, like in Neeraj's case here, we are able to see it's a hyperlordotic L5 segment, and your neck may be working like this. Instead of that, you can just have a head and high of the patient, bringing the lumbosacral junction parallel and perpendicular to the surface of the floor. So these are few things that have to be absolutely mandatorily checked even before your incision comes up, like Neeraj just highlighted, and we'll be able to get a good positioning of the tube and also reduce the intraoperative hassle. As we can see on the right side of the screen is head end, on the left side of the screen. Yes.
This is first, and there are still some muscles which are lying here. Here is muscle belly. belly.
So your table attachment is on the same size or opposite side?
We will return the tube. There are some muscles which are coming.
So it is important to make sure that minimal muscles are coming in. So if you're not satisfied, it's better to reposition it again. Otherwise, you will have to sacrifice those muscles.
Movement of the tube because your dilator is when you are just fall apart. So this here is the beveled end. Sometimes in a flat lamina, whenever the beveled end is very drop inside. This beveled end. When you have a flat lamina, you require a proper beveled like a flat. Your position how it identify the pen.
Yeah, that's much better now.
Stamina?
Yes. Yeah, that's much better.
You have removed the muscle. Just now angulate the tail. It is the cervical lower border. The stamina and the lower border of lamina.
Yes.
You want to start from here. So just try to want the tube slightly the angle what you are interested in. Do not try to cut or damage this muscle. This is probably coming in from the beveled end of the tube.
Okay.
And we want to work down here. This is the facet joint. Here.
Right.
This is the facet joint.
Yeah.
Not exposing the capsule. Here is the isthmus. Must know. This is the isthmus here.
Yeah, that's very important.
If you damage isthmus, you may create
instability.
Always make sure that there is far so how you want the tube? We take the largest diameter tube what we put inside so that the muscle doesn't, and then we loosen that.
So Niraj, if in a beveled, if you come from opposite side, then that angle, that muscle pouting in won't be there. Like.
Yeah, but there's a medial muscle coming inside there. Right?
Oh, okay. Okay.
This side.
Yeah. Okay.
does this basic type the rounded and the beveled one? This muscle
With a monopolar, he is exposing lower part of L5 lamina and medial aspect of fascia.
trying to protect the muscle that I don't cut the muscle. I usually do my operating. Just tell to my low level. You are working below the micro that it targets for this is the interlaminar word and turning. And here is the diameter level. This is a long-ended quadrative, otherwise it doesn't reach all. The conventional short tips not reach all the way down.
In my early days, I have had situations where we have had problems with every single thing that is spoken here. Where if the table mount, then the mount of OT light is bang above your surface. Imagine a mic that is coming in. You will not have the right angle. Why? The surgical field should never be bang below the OT light mount. And that is now, as a rule, even before I wash up, I always see this. So my eyes are screening for problems before I wash up. Is the surgical bang below the OT light mount? Number one. Number two, is my microscope actually working or not? Because I have washed up, the tube is inside, and we see that.
I prefer to drill this lamina with a drill. Not always you require a drill. You can direct your upcutter.
Right.
I'm starting at the spinal laminar. Just level of geminotomy.
Neeraj, can we have your microscope to be moved little towards the right? We are seeing less of that base of spinous process on the tube.
Now?
Yes, much better, much better. Yeah. Again, little more.
For all my MIS, I use this section.
Neeraj, the microscope.
I'm just going from my. I comment part. This beveled and I mean that's the right angle section. So this section from the matrix has a root structure as well as the structure here.
Yes,
and
yes.
You can retract the root and cut also, and it is right angle, so it doesn't come in your view when you are operating.
Right.
This is one thing without which I don't operate any of my MIS.
Right.
Now you are able to see inside the microscope.
Not yet.
You want me to zoom out, zoom in?
Yes. So we are able to see microscope view, but a little eccentric. So can we? Yeah. Little more towards the right. Yes. Little more towards the right. More.
Okay.
Yes. Perfect.
So have a drill. So either you can use with your Carrison Ronja or you can use drill to drill out lamina. I usually prefer to drill whatever I can. That for me.
Right.
You can use your Carrison Ronja. Just thin out the lamina. I don't go all the way. Just trying to thin out the lamina. That is much easier inside. This upcutter is also from matrix set. which Vishal was talking about, and it's a beveled end.
Right.
One of the most important things for a instrument is this bite length. If you're operating from MI, you don't get much angulation, bite on lamina or thick. You have a good bite length for Carison one. This is a long Carison, some when you're operating 80 millimeter or less. So I use always suction in my left hand, one hand, and operate from the other hand. When you're operating from the tube, it is dorsal surgeon use dorsal with an other. You have to train yourself so that you can both with same hand. I'm just trying to my Carison inside the lamina. From here now. Bite from here.
So Neeraj, your extent of laminectomy would be upper end of ligamentum flavum, or you try to would cut?
Depends, sometimes alpha S1 you don't need too much of laminectomy. But in this particular case, I think it's quite a collapse, so I might have to go a little upward.
Right.
The lamina is almost at the lower end of the lower plate level on the Shyam. More or less, I have to go at least up the superior end of the upper end of the disc. This fragment.
Right.
So I'll have to do around, I would say, around 3-4 millimeter laminectomy this for the patient. But if you have a tall disc, if you have a good interlaminar space, sometimes alpha S1 doesn't require much of a problem. You can just make the ligamentum flavum and side.
Right.
One of the most important steps for any microdisc surgery, what is and Umesh was also segmentectomy, that is more or less enough. But I prefer to do good foraminectomy in patient I operate from disc. So that is the area which sometimes leads to fibrosis and later on starts having problems.
Yeah, I agree with you. It's important to do a foraminectomy apart should be discussed.
And part of this joint removal or part medial facet removal is always important. Whether you are doing a discectomy surgery or you are doing surgery. Away from vestible. Now you can see the flavum which is quite evident. This is the S1 lamina, superior end of the S1 lamina. So our original lamina was almost here, overhanging on the S1 lamina. So we have to create a space that we can enter into the epidural. Might again have to build the tube so that we can go upward. You need to tilt your tube, bond your tube a couple of times to reach the desired area.
Well, that's a very important step, bonding of tube. Like once you, at initial practice, I was just keeping a fixed tube in that case. So it's important to do a bonding whenever it's needed.
Different area you need to bond your tube different. Right. I'll just done laminectomy, go inside, I'll just bond the tube and try to go right.
So initially, when there is a collapsed disc, to get with a narrow interlaminar window, he had to keep the tube angulated inferiorly. But now again, he's bonding it superiorly. Sorry, Niraj, we didn't know that you use flat tube. I like bevel tube a lot, so you can do more work from a smaller diameter tube. That's why I use bevel tube. Yeah.
I mean, this is a flat lamina.
Right.
A flat lamina, this bevel would be ideal. Quite a flat.
Umesh, use bevel tube or straight tube like bevel? Yeah. Neeraj? Array. Vishal bhai? Straight tube. Okay. I am just asking.
I only use bevel tube when there is a quite an angle of the lamina. So that facet joints are probably and the rounded more obstruction.
In fact, nowadays there is the availability of 3D patient-specific bone model tubes of per lamina. So they are 3D printed anatomical tubes as per the lamina angulation, for which you have to just do a CT scan of the lumbar spine and see the angulation in the prone position for that particular lamina, and you get tubes. Per tube is 25,000. Yeah, that's it. And they are available in 3D printed format as well. Yeah. They are available in Bombay. I think Ahmedabad also has a company called Genex. Yeah. So the advantage of those tubes is primarily that one, they come in a material which is resistant to the electric cautery, so the skin burns are least. Second, they are very patient centric, so the muscle damage is further less. 3, they come in the form of angulation of the lamina in medial lateral plane also and in superior inferior plane also. So they would absolutely sit bang on the lamina. The problems arise. Yes.
Right, you can see that. Be little more focused. Yeah, better. Yeah. Right. Right. Yes, yes. Very clear. It's always better to find a route before putting an incision on LUS. So make sure that you see traversing route, then only you would put a incision on a disc.
Here you have to decide, whether you want to go further lateral, to reach enough laterally. This is the portion of the bone you still want to remove or not. Try to preserve your lateral bone as much as long as possible so that you don't again damage the ligament, the facet joint. See the root here now?
Yes. Now we are reaching lateral to the root.
This is the root.
Yes.
See that is root.
Yes, yes. Very well. So it's important to make enough space lateral to the road so that you don't put too much of traction, especially when there is significant protrusion.
Upcutter also, majority of my cases, it takes time. Your that gives a lot of layer inside this.
It's a good instrument.
Goes inside and your
Which company make it this? Angulated cutter upcut?
sorry.
Which company make this? Angulated? This one? Oh.
So two companies that make these curved forwards is Gister and one is also available with MJ Surgical from Ahmedabad.
Jesco and Geon, they both make it. So it depends, what you're comfortable with. I think that's Jesco one.
I use the Gister company which has a removable handle also and it has variable angle also. And they're very nice for undercutting under the facet. Any questions to any of the delegates? Anyone who wants to ask a question to Dr. Neeraj? Anyone? No? Pratik, any question that you have to ask?
Hello, sir. Pratik here. Sir, am I audible?
Neeraj, there is a question from audience. There is a question. Yeah.
So what is your plan for the opposite side disc, which is
So it's unilateral symptom, right leg symptom, no left leg pain.
is it possible to get the opposite side disc fragment from this side, from ipsilateral?
So here there is no contralateral ligamentum flavum or facetal arthropathy. So this just disc protrusion can be taken out from the same side. You can use long tip blunt hook and then push it ventrally.
Most important point which I feel is, before you start doing discectomy, make sure that you have done a root laminar decompression. Otherwise, if you keep on retracting root, and if your root is somewhere tight around the foramen, that may go better.
That's a very valid point. Do a foraminotomy before discectomy so that you have to minimal retraction.
My kerison, the number kerison inside the foramen, inside the bite for the root, and not down by retracting. Suppose ready to put incision on the disc face so that all the well parameter. So I'm just getting ready for any sort of disc right. Everybody can see this?
Yes, very well. So the root is retracted and you can see significant disc protrusion there.
What my root retractor does, this will retract the root and start. So make sure that you are releasing the root in between. This time you are waiting for. This is just a nick on the disc. These root so that it doesn't retract it. So that your root retracted for a long time, you also need.
So that is also very valid point. Release root in between. Prolonged root retraction may be a cause of post-operative paresthesia. So what about the size of annular incision? Does it matter? It doesn't matter. You try to go through, try to find natural rent or.
This does matter.
Right.
Try to just
So fish out with hook and then use a disc forceps rather than retracting root and trying to find fragment.
and there is one acute one. Two fragments lying there.
Hello?
The idea is to fish out as many fragments as possible. As many loose fragments. And microdisc is one surgery where, my co-surgeon doesn't have to I would want to retract the root myself, so I'm very much aware at every point of time how much I'm retracting the root. This looks like the central fragment, not something. Third fragment we should have taken out.
Yeah, that's a huge, huge fragment.
So many times you encounter this kind of fragment with this throat. So I have this curved disc. This is a curved disc process. I use a very small curved disc process. So if I want to go on the opposite side from the root, I can see this.
Yes.
Around 45-degree angled upward this process. I think the majority of central and right side disc we have removed. We'll try to remove on the opposite side.
Hello? Rakesh bhai, Maulik here.
Yes, yes, Maulik. Good.
So, what are the extra points if the disc is calcified or hard? Sometimes we have seen the knife is also getting bent if you are trying to put incision over the.
So, if you have a calcified disc, you don't always have to remove the disc. See, always be sure that the purpose of microdisc surgery is not to remove disc. The purpose of microdisc surgery is to release the pressure on the nerve. So, if it is a calcified stable disc, you don't need to remove it always. However, there are some cases where there are is a congenital in narrow-spinal canal, very tight stenosis. In those cases, you would want to do a removal of calcified disc. But otherwise, the purpose of surgery is always root decompression, nothing else.
And usually in a calcified disc, you will find some soft fragment or just calcified annulus with a soft fragment beneath.
Right.
So once you just get in.
Yes, annular lips are sometimes calcified, and there will be a central portion will be causing the acute. So this is more or less, we have done a discectomy on this side centrally. I'm just trying to take the other side.
So, Rakesh bhai, do you recommend using drill, high-speed drill, if it is large protruded calcified disc which is not relieving pressure on the root?
Yes, at times yes, but that's usually you don't need. So what my observation is, usually I do foraminotomy and try to, with a palpation with a hook, you try to find a soft point where it has protruded. There will be thin annulus. You put an incision there, take out the fragment, get in, use a punch and take out that calcified component and then decompress. And that at times you will find that calcified hump that you need to drill it at times. But that's very, very.
And sir, what about using scraper? Disc scraper, what we use in TLIF.
Yes. So usually you don't need to use it, but at times in a hard fragment, you get into the disc. I use reverse angle curate and go back and push the disc fragment ventrally and then take out. That can be needed at times.
So we are almost through, Rakesh, with the discectomy.
Yes.
There's no fragment opposite side also. I'll show you.
so that the audience can see. There are two ways to check opposite side. One is, you slightly retract the root, use a long hook like this, retract the root. You can go almost, this is almost opposite side. There is nothing left here. This is one way. Specifically, these are annular flaps. You don't need to remove annular flaps. Umesh was saying previously that you can burn it if you want, but generally the other one is an alpha S1. You can go from the axilla of the root. This is the axilla, and you can check the opposite side, which is more or less free of any fragment, or you can just try to push it toward this side and check that, if you have received any soft tissue.
Yeah, so if there is no ligamentum flavor
which I personally feel is, I try to use bipolar, unipolar, everything to the minimum in epidural space, because that prevents carrying in my damage much of the epidural fat, which is still here, and the moment we will close, it will cover the root. So we have done the fragmentectomy and this much of flavectomy. The central flavum is also intact, central bone is intact. This is the joints which are intact. This foramen which is completely free. So that is the purpose of his surgery, is to make the root free. If you see, the root is completely free. It is moving freely.
So would you try to get into the disc space and find loose fragments?
No, I'll just try to hook and try to find out any loose fragment which comes out. I generally don't go inside the disc with my disc forceps to go. So if you see, what we do is, this is the annulotomy. I just put my ball tip or probe inside to. We don't use that wash, with so that the fragment wash out. This looks pretty intact annulus here. You see.
Okay, right.
This is pretty intact annulus. It was just the ruptured fragment, and this is the superior. The annulus is not showing any other loose fragment. You can check 360 degree. We don't find any intact loose fragment here. So I think for me this would be end of my surgery. Wash.
Yeah, agree. Any other questions?
So I don't put this wash inside the disc space. There is no particular reason why I don't do it, but that has been my practice since day one, that I just try to fish out as many fragments as possible with my hook or a nerve hook or a ball tip probe, and then just.
So there was one paper which suggested that irrigation reduces chances of discitis. So I usually do a lot of irrigation.
No, that's
personal problem.
Absolutely all right.
Any epidural medication drug that you routinely use?
Neeraj, any epidural medication like steroids, xylocaine, mixture of sensory?
That's personal choice. Steroids you can put. It may help in prevent probably post-operative some root pain or anything which patient may have. There is no harm which has been reported in this steroids. So I generally don't put anything. I would want to keep this space as it was. Not much change inside.
Any fat graft?
So I'm seeing this one ligamentum flavum flap here. I would want to remove this because that may.
Any fat layer that you put there?
I think this epidural is fat. I'll just reposition. The fat is always here, so I'll not much put anything extra. There is probably one ligamentum flavum piece laterally which is just touching the root. So I would want to remove this because that may sometimes get adhered to the root.
Sir, if this patient had symptoms on the opposite side, what would have been your?
Over the top.
The next surgery, Umesh is already there.
Over the top, I would have gone. Just to check, but more or less I know that, I've removed the disc fragment from the opposite side. But if patient is having symptoms on the opposite side, I'll definitely go on the opposite side, over the top to check the root. So, ball tip, final checkup, and then we'll close. This lateral recess is also free for the patient. I don't want to see the exiting root. This is the root which is pre-mobile, and this is the fat layer. I'll not touch much, so this fat would take care of itself, and we'll remove the tube to see that how good muscle falls back. You can see the muscle has fallen back. It closes the space. So thank you guys. Thank you.
Thank you, Neeraj. So
we have another anesthetist, madam, whom we forgot to introduce. Madam, I'm sorry, Dr. Patel. So thank you, anesthetist. Thank you, staff. Thank you, Pratik. Thank you, Vishal.
Thank you, Neeraj.
I'm free now.
This beautiful relay is happening from one of the state-of-art spine surgery center in Baroda, which is Dr. Rakesh Luhana's parent institute as of now, and it's Venus Hospital in Vadodara. Dr. Luhana is a senior neurosurgeon who has a center in Vadodara, and all these live surgeries are relayed from Venus Hospital. We thank all the staff members there, anesthesia team, and all the relay staff and audiovisual team from the OT in Venus Hospital to conduct this for us. Thank you so much, Dr. Patel, and thank you so much, AV team over there. Any questions to delegates around? Any questions?
Sir,
yes.
What are the chances of dural tear in this type of cases, and what are the possible ways we can manage in times at least?
Neeraj, what is the incidence of dural tear in microendoscopic discectomies, and how do you manage that
It all
dural tear?
depends on your learning curve. When you are initially in your learning curve, the dural tear rate would be slightly higher. Internationally, it is around 5 to 6%. So most likely, when you are operating from the tube, the dural tear will be very, very tiny. But if it is repairable, I would always want to repair if possible. There are some surgeons who don't repair, and that is also a fine way of dealing it. Just use any sealants what you are using. We use T-cell. You can use your pad, put a T-cell and come out, and that would be okay. In my experience, one patient I had arachnoiditis where I did not repair the dura long back. Since then, I have made it a habit to repair dura watertight as much as possible. If required to put a dural patch or a very bad tear, that's probably, I would weigh in an option whether I want to repair or not. But small tears, always repair, because small tears inadvertently lead to root entrapment and your patient may have pain. Try to repair if possible. If need be, if you cannot repair from the tube, you should repair it by just making incisions wide open, but never leave dural tears without unattended. I have always seen whenever I have not repaired, CSF comes out. So I have made it a habit to repair.
Right. So dural tear in MIS incidence is almost same as open. Initial learning curve may be more, but then it's almost the same. If it's and it's usually forgiving because there is a lot of muscle flap that is coming back. There is less desk space.
People ask me about
so whenever there is a small dural tear, I use graft pressure that ENT people use for tympanic membrane. So I take out that muscle piece initially, keep it in a saline. When I need it, I just press it with the graft press. It makes a small patch. I put it over a dural defect and put a glue over it. Whenever there are roots coming out, we try to put the root back in and then cover it. If there's a large defect, I use G patch or Dura patch and a glue over it.
Rakesh,
Yes,
you
Niraj.
have a god of dural repair with you. You should ask him to show the video. Umesh has a beautiful, scary video, and he repaired dura. So if you get time, I'm sure he would have that video.
Yeah.
I had my heart in my mouth, when he showed that video and how beautifully repaired it from the tube.
Right. Okay, thank you. Any other questions? Okay, thank you,
All
Neeraj,
right,
for
thank
excellent
you,
demonstration.
everybody.
Thank you. Yeah. So once the tube is taken out, the fascia is repaired and then skin closure. We have a tea, coffee, and cookies if anyone wish to have it. And we'll move on for next case, which is a lumbar canal stenosis.
So 48-year-old male with right-sided lower limb radiculopathy due to L5S1 sequestrated extruded disc fragment, as we saw here, was done a microendoscopic discectomy performed using tubular cylindrical tubes. The surgery started with general anesthesia, prone position, horizontal bolsters. After positioning, maintaining the lordosis, a paramedian incision given, muscle dissected, dilators inserted, tube placed on spinolaminar junction, dissection of the muscle carried out. At the base of spinolaminar junction, a small laminotomy created, ligamentum flavum released, access to the epidural space created, a nerve root retracted medially, reached the disc space, removed the disc fragment, added foraminotomy, partial flavectomy was added, all the disc fragments removed. It was checked on the contralateral side if there is any free root fragment, and then closure was achieved with good hemostasis, allowing the muscle and fascia to fall back. And that was the end of a beautiful demonstration of a microendoscopic discectomy. And now we are moving on to one step ahead, where the case we were discussing, where we have bilateral symptoms. Dr. Luhana will present the case to us.
So in a journey of MISS, you begin with a simple discectomy, then ipsilateral lateral stenosis, and then move it to contralateral decompression from one side. So here is a 57-year-old gentleman who presented with a bilateral leg pain on walking more than 100 meters or standing more than 5 minutes. That was going on for 6 months. There was no significant back pain. On examination, he had neurologically intact, peripheral pulse are okay. It's always check pulses, rule out vascular claudication whenever patient presents with the claudication. So we got a dynamic X-rays which showed no significant instability, and this was his MRI. It showed he had sacralized L5, so significant L3-4 stenosis. And these are axial, again, with some lateral stenosis at 4-5, but the significant at 3-4. These are axial views showing severe 3-4 stenosis. There is mild L4-5 lateral stenosis. So, anyone, how would you do it? Sandeep? So there are various ways to do it, right? Decompression. So you would do laminectomy or laminotomy, or you do complete laminectomy, laminotomy. What is your preference?
Yeah, minimally invasive L3-4 decompression.
Right. So minimally invasive L3-4 decompression. Rakesh, Jasani? Same? Okay. Anyone would do it differently? You would address L4-5 as well. Okay. Pratik? Both with? Okay, okay. Sorry? Sagittal facetal orientation. So you would like to add fusion here? Yeah, so it's important. That's why here microscopic surgery would get into play. It's important whenever there are sagittally oriented to prevent iatrogenic instability. It's important that you stay medial and go this way, like you try to preserve facet from medial inside. Right? Javeri sir?
We'll do minimal invasive bilateral, and many times we do with single midline incision and go bilaterally minimal invasive, removing the ligamentum flavum and the bilateral foraminotomy.
Right. So the ways are either in open you do just midline incision, midline fenestration, bilateral decompression. You can do bilateral fenestration in open, and or in MIS go unilateral approach and go to right side. So in MIS, if it's right-handed surgeon, usually you go from left side and do a bilateral decompression when symptoms are bilateral. If the symptoms are unilateral, you go from the symptomatic side. Dr. Vishal, in addition?
Yeah, I think there are many things. So the decision making about how to do it and what is to be done are the two most important aspects of planning. In this case, where there is bilateral symptom in a middle-aged gentleman with 2-level canal stenosis, we know what is to be done. We know that the principle of surgery involves decompressing the L3-4 and 4-5. Both the nerve roots at both the levels have to be decompressed by removing the hypertrophied ligamentum flavum. The medial facets which are hypertrophied more at L4-5 have also to be taken care of. So the end point remains the same. The principles of surgery do not change. What you have to achieve, you have to achieve. How you achieve this? Once you have defined that you have to achieve X amount of decompression at X number of levels, how you achieve it is purely a game of technical learning, and this learning evolves with time. Every surgeon who has been an open surgeon will evolve to a MIS surgeon, and every MIS surgeon has reached because he knows the basic anatomy of open surgery. So at what point of your learning evolution you are, you can decide on what is to be done and how is to be done. In this case, we know what is to be done. How it is to be done can vary from our very senior surgeons who have been doing a very efficient laminectomy and medial facetectomy to surgeons who do endoscopic, minimal invasive, lumbar canal stenosis decompression using only pure endoscopic techniques. And in the middle, there are multiple options of what neurosurgeons call MIDAS, minimal invasive decompression of spinal stenosis where bilateral foraminotomies are being done. It can be also be what we used to call expansive laminoplasty, where you do not cut the spinous process, you just expand it by laminar spreaders, which was the time of evolution, to a tubular microendoscopic decompression where you go from one side, spare the muscles and do over the top decompression on the other side. And you have to see how efficient you are in doing a particular kind of procedure. Like for me, this is a microendoscopic tubular decompression, but if this was a 3 level, I would be really wary about doing it any endoscopically or microendoscopically, because 3 level tubular decompression can not only tire a surgeon, fatigue the surgeon, the surgical time is more, the blood loss is relatively more than an open surgery, whereas in an open surgery it would be a straightforward laminectomy 30 minutes job. In a microendoscopic surgery, it may take 2 hours for 2 level, 3 level surgery may take another hour to add to it, and the surgeon fatigue can actually compromise the overall results. So in the phase of learning of the evolution of a surgeon, what kind of surgery you would want to do, your technical skills will decide on that. Of course, the principles and the benefits of minimal invasive spine surgery cannot be neglected, and the learning evolution has to evolve with period of time. Yeah.
Okay. So we go to OR.
So we have with us Dr. Umesh Srikantha, who is going to do a tubular microendoscopic decompression using a microscope, where unilateral access, bilateral decompression using over-the-top technique will be utilized. And the primary goal is to do L3-4 decompression, SOS L4-5. Let's hear it from the surgeon himself, Dr. Umesh Srikantha. Any questions so far? Any questions? The plan remains the same. We saw how to dilate through the muscles, how do we dock the tube, where do we dock the tube. The preparation for surgery remains the same. The anesthesia part remains the same. And because the surgery is same through the access part, the rehabilitation also remains the same. Yes.
3 level decompression require 3 different incision or only 2 incisions?
So again, it's a very, it all depends on the patient's habitus. If a patient is a thin and lean patient, just by using a single incision, you can go for L5S1. Through the same incision, you can reach L4-5. Problems arise when you are reaching for a lordotic fat patient for 3 levels. Whether your tube can bend and see the 3-4 in line with the disc or not is a big question. So in this case, if you see the basic principles remain the same. Your tube, when sees here, has to lie in the line with the disc. It has to be in the line of the disc every time you are doing a decompression. So here you can get in line with the disc. The same incision will allow you to have in line with the 4-5, but whether the same incision will allow you access to this level in line with the disc, probably not. And that is why a second incision may be required. However, in a hyperlordotic fat patient, through the same incision, you will be able to have this, this and this. Say a hyperlordotic fat patient, single incision for 3 level may be possible. But for a thin patient with a very thin and lean body habitus and a straight lumbar spine, which is not so lordotic, it may be difficult even for 2 levels. Imagine this a partially kyphotic or a collapsed disc space. It will be extremely difficult for you to get incision in line. And sometimes surgeon's ego will not allow you to take a second incision, and you may try to bypass the principles and have intraoperative struggles. So maybe as we get time, I'll show you some of the cases where how struggle can mount and compromise your surgical results.
Excuse me, Vishal sir.
So initially I started doing 2 level with single incision, but in that case, obliquity and you would get your neck would be get tired. So now what I do is I do it one from one side, upper level from opposite side, and if it's 3 level, one on left, right, and left. So that your laminotomy on one side, second side, on a contralateral side, so post-operative pain would be less, instability chances are less.
Excuse me.
And it's always better to align your incision in a line of disc.
Excuse me.
So we'll go to OT now.
Hello. Hello. Hello.
Umesh, we can hear you, but we are not able to see the screen. Can we have the OR screen? Yeah.
Hello.
Yes, Umesh. Umesh.
Hello, sir. Pratik here.
Yeah, hi, Dr. Pratik. Can you enlighten us about what your case is like? What is your surgical plan? Yeah, Pratik, your first case. Yes.
Yes, sir. I mean, the first case we have just closed the incision, so we wanted to show the incision that the incision is less than an inch. So we need to show the incision. We have already closed it.
Okay.
So that will take a minute.
Please.
Just we'll show it and then we'll shift to the second case.
Sure. Perfect.
Okay. Can you
Yes.
see it?
Yes, yes.
Okay, sir. Thank you.
Thank you so much.
Now we'll be shifting to the second case. Yeah. Thank you.
Umesh, can you hear us, Umesh? We have with us Dr. Jinil Doshi, who's getting ready and gloves coming up. उधर Jinil, do we have time there? Or if yes, if we have time, we can come back. Jinil? Can we slide? So I'll try to show you how what all can be problem mongers in tubular surgeries, because today we are going to see the technical demo of how to do a particular kind of surgery. But unless until you are prepared about the problems that can come, unless until you know the problems that can really enhance the struggle, you will not be ready with the salvage. And that's what the typical learning curve or evolution of tubular decompression procedures is all about. Yep. So how to avoid problems and what are the salvage options? I'll just show you. What can go wrong will surely go wrong if you are not prepared. Particularly when it comes to technically dependent surgeries, any surgery that is technologically approved but technically dependent will go wrong if it has to go wrong only if you are not prepared. And that means if you are prepared, you will be able to avoid 99% of such problems. And believe me, in the whole learning curve, there are multiple surgeons. My own papers, we have at least 5 such learning curve papers where we have evaluated our own results of first year, second year, third year and fourth year results, including the struggle, including the surgical time, including the blood loss, the number of days of stay, the neural problems, the dural problems. And we have come to a conclusion that first year is the most difficult year. First 25 cases are the most difficult cases for tubular spine surgeons. And these difficulties are all avoidable. We could have avoided them day one, and this forms the basis of the learning of all the youngsters who are evolving into tubular surgeons. And the issues can be purely prolonged surgical time, either due to poor planning intraoperatively, poor execution intraoperatively, or it can be pre-operative planning issues, guide wire related issues. And the most important, most common problem that a surgeon faces is about tube docking issues. If your tube is not docked well, 99% your surgical time will be more. If your tube is docked well, all other problems will be circumvented and you will be able to do this surgery seamlessly. Inadequate decompression again can happen purely because of docking issues. Dural tear and neural tears are also if you are trying to struggle with the tube because of inappropriate positioning of the tube, and also if your tube is not placed well, there will be an inadvertent facet injury or a pars injury which you will not even recognize intraoperatively that you have taken down the facet or the pars is already broken. So how do we avoid these problems? There are 6 tips that I would like to come up with. Correct indication. We saw the evolution that we started with discectomy. We are going on to lumbar canal stenosis. Then as the day progresses, we will see MIS, TLIF coming up. And as the day progresses, like Neeraj has evolved into OLIF surgeon, there are direct lateral access and there are surgeons who do it, cervical spine surgery also. But these are the 6 basic points that you have to take forward that your surgery has, and your surgical hood, as a surgeon's ego has to evolve only in these 6 points. So what are the correct indications? You have to not only evaluate the right symptom which will get better with that particular surgery. Back pain, you do a surgery, is 100% bound to fail whether you do a tubular or not. Radicular symptoms are the first symptoms that you should choose for any kind of surgery, be it open or microscopic, and the principles of right indication do not change just because you are becoming a minimal invasive spine surgeon. And that is why the indications have to be absolutely thorough, and the principles when to do surgery do not change with MISS. You have to understand the basic symptom, and the basic cause of symptom has to be absolutely clear right in front of your eyes.
Nice.
And it's a recommendation that please, in your first 50 cases, do not try to choose any complex case where there is very severe facial arthritis, severe developmental canal stenosis, like in the screen as you can see, the facets are so nearby, hypertrophied, there is a bony central canal stenosis. These are the cases you may inadvertently not only damage facet, sometimes neural injuries may happen because of retraction, and problems like pars injury is very, very common in such case scenarios. Multiple levels, again, these are the cases which in your early 50 cases, please don't try them. And in patients with high level listhesis or in a fixed listhesis, please avoid minimal invasive surgery. At least in your first 50 cases, you may otherwise have problems and develop aversion to such cases. And the ladder is very well described. Multiple papers have described this. Now, planning a surgery, particularly minimal invasive, we must remember that our vision is tubular. You can only see that much what is seen through the tube. You can't see anything beyond. And that is why your 3D mental navigation of the anatomy has to be absolutely precise, because you will only be able to see what is seen through the tube, but you have to see far beyond the tube in your mind. That tube dikha itna raha hai, but mujhe dikhna bahut sara chahiye. And that happens when you know the pathoanatomy. We all know that ligamentum flavum is something that is seen through the tube. We all know that the relation of spinolaminar junction and the spinolaminar line is seen. Part of it is seen through the tube, but we all also must understand, like Neeraj highlighted, that the ligamentum flavum span under the lamina is also there, which is not seen. On the opposite side is also there, which is again not seen. And unless until you have the understanding of the span of whole ligamentum flavum, you will not be able to remove all the decompressive structures there. And all this you have to extrapolate through this circular tubular structure, or even in endoscopic anatomy. Your understanding about anatomy has to be very, very good, because your pathology, whether it is a inferior migrated, superior migrated, laterally migrated, far lateral disc, has to be understood. So this understanding of precise location of pathoanatomy in relation to the anatomy, which you have read through CT and MRI, this correlation in your mental mind is absolutely, absolutely important. This meticulous understanding of anatomy helps you about tubular surgical planning there. Some variations which have invariably been associated with bigger problems of tube docking problems intraoperatively. Spinous process. For example, if this patient had right-sided discectomy that we just saw, Neeraj did a right-sided discectomy. Just imagine the spinous process deviated slightly towards the right side, which you had missed. Your tube will not be able to reach there if you are doing a right-sided decompression. Your tube will continuously slide away. And that is why it is very important that pre-operatively you have assessed whether the spinous process is straight in midline or angulated slightly. Because if it is angulated towards the symptomatic side, it is better not to put your tube, otherwise you will just not be able to reach to the pathology. Your disc fragment will not be able to reach there. It is better to come from the contralateral side. And same thing happens when there is a Dijon listhesis, which happens in 50-year, 55-year, 60-year-old patients, where there is a slight rotation of the affected vertebrae, and this rotation, the spinous process will be deviated to one side, and in an attempt you will do a true AP intraoperatively, but your tube will not be able to reach to the pathology, inadvertently resulting into you forcing yourself to remove the facet to reach the pathology, causing instability there. And also not only rotation or angulation of the spinous process, sometimes the facets may be vertical. So if your tube gets docked on the facet, you may actually end up removing the facet, and you will never come to know that you have removed enough amount of facet to cause instability. And this all has to be planned in the tubular manner. You not only have to see the spinolaminar line and spinolaminar junction where the tube comes and gets docked, but also the span of ligamentum flavum underneath the lamina has to be understood very well, and all this extrapolated in your mind all through the tubular vision. We spoke about the requirement of microscope. You have to see whether microscope is working or not. So at this we will stop here. So this is that one slide that you have to prepare before washing up, before your incision comes up, the long length of cautery tips, suctions, handles, forwards, dilators, tubes, cautery tips, bayonet suction pumps, and availability and movement of your microscope, whether the light permits it or not. We'll move on to the rest three very soon as the surgical case comes up. All before the surgery.
Excellent tips, Vishal. Hi, Umesh.
Hello.
Yeah, Umesh.
Yeah. Hi. Hi. I was able to hear you that time when you were calling, but my mic was not on.
Yeah.
So I'm sorry.
Fine. Okay, so your marking is differently. Tell us about your imaging and your plan. Yeah.
Yeah. Again, please. So basically, I do this step before the painting and draping takes place, but here now the needle marking takes place.
So here is a sacralized L5. So it's important
so
whenever
this
there
is
is
the
segment.
second motion segment that we are looking at.
L3, 4, but second motion segment, second last.
So I'm just changing the position of the needle so that it is exactly coaxial to the disc space. Okay, so I think that is acceptable. So as you can see, this is the second motion segment that we are dealing with. That is the L3, 4. This is a sacralized L5. I think the case discussion is over, na, Dr. Rakesh?
Yes. You can tell us your inputs. Yeah, we have discussed about the case, but tell us about what you think and what are your plans. Yeah.
So basically, I think for a bilateral decompression, that is over the top decompression, what I call is UBF, that is unilateral approach for bilateral foraminotomy. It is a term that I imbibed in during my fellowship. So basically, what we have to do here, we approach from one side of the spinous process, do an ipsilateral decompression, then go to the contralateral side, do a contralateral decompression. So for ease of understanding, we would like to divide it into 4 quadrants, that is ipsilateral upper, ipsilateral lower. So as you can see, in a discectomy, once we position the tube, the amount of wanding that is required is not too significant. That is because our entire pathology is directly under the tube, whereas in an over-the-top decompression, we need to keep wanding the tube more regularly or more frequently in order to access the area of pathology. There are times when we might have done a beautiful decompression directly under the tube, but might have left compression either superiorly or inferiorly or on the contralateral side. So that is very important. What is another thing is pertinent to this particular case is the facet angle that we need to see at. So I was informed that this patient has symptoms bilaterally, and it is more on the left side than on the right side. So in a normal course of events, we would approach this patient, or the approach side will be from the left side. But if you see the facet angle, it's almost sagittal. There is hardly any gap between the spinous process and the facet joint line, and that will limit our ipsilateral approach to the lateral recess and the entry zone of the foramen, where we need to do the decompression. So basically what we have decided in this particular case is to approach it from the opposite side. We are approaching it from the right side, and we are going to do an ipsilateral decompression and do a contralateral decompression, where the visualization of the contralateral foraminal zone or the entry zone of the foramen or the subarticular zone on the contralateral side is much better when we go from the right side as compared to when we go from the left side. So that is what we can see. So that is this one. I think we have also discussed this patient has L4-5 moderate canal stenosis. I think we are not addressing that as of now. So what I have done here is I have marked this. So if you can see the Shyam image, the needle, unlike in disc space where we target the inferior, or most often we target the inferior end plate, whereas here we like to be more in the center of the disc, more of coaxial to the disc space, because we need to do a laminotomy that extends all the way to the, give me a markup. And
how much lateral to midline you are?
So I'll just mark it. So this is the needle. So this will be our entry point. So what I'll do, I'll mark a horizontal line. So usually the horizontal line, we mark it all the way across. Now, it's not necessary that we need to always take an AP view in order to mark the midline. So usually in a thin patient, or even in sometimes even in obese, by palpating, we can actually mark where the spinous process is. So this is what we do, and then you can just join these lines. So usually my incision is closer to the midline. I'll explain why. So because see, we use a bevel tube. The more lateral we come, the lateral edge of the bevel hits against the facet joint, and the medial muscle creep is more. So these bevel tubes actually were designed in order to do just bang on the spinous process, so that the lateral bevel because of the laminar slope, the lateral bevel actually pushes the muscles away on the facet joint. But of course, when there is a facetal hypertrophy, despite this bevel tube, there is a significantly higher risk of local infiltration. Nahi hai? Okay. So usually I take local infiltration, xylocaine with adrenaline, and we infiltrate before we mark. So just to orient again, this is the midline. So this is the midline. So this is the horizontal disc space that we have marked. When we are marking, we have to note the orientation of the needle also. This is more or less a flat spine, unlike the previous case where there was an exaggerated lordosis. So in these cases, the chance of entering into a adjacent level is less. Whereas if there is a hyperlordosis, so with the same incision, by just changing the trajectory, so if instead of going like this, if we just change the trajectory, it is very easy to go to the next level, adjacent level. So that is what precaution we need to take care. So in this particular case, I'm not very worried about going to the adjacent level. But in either case, we have to note in what angle we have inserted the needle. So our needle was almost straight banked down, perpendicular to the ground. So that is the angle in which we are going to insert our tube as well. So if our angle was more like this, I think that is the angle that we need to follow while inserting the first tube or doing sequential dilatation. Give me a gauze piece, dry gauze, smaller gauze, and give me a first knife. So again, we are using, just like in the last case, as Dr. Neeraj has beautifully demonstrated, we are using a 18 millimeter tube. So unlike going all the way, so usually what I do is I just palpate the spinous process, and I palpate the interspinous gap, the gap between the upper spinous process and the lower spinous process. That will give us a rough orientation of where the interlaminar area is going to be. Though the spinous process can be sometimes angulated inferiorly, in lumbar spine they are more horizontal, as we know. They are more coaxial to the disc. So I would just make a small facial incision with my knife itself on just lateral to the lower part of the upper spinous process. So I am palpating the lower spinous process, upper spinous process. This is the gap. Now I just come here and just lateral to the spinous process, I'll just make a vertical incision. And that much space is actually enough for inserting our first dilator. So instead of directly inserting the finger all the way down, we can use this dilator. This is not a sharp dilator, as you can see. So we can use this dilator in order to use, this is actually acts as our finger, and we can use this dilator to go down, identify the facial opening that we have made. And I have gone through the fascia, but I am not on the bone. So what I do, I just palpate the spinous process, the lower border of the spinous process. You see, and actually now this is the angle with which I am going more medially. So that is the spinous process angle. Can we just zoom out a little bit? Yeah, zoom out. So yeah. So you see, that is the angle towards the spinous process. So with the same angle, we go down till the spinolaminar junction. All right, I'm palpating that. And then we are making the tube or the dilator straight in order to palpate the lower border of the lamina. So with the same step, what we can do is we can actually separate the muscles and create that space that Dr. Neeraj was creating with his finger, create that space using the first dilator. So there are different techniques how you can create this space. Now some people directly dock it in and directly do the sequential dilatation. Of course, that is also a method. But by doing this, what we realize is that by creating that space, our subsequent dilators go in much more easily. And then, the amount of muscle creep that we get is significantly less. So unlike the keeping the first dilator on the lower edge of the lamina, so now I am able to palpate the lamina and the lower edge of the lamina. If you observe very closely, you see I am on the lamina. As I go down, you see there is a dip there. Can you make out? There is a small dip. Okay? So that small dip is the lower edge of the lamina. So I am not dipping it too much, not to enter the interlaminar space there. So just to identify the lower edge of lamina, and then we start our sequential dilatation. So again, with each dilatation, we need to palpate the bone, mediolateral up and down movements, as well as circular movements. So all range of movements have to be done. Give me a small dissector, regular dissector. So, and then while doing this sequential dilatation, we should also make sure that, you know, our skin is not getting crushed between the tube. Not this, the regular one. This is after the tube. So in this particular case, because the facet angle is so is sagittally oriented, and the interlaminar, the laminar width is very narrow, so we need to be very careful that we are as close to the spinous process as possible. If we go more laterally onto the facet joint, the chances of us removing extra bit of facet that is not required and causing an iatrogenic instability is higher.
So here there is a lot of bony canal stenosis. So whenever there is more of a ligamentum fluum, you need to do a less of bone drilling. Here, a lot of bone drilling is needed apart from taking out the ligamentum fluum.
Perfect. Okay.
So the retractor
So
stays on contralateral
down.
side, either lower or upper side. I use it on a higher side like arm side, and Dr. Umesh is keeping it out
The
leg
height
side on
can go down till there. So the flexarm assembly usually comes from the contralateral side. Some more. Let it go down. Yes. Bend. Keep it down. Yeah, keep it down. So you tighten this. So this has to be down, because otherwise the assistant, when he is standing, then this can get pushed. So that will come in the way. Fix it, please. Yeah. Okay. So I have done that. Now I am going to confirm my tube position with Shyam. Sister, can you please come and stand here? Okay. So I think the darker image in the Shyam is the one of the flexarm assembly. The lighter tube you can see behind.
So a Shyam image, please. Yeah. Yes, yeah, we can see.
Okay. Yeah. So as you can see, the lower edge of the tube is still at the upper end plate. But for an adequate decompression, we need to go all the way till the mid pedicle. So that is where the upper lamina or the upper edge of the ligamentum flavum will be there. The lower edge of the ligamentum flavum will be there. Upper part of the lower lamina. Shyam can go out, please. Yes. So this is the first quadrant that we are addressing, that is the ipsilateral and upper. Once this is done, we are going to angulate the tube more inferiorly, which at that time we are not going to take a Shyam, but you can imagine the tube position will be more angulated inferiorly in order to address the lower part of the lateral recess and the traversing route along its course. Shyam can go out, the table height to be reduced, please, and then microscope. Where is the microscope? Okay. So I think the microscope will take time to come in. So any questions are there until then?
Any questions among delegates? So we saw a patient selection. Yes. So we saw a patient selection of bilateral symptoms in a patient with 2-level lumbar canal stenosis, 50-year-old female, and the plan is microendoscopic tubular 2-level decompression.
Sir, my question is, here you are using tubular retractor. There are different type of retractors are available. Which is preferable? There are blades are available, 2-bladed, which can get kept separated, and retraction will be more. So whether this round one is preferable or the flange one?
So your expandable tubular retractor. So there are 3 types of tubular retractors. So these are fixed tubular retractors. The name fixed comes, it's not because it is fixed to the table, but because it's a fixed diameter. So these are fixed tubular retractors. The other ones are a semi-expandable, where the the entry at the skin remains the same, but they just open up in the deeper area. The third ones are expandable retractors, what you are mentioning. They are either 2-blade, 3-blade, 4-blade. Different companies have different systems. The blades can be opened up to increase the incision on the skin and increase the exposure at the skin level, as well as angulate them in order to increase the exposure at the level of the surgery. So it depends on the case. So usually whenever you are using an expandable tubular retractor, that means that you need more space. Whenever you are using an expandable tubular retractor when you need a bigger space. So expandable tubular retractors the basic starting diameter is 22 millimeters. And I feel for discectomies and decompression, 22 millimeter is just, it's more. So you might think that using a bigger tube gives you more space, but using a bigger tube just increases your overhang on the facet joint and it gives you an exposure that you actually do not require. You see, it's like a circle. The circle will not go beyond the spinous process, right? It won't go across the spinous process. So you have to limit, or you have to limit the medial border of your circle on the spinous process. So the smaller the circle, your overhang on the facet is bigger. If you use a bigger circle, you are just increasing your area laterally, which is actually not required for a discectomy and decompression. So the ideal size for a discectomy and decompression is actually around 16 to 18 millimeters. When you are starting off, using a bigger tube just increases your maneuverability, where you can use your instruments without the light or the vision coming being obstructed. But it doesn't increase your exposure at the level of surgery.
In an initial learning curve, you can use expandable retractor, so that if you feel you are stuck, you are not able to do much work in a smaller diameter, then you can use it. Like I began with X tube, which is expandable, then also quadrant, but now I do majority of degenerative work with this, and I use that expandable one only if intradural tumors and all.
So I use an expandable retractor only in cervical cases, not cervical decompression and laminoforaminotomy, but for using C1, C2 fusions or cervical pedicle screws, those kind of things. I use an expandable retractor when we do a thoracolumbar corpectomy, even for tumors and all those things, TLIF. I think we are using a fixed tubular retractor that is a 22 millimeter size.
That's the beauty of tubular MISS. You can begin with simple cases like a discectomy, but the Dr. Umesh does a lot of C1, C2 fixations through the tubes, tumors, corpectomies is excellent.
So the other advantage is when you use an expandable tubular retractor, your muscle creep actually increases, because the gap between the blade can allow for the muscles to creep in. And that is something that you can avoid with a fixed tubular retractor. Give me a suction, please. Suction on. So as you can see, that is the lamina. you can see the amount of laminar space that we have. So again, to orient, this is superior. Give me a marker pen, please. Marker pen, please. I'll just mark it.
We need to see how, okay, microscopic view.
So I'll just mark this one here. So this is superior. All right. So this angle is always superior. Can you see the mark? I'm not so sure.
No, I think, it's just the light.
No, it's okay. The inside vision will get obstructed. Otherwise, what I will do, I'll mark it on the skin.
Yeah, that is better. Mark on the skin.
Yeah, so that is superior. Is the vision clear? Is it clear? Suction is not worked on. So again, this is superior. So as you can see, that is the facet joint. That is the facet capsule as you are seeing. So that is the facet capsule there. Can you make out? So I'm not at going to the lower border of the lamina, but that is where the lower border of the lamina is. So we need to just create some small space, you see, for doing our laminotomy. Suction is blocked. So in significantly hypertrophied facet, can you give me a dissector until then? So in significantly hypertrophied facets, when you are not sure about where to start your drilling, in those cases, a good indicator will be to go to the pars. So there, so that is the pars. That is the lateral border of the pars. Can you make out? So that is where it is dipping down. So normally around 5 mm of pars we need to preserve. So this is a 4 mm suction. So I think the safer part to start your drilling will be there, and that is where we will go down. So usually I always use a drill for such kind of decompressions. Is the orientation clear? So as you can see, the amount of the first position of the tube is slightly higher than what we would use for a discectomy. For a discectomy, we would like to see the interlaminar space, but here we need to see the upper attachment of the ligamentum flavum. So I think usually it will be somewhere around here. Let us see that. So once we drill is the drill ready? Is there any question?
So you don't see inferior laminar line in LCS, right?
No, we are going to angulate the tube later on, and I'm going to see that later.
Okay.
So this is the first step. This is the first step. So usually we have to expose the upper part, and then usually we remove the ligamentum flavum from its upper attachment. And then once this ipsilateral, or here what we are going to see here, this is L34, what we are going to see here is just the lateral border of the dura. We may not visualize the traversing nerve root as yet. I mean, sometimes we may just see the origin, but then we have to angulate the tube down, and that is where our actual decompression will be, where we have to remove the upper part of the lower lamina along with the lower attachment of the ligamentum flavum, the medial lip of the superior articular process, especially if it is hypertrophied. In this case, it will be required. And then we will be able to visualize and decompress the traversing nerve root.
So if you guys can recall what we were speaking about, the tube docking which will reduce your problems, requires only one landmark, which is spinolaminar line, or also starting from spinolaminar junction, going all the way to the lateral border of inferior facet. That's the spinolaminar line, and that's the spinolaminar junction. So the center of the tube should actually be seeing the spinolaminar line. Now this is very important because few things that you'll be able to see is, that's the whole ligamentum flavum, interlaminar space. Your ligamentum flavum under the surface of lamina is all the way up to here. Your pars is here, and this is the facet and capsule which remains undisturbed, untouched here. And from the base of spinous process, spinolaminar line, you are able to see almost everything. You will do a laminotomy here, remove the ligamentum flavum, and be able to see the dural sac here. So if your tube docking comes here, after this process, the surgery is like any other open surgery. There is nothing more that you have to add to it. And the beauty of this tube is, on one hand, it's a fixed tube. On the other hand, it allows you maneuverability with bending up, down, further medial, further lateral. You want to do a fusion, you can do lateral. You want to do see a exiting nerve root, you can further do it superior lateral. You want to do foraminotomy, you can do inferior lateral. You want to do over the top, you can do inferior medial. So all these things, maneuverability of this tube allows you to make it a dynamic decompression device. So Umesh, how do you start? What is the first bite that you start with? Is it at the base of spinous process, or you start laterally here?
No, I usually start laterally. I usually start laterally at the junction of the facet and the lamina. And, usually I'm searching for the drill. It is still searching. So I'll show what I do. Of course, there are different techniques in which we can do it. We can start at the base of the spinous process, spinolaminar junction, and then we can start either at the lower border of the lamina, or usually what I do is I start right in the at the junction, like I'll
So I differ a little here. I would always start at the base of spinous process for two reasons. One, in a very severe canal stenosis where the dural sac is pushed dorsally, it gives me maximum space just under the base of spinous process, number one. Number two, when there are a lot of facetal arthritic osteophytes here in the lateral aspect, this is the most open space which will always remain open even in a collapsed disc space, a lot of osteophytosis. This space is always open, and the moment you bite your first bite here, you will be able to walk up, lateral, come down, and complete the circle like that.
Both are valid point. Like I first time heard Umesh doing this, but it's an interesting point because when you are using drill, inadvertently you may take out the facet or pars. So if you know that it's your lateral border, then it's easier to preserve the pars and facet.
What I will do is, I will actually soft dissect it with a McDonald, and you will actually see longitudinal fibers of the capsule. So the point where the first fiber of the capsule is seen, that becomes my lateral border of bony resection. You just do not touch the capsule. And if you draw a line from here upward, you will 100% of times save the pars also. So your capsule is saved, your pars is saved, and this first fiber. Umesh, can you, for the sake of delegates, show us the first fibers of the capsule here on the lateral aspect while your drill comes up? Umesh?
That's the one.
The capsule fibers.
Yeah, that is the capsule there.
Yes, yes. So now you exactly know your capsule fibers are starting. This is the only amount of bone you can remove. You can't go any further lateral because your pars is right there. So you have to preserve the capsule, you have to preserve the pars, and that's the amount of bone you can remove. That's the maximum amount of bone you can remove.
Umesh, we had searched for that 22 OHD.
No, I got it. Means it's okay. That's fine, not a problem. We are drill, it's not starting. That's why I'm waiting.
Okay.
So if there are any other issues, questions, we can sort it out by that time.
So Umesh, Neeraj here.
Hi, Neeraj.
When you are doing over-the-top decompression, any particular tips and points about positioning, because you will have to tilt your table, you will have to tilt your microscopes, No,
Yes, yes. So we are going to do that. We should always have a tiltable table. So because when we are angulating the tube to the contralateral side, our ergonomics will be better if we can tilt the table slightly to the contralateral side in order to make the tube more horizontal as compared to the angulation that we would have done. So this is what I was saying. So usually this is the point. So what I feel is in a lumbar canal stenosis, if you observe, so the lateral usually the dura and the nerve roots are all displaced more medially. So this is where put the suction, please. Can you hold the suction? One of you hold it. Yeah, you just it's not working. The tube is blocked. Suction tube. Change the suction. Yeah, that's okay. Just hold it there. Hold it deep inside. Yeah, just hold it inside. Here, you hold it in this corner here, where my drill is. Oh. Yes, please put the line. So put more saline, sir. You should put more saline.
So Umesh, one question, your choice of matched burrs, you would use diamond, you would use fluted, when, where, why?
Sorry, can you repeat that?
Your choice of burr, the matched burr, which you are using ball tip, right? You're not using matched.
No, this is a diamond burr.
Okay.
And I always use a diamond burr.
Okay.
So usually I use a 22 mm MH.
Okay.
So as you can see, this is the ligamentum flavum there. I have reached all the way to the deeper portion. And then with this same burr, I am going to create that laminotomy. Put more saline, please. You should gush it. Put more saline. Leave your hand. Put more saline, please. Yeah. No, can you keep the needle away and put? Yeah. So now you see that I have removed that part of the bone. Now, so that is the superior articular process there. So I'm going to drill that in the same place. So if you see there, if you observe closely, that is the ligamentum flavum. Can you visualize the ligamentum flavum? I'll just adjust the focus a bit.
Excuse me, GJ6 KP3158. That car need to be moved.
So in very severe hypertrophies, usually what I do is I don't go directly like this. I again, you start your drilling more medially and then come laterally. That will give you an exact idea of how much facet can be safely drilled. So you see, I think that is the upper edge. So I'll just remove this piece of bone. Can you hold it? Can you see the epidural fat there?
Yes, yeah.
So that is the upper edge of the ligamentum flavum. So now our ipsilateral hemilaminotomy is almost complete. Whether we need to undercut the superior articular process, we are going to assess later. Can you give me a dissector, please? Not this, dissector, a dissector. Okay. So that is the upper edge of the ligamentum flavum. And now we are just lifting the ligamentum flavum there, separating it from the dura as well as the lateral part, and then I'll just hold it up. Give me a 2 mm upcut. I'm just lifting and keeping the ligamentum there, then inserting the foot plate, turning it up in order to go all the way to the upper attachment, and then removing the ligament in the same way.
So you take out the ipsilateral ligamentum first?
Yes, always. Means
okay. That
is how I do. So ipsilateral ligamentum flavum I remove, because contralateral usually it is before I do the contralateral. Can you give a smaller section, please? So contralateral ligament, as I'll show, it's not really not going to come in the way.
So usually I do ipsilateral laminotomy, keep ligamentum flavum intact, go contralateral, decompress so that your dura won't be getting in a way.
So even I don't remove the ligamentum flavum all the way in the, try to remove it. I try to remove the ligamentum and just separate it as of now, and then actually remove it when we go to the lower quadrant. So now I have separated the ligamentum flavum both from the medial aspect as well as the lower aspect, lateral aspect. Dissector again, please. We can see the dura and the lateral border there. Dissector, please. So, can you see that is the lateral border of the dura?
Yes, we can see.
Okay, so now this is the part of the ligamentum flavum that usually is not going to be reached by a straight Kerrison sponge. So I will show that. You have the curved Kerrisons. Is it ready? So you see now, for me to angle like this and go remove that subarticular portion of the ligamentum flavum, only a small portion is coming, but I'll not be able to remove the entire subarticular portion of the ligamentum flavum without removing extra facet. And in this case, especially when there is a sagittally oriented facet, we don't want to remove the facets too much. So this is where the angled Kerrisons comes into play. Dissector again.
We'll get it next time when you come.
No, it's available here. I think we are just waiting for it to get autoclaved. So that is the disc. As you can see, the upper part of the disc there. So that is the lateral border of the dura. Now this ligament also I would like to remove, but to remove that we need that angled Kerrisons. Once it comes, we'll come back to this area and remove. You can see the epidural fat in the axilla of the exiting nerve root there.
Yes.
That is the epidural fat. So anyways, now what we will do is, oh, it's ready? Can you give it? 2. Okay. So this is 3.
Umesh, both are 3 only.
Oh, okay. Okay. I'll try to adjust. So usually when we are putting this, you need to be careful that we are not pushing the dura with it, or we are not compressing. The shoulder of this is not compressing the not able to turn. All right. Now we are angulating the tube down. No, it's okay. Release. Tube is release. Fix. Monopolar again. So can you see now the muzzle again? So that is the lower part, the muzzle over the interlaminar space. I think we'll need to remove a little bit of the muzzle from the interlaminar space. So that is still the facet, part of the facet joint there. I'm trying to palpate the upper edge of the lower lamina. This forceps? No, regular. The monopolar. Monopolar. So invariably when you do this, this is the point where your facet joint gets opened up. So I think I usually make it a point to coagulate that area, the capsule that is there where we have exposed it. Drill again, please. Dissector. Upcut.
So what are you drilling, Umesh? Like which
so
part?
This is just this is just the lateral, the lower part of the facet.
Oh, okay.
Right. I think I have to angulate a little more in order to reach the upper part of the lower lamina.
So this is ipsilateral side only, right?
This still.
Yeah.
We have not yet angulated the contralateral side. So if you can observe the amount of space that is available, so usually I call it like a D. So that is between the lateral border of the medial border of the drilled facet and the medial border, of the tube. So this is not fixed. No, release, please. Both. Fixed. Tube is fixed, huh? So I can palpate the upper border of the lower lamina over there. Give me mono. That is the upper border. So as you know, the lower part of the ligamentum flavum attaches in two separate slips. One is the superficial slips, which attaches to the posterior superior border of the upper part of the lower lamina, and that is the one that I am removing now. So the superficial slip of the ligamentum flavum, if you remove, and then take a dissector, give me a dissector. I'll try to separate it. Sometimes it gets easily separated and then only the deeper slip will be left behind. So if not, we can remove both of them together. Not getting separated easily. Give me monopolar again. Mono, please. So that is the, anyways, that is the upper part of the lower lamina. So what I will do now is take a drill again and drill that a little bit in order to free the lower attachment of the ligamentum flavum. By doing this drilling, we are also separating the attachment of the superficial slip and then freeing the inferior or the deeper slip of the ligamentum flavum, at the lower attachment of the ligamentum flavum. Give me dissect. Upcut again. So this is where usually you will observe that the ligamentum flavum is the thickest at the lower inferolateral portion, where it tries to compensate and support the facet joint. Dissector, give me a second. And stop. No, not. Give me the general. Give me this. Give me this section. It's okay. Give what you were giving earlier. No, same thing. Just clean it and. Fix. Fix.
So it's important to fix the tube properly in a direction you want.
Give me the upcut.
So that there won't be any blind spots and you may not injure inadvertently.
Yeah, I think in a decompression procedure, it's very important to adjust the tube according to where you want to see. So because as you can see here, you know, in an open surgery where your vision is from the midline, so it's easy to visualize these lateral structures or subarticular recess. But in a MIS procedure, your tube, especially on the ipsilateral side, is directly visualizing onto the facet joint. Now, if I can increase the visualization by drilling more of the facet joint, but especially in this case, because it's a sagittally oriented facet, if we try to do that, the chances of causing an iatrogenic instability are significantly higher. So we should try to avoid that. So now that is the upper edge of the ligamentum flavum that we had created. So ideally, I would have wanted to remove this from there, but because it is quite stenosed and I'm not able to get that correct plane there, what I'll do, I'll remove it here and then
That's very, very important point. In a severely stenosed case, if you try to put your instrument beneath post-operative paresthesia, neurological deficit like biter root syndrome would be higher. So come from the area where you get enough space.
I can drill a little more. If you see this, I have drilled till there, and this is protruding a little bit medially. So I'll just drill off that portion to make it completely vertically flat.
That's the beauty of live workshop. You see everyone having a different technique, the same things being done differently. Like what I do is I keep ligamentum flavum preserved on ipsilateral side, go on contralateral side. When the almost complete drilling is done, then only I open the ligamentum flavum.
You can see that is the thick ligamentum flavum over there.
Right.
So I think we need to remove that. So the other technique, usually I do this on the contralateral side, is I just separate the ligamentum flavum. I can show it when I'm doing it on the other side. When we separate it from the from its attachment in the subarticular portion, then actually it becomes easier to remove. So give me a right angle now. Give me the right angle probe that you had. Do you have a straight one? Then you can just give me an upcut. Give me upcut too. So you see the dura is bulging into the area that we have decompressed. So in such cases, we have to be careful not to pluck the dura, not to pick the dura in our when we are taking the punch, when we are taking the punch bites. You have to just wiggle it a little and then go in and then remove the ligamentum flavum.
That's very important technique. He is holding it, wiggling it, making sure that there is no dura and taking a bite. In a canal stenosis like this, severe stenosis, long-standing stenosis, the rates of dural tears are higher. You have to make sure there are no adhesions and before taking a bite.
So you see that is the means if you have freed the ligamentum flavum, in this case I have not freed it completely, but even if you have drilled a little bit of the upper part of the lower lamina, the lower edge of the ligamentum flavum comes off very easily. So you don't have to actually struggle. And like Dr. Rakesh was mentioning, to preserve the ligamentum flavum. So whenever there is some fat, you see there is a fat. So whenever there is an epidural fat that you encounter, it is always, again, safer to preserve that and go directly above the fat layer so that the chances of actually catching the dura is significantly less.
Right.
So you see the amount of lateral recess. We have actually not drilled the facet too much. So the facet joint line should be somewhere there. So we don't want to drill it. So as we know, in lumbar canal stenosis, the main problem is the subarticular stenosis. So we can actually preserve the superficial part of the facet and remove the inferior part, which we are going to do now using that curved Kerrison sponge. Release, please. So now what I was trying to do earlier, I'm going to do that again. Now I have got a space there. No, don't. While tightening, please don't change the tube. Yeah. Tighten, please. Don't. So now I'll come from above. Give me a dissector. So what you have to do now is you identify that. Give me a dissector. So you identify that lateral plane. See, that is the lateral border of the dura. Okay. That is the lateral border of the dura. Can you make out?
Yes. Yeah.
So I'm just trying to separate that so that if there is any attachment or any micro adhesions between the ligamentum flavum and the dura, that is taken care. And also by separating it widely, you are free to insert your curved Kerrison sponge into this space. Now where my dissector is going, I'll try to insert my curved Kerrison sponge. See that? That is the lateral edge, that is the dura.
Yeah.
Okay. So now I'll just hold it there. Give me the angled Kerrison. 2 mm. Okay.
Anytime you would do discectomy when you do a stenosis, or you avoid doing
most of the cases, no.
Okay. So where are the cases when you do a discectomy?
Only if there is an acute fragment.
Okay. Thank you. In patient with lumbar canal stenosis, doing bilateral decompression with when you add discectomy, chances of instability are higher, and most of the time that stenosis is the symptomatic. So if patient has claudication, mild disc protrusion, then avoid doing discectomy in addition to posterior decompression.
So a 2 mm upcut would have been ideal, because in such severe stenosis, usually again passing a So usually what I do, so usually you pass your upcut like this, and if it is a smaller upcut, you can actually turn. I'm trying to turn, it's not turning. So you can turn so that you trace your upper border of the lateral dura, and then you turn your upcut so that it goes to the lower border. And because you have already identified the lateral border of the dura and you have separated the lateral border of the dura from the underlying adhesions, so when you go like this in the lateral area and then you turn your upcut in the subarticular facet, you can sequentially come and remove all that subarticular portion. So actually it is kind of a blind procedure. So initially when we have done it, we have actually checked with an endoscope also to see if our decompression is adequate and all. And we find that we can actually remove the entire portion of release the tube there. So sometimes tube angulation also is important. See, now I have angulated the tube to the contralateral side slightly. So I'm just changing the orientation to be more, release some more, both.
Yeah, that's an interesting technique.
Yeah, release.
From going rostral to caudal and turning it.
Fix, please. So now I have made it, release both. No, one by one. Fix the lower one first. leave the upper one, fix the lower one first. Okay, and then fix the upper one. Yeah, see, then the tube doesn't move. Give me a dissector. So there are two options now. I'll just try once more to use that angled carescence to remove that portion of the ligament. That is very important. We have to remove this portion of the ligamentum flavum. So I'll use that angled carescence again. So if that is not feasible, I think I'll slightly risk drilling a little more.
Yeah, you can go little lateral. I think it's safer. Huh? You can go little lateral still.
Yes, yes. So, but I just wanted to preserve the entire facet if possible. So usually that is what nowadays we are doing. Most of our subarticular decompression takes place, and with this, unfortunately, not able to do it. Okay, give me the drill. So usually we can preserve the superficial part of the facet. Again, when we have removed the ligamentum flavum and you are using a drill, you have to be careful. An upcut straight too.
Any question, any feedback, any suggestions from audience? Anyone? Yes. Any experience with Misonix bone scalpel, Umesh? Dr. Dr. Zaveri is Dr. Deven Zaveri is a senior neurosurgeon from Ahmedabad. He is asking, any experience with Misonix?
No, I don't have it in my system. So I am very comfortable using the drill. So even in OPLLs or OLF, we are actually, I use
Misonix handle is very big. So passing through this 18mm tube is very difficult.
No, that cutting bar is scalpel is big one.
Right.
Cutting bar is small one. So you can use. We are using since last 6-7 years.
Through this 18mm tube, or you do larger tube?
Larger tube.
Yeah, so you need probably larger tube, because his handle is a bit bulky. Tip is little smaller, but handle is quite bulky. You won't be able to see it. So if you are using expandable retractors, or maybe 24, 26, 28, then probably you'll be able to use it. That Misonix bone scalpel is a beautiful angled burr which drill on a side. That's good for a lateral decompression.
By doing that extra bit of drilling, we have got some little extra space. So in MISC, for the sake of ease and convenience, we could have done this earlier itself. But it's always better to be more cautious rather than drill the facet and realize that it has caused some kind of a problem later on. Dissector again, please. That is the lateral border of dura. That's the origin of the nerve root there. Upcut.
Requesting all the delegates, if you are not registered, to register at the reception desk so that they would be preparing certificates. Thank you.
Okay. Release tube some more. So I've again changed the angle of the tube. I'm looking slightly more lateral now. As you see, I've decreased my area of dural visualization. But what I'm trying to achieve is to visualize more of the lateral recess. Dissector. You have some bands, rubber bands, tight, won't come like that. Give me a upcut. No, no, don't put the pin. Hmm? Good.
Hello, Rakesh bhai. Maulik here. So, I'm sorry if I have not listened the point, but what will be the difference if we have started this surgery from left side?
Umesh, there is a question. Why not you begin from left side? Like
The left side facet is more horizontal, more vertical or more sagittally oriented than the right one.
Yeah. So basically.
So that would in the in the left side, what difficulties we are facing now, I think it would have been more.
Yes, yes.
So we would have definitely, by drilling this much, I'm sure on the left side we would have entered the facet joint line.
Yeah, so that's an interesting point. When you are choosing side, you have to see one which is symptomatic side, second which side is less arthropathic. Like left side was more sagittally oriented. So if you go from left side, ipsilateral facet resection is more. So then your chances of ipsilateral facetal instability would be higher. So you go from less of arthropathic side. If there is one side facet synovial, you go from opposite side. Yes, Pratik. Yeah.
One more thing. How to choose ligamentum flavum should be removed from below upwards or upwards below?
So there are various techniques. So what I do is I identify spinolaminar line. I go from bottom to top, go till upper end of ligamentum flavum, dissect it, and again then ligamentum flavum should give it from rostral to caudal.
Give me that.
So dissect from lower down to up, but then ligamentum flavum should be cut from rostral to caudal. If you are cutting ligament from inferior to superiorly, it is difficult, and at times you don't see the orientation of root. The chances of getting root in a bite is higher if you go from inferior to superior. Yeah, Pratik, you were asking something.
Normally in open surgery, we used to decompress the foraminal or lateral recess or undercut facet from the opposite side. Like decompression from the opposite side and disc from the same side. Normally we'll do in open surgery. So is there any limitation in MIS if we are planning for both the level foraminal decompression or any undercutting of the facet from both the sides? So ipsilaterally it's very difficult to undercut the facet or any foraminal area.
You can do ipsilateral foraminal as well. So the tube has to be angled like if you are doing ipsilateral. Initially, you tube medially angulated, then laterally, then you can angulate even more. You can use table tiltation as well. So you can tilt the table ipsilaterally and see the foramen. And you can use this kind of banded instruments which can do a proper foraminotomy, preserving that bone. So basically with MIS also you achieve exactly the same decompression as you achieve in open. The purpose of MIST is to reduce approach related morbidity, but the decompression you achieve should be exactly the same as you achieve in an open surgery.
Yes, sir.
You can do ipsilateral traversing route, exiting route, contralateral exiting route, contralateral traversing route, all.
So can you see, I'm able to see the lateral border of the dura and the nerve root, and that is the ligamentum that we have to excise. And what happened? Give me that suction retractor that.
So ipsilateral thecal sac is very well decompressed, and ipsilateral traversing route is being decompressed here.
But this is not adequate. So what we have to do is we have to remove that portion of the ligamentum flavum that is there. See that one?
Yeah, right.
Give me the angled upcut now.
Hello.
Yes.
Sir, what about doing fixation and doing liberal facetectomy for wide release of nerve root? And
so with this, it's like you can say surgically, technically challenging, but you achieve the decompression, you avoid fusion. Just for the ease of surgery, you should not be resecting facet and doing a fusion. This is one of the difficult case. It's not for beginners. It's he's an excellent surgeon. We choose him difficult case for him. So it's a tight stenosis, more of a bony stenosis, sagittally oriented facets, and more chances of post-operative iatrogenic instability.
So again, as I was mentioning, I am trying to separate, you see, I am trying to separate the attachment of the ligamentum flavum.
For your academic purpose, if you have resected facet and if expecting post-operative instability, then you maybe do it at 3 months. But otherwise, not routinely. If patient has no post-operative back pain, you don't need to chase it.
Can you see that now? See, I have separated the ligamentum flavum from its under attachment. I've got a little bit more space. And now I'm trying to pull it off. Can you see that?
Yes, yes, yeah.
So now I'll just put the ligamentum flavum away and try to separate it from above the nerve root as well. That is the junction of the superior articular process and the upper part of the lower lamina, where the ligamentum flavum is there, where just underneath that will be the traversing nerve root. Trying to do that now. So as you can see, now I have separated this.
Yeah.
So if we had smaller curved carisons, removing this would have been easy, but I am facing slight difficulty because of the.
Yeah, I understand.
Yeah,
that's
so
the challenge
okay.
of being
so
in.
I might take some little extra time, but
no problem.
I think we should be able to do it.
Yes, yes.
So usually what I do, I just curve it like this, and it's very easily, it comes off. Not able to do that now. Yeah, I think I curved it.
And Sandeep, in a case of if pre-operative grade 1 listhesis, which is a stable listhesis, and you do a decompression, then probably yes, you would get a dynamic X-ray to watch further progression of instability.
As early as possible.
And maybe 3 months. Initially, there will be muscle spasm, and then you don't want to do that. So maybe 3 months is a good time.
And for only pure lateral stenosis, this approach will do, or
yeah, this approach will do.
Same docking of tubes.
Same. So MRI indication is usually facet effusion, arthropathic facet in association with clinical presentation of back dominant symptoms. So lax facet on MRI, you would see that T2 hyperintensity in a facet with a thick, like more than 2 millimeter or 3 millimeter sized facet cyst or facetal effusion. that suggests it's a wet facet and chances of post-operative instability are higher. In those cases, you may use.
Must understand here is that back pain in isolation is not an indication for surgery.
One more, right?
Even when there are radiological signs of instability present, if you do surgery for primary symptom of back pain, the success rate of your surgery is less than 50%. The success rate of surgery doubles up the moment the presenting symptoms or compounding symptoms are primarily neurological. So in a patient who has neurological symptoms, the surgery is primarily for neurological symptoms. Whether to add surgical fusion for associated back pain or not is a question. And fusion in that situation becomes important when there are both, not individual, both clinical and radiological features asking for fusion. But primarily doing fusion for clinical or radiological criteria for only back pain symptoms or only radiological findings with no neurological symptoms, the surgical results of such surgeries is less than 50% success. It doesn't mean that you will never succeed when you do surgery for back pain primarily, but the surgical rates are low if you extend your indications to surgical fusion or decompression done for back pain. That's point number one. So fusion is to be added in such case scenarios for very, very select group of patients. In my books, fusion in a patient with discectomy or lumbar canal stenosis comes only if clinical and radiological, both the criterias are present to justify fusion. So what are those criterias? A young patient, tall disc space, prominent associated back pain, not primary, prominent associated back pain apart from claudication, with severe facet arthritis, facet effusion.
Okay, guys, I think there was another angled upcut here. So I'm using that, and as you can see, now I am able to turn it inside like how I wanted to do it.
Yeah.
So as you see, now I'm going lateral to the disc space here. We know that that is a safe space. And now I'm turning it here, at the same time retracting the nerve root and the lateral border of the dura with my angled carescence itself. And now you see the ligamentum flavum there. I am able to catch that ligamentum flavum and remove it.
Yes. Now again, what Umesh is doing, we must acknowledge the fact that why is this struggle there is only for two reasons. One, we want to achieve optimum decompression. Number one, that means all the extent of lateral recess has to be decompressed. Number two, we have to save the pars and facet also. It is so easy for him to just sacrifice the pars and add fusion to it, and you will be able to do decompression. And so, on one hand, you have to achieve decompression like you want to. On the other hand, you have to save the pars, capsule and facet joint also. And both these principles to achieve, ipsilateral decompression is always difficult. Irrespective whether it is a broad facet, broad lamina or narrow facet, narrow lamina, ipsilateral decompression,
so that is only the portion that is left behind.
Is always time
now
consuming.
I'll angulate the tube a little down.
Which
I
is
think that
contrary to the
difference.
understanding. Because when you do open surgery, same side decompression is easy. Whereas in a tubular surgery, because your tube is angulated, you have started from paramedian pointing towards the median central part of the dural sac. Ipsilateral decompression, you must expect that you are going to take more time, you are going to have more bleeding, more struggle, maneuverability of the instruments is going to be a difficult part, and so ipsilateral decompression is difficult, and you will see that the contralateral decompression will take less than 5 minutes. However, ipsilateral side, because you have to save the facet, you have to save the dural sac, the retractability of the neural elements is very low, and that is why ipsilateral decompression may not only take effort, may take time, may make you more resourceful. You would want to use all these.
So can you see that, guys? So if I want to put this here, now I am not sure whether I am directly above the nerve root or whether I am, So but now we know that this is a safe area. See, it is so easily going. And now what I do, I usually turn this like this, and we know that we are safe. Exactly. And then you can actually remove that portion of the ligamentum flavum that is above the nerve root that is
very
attached.
Important. What is coming up is blind bites is a recipe of neural and dural tear. If you are not able to see something, do not complete your forward bite. only when you are really sure that you are able to
So you
see and
that is
feel,
the,
only
yeah.
then bite it out.
So why not to do contralateral from both the ends?
Sorry?
Oh,
Save
no,
time.
you will have to.
Want to do this side, you do from opposite side.
You'll have to put 2 incisions, 2 muscle dissections.
Yeah, but anyway it is MIS, right? So I mean.
Yeah, but if you can do it the same thing from one side, you might as well do it. What does it
But
take?
you'll save a lot of time, right? I mean.
10 minutes, 15 minutes extra.
Yeah. So if just putting a small incision from opposite side, you can do both the
You'll
things.
have more blood loss, you'll have double the incision on that
Yeah,
side.
other thing is, yeah, so opposite side lamina goes off, there are higher chances of fibrosis other side as well.
And it is not difficult. These difficulties you will face only when the facet is sagittal and there is a component of developmental canal stenosis. If you heard my first case slide, try not to choose a developmental narrow canal in first few cases. This case, if you see the MRI, maybe in the middle of somewhere we'll see the MRI, there is a developmental bony component with a sagittal facet. So it is one of the difficult and challenging cases with MIS technique. It is easy to do it from the opposite. And the easiest thing is just convert it to open and do it. Laminectomy kitna time lagta? Aadha ghanta.
So can you see that now we are on the lower part of the disc. That is the nerve root. Can you see this?
Yes. Yes.
So now only this is the portion of the ligamentum flavum that is left behind, and that is what we need to remove. So only this portion is there. Now again, before passing my upcut, what I am doing, I am passing this dissector and seeing that it is going freely. There are no adhesions between the ligamentum flavum and the lateral border or the superior part of the nerve root, superficial part of the nerve root, and that is why I can confidently put my angled upcut in the same way and then turn it so that I can catch this portion. So if you have the right instruments, it is as easy. Can you see that?
Yes.
This is the chunk of the ligamentum flavum that was above the nerve root. That is the attachment bit at the level of the junction of the upper part of the lamina and the superior articular process. So I'm again seeing there is still some more small, but my dissector is now going much more freely than what it was last time. Give me the upcut again, angled upcut. Again, I do that, catch this, and so you can see that is the ligamentum there. So basically the idea of doing decompression here is to remove the ligamentum flavum completely. Give me a second. Again, as Vishal was rightly mentioning, this time I was not sure it was in the right place, so I didn't take a bite. So again, we have to be very careful each and every time we take a bite that our upcut is in the right place. See, that is the only portion of the flavum that is now left behind that we have to remove. Give me the upcut. Again, coming from above, retracting the dura, turning the
So Umesh, how much medial edge of the facet you remove? Always up to the pedicle, or just enough to make the root free?
In this case, I wouldn't remove it up to the pedicle. So you always assess the preoperative MRI and see if I was doing the same decompression at L4-5 in the same case. So definitely we would have removed it up to the level of the pedicle, because there the facets are more coronally oriented. We don't risk the chance of instability. Here you can see we have not even removed the facet. Despite that extra drilling that I did, we have not even removed the facet till the lateral border of the dura. The lateral border of the dura, I have to visualize, I have to retract this. See, that is the lateral border of the dura.
Correct.
So we are now absolutely safe that, we are confident that we have not removed the facet to an extent that it is going to cause, any kind of iatrogenic instability. So usually we can assess that on a
Specifically, it is all the more important when you have a vertical facet that you don't try to go too much lateral, otherwise you may actually break the facet.
Okay. So I think we have removed the ligamentum flavum. Now you can see the nerve root there.
Yes.
So that is a small portion of the ligamentum flavum that is still there. I would like to remove that. Just a couple more bites and then probably we are done on the ipsilateral. Dissector. So now you can see now my dissector is going very freely. I can see some amount of fat. I'm not sure. Can you see that?
Yes, yes.
Some amount of fat on the lateral part as well. There is a small strand there. I don't think that is going to make any difference. Of course, if I had a smaller upcut, I would have removed that. I think now this decompression is complete ipsilaterally.
So any questions from the audience? So
you agree? So shall we move to the other side? Okay.
Yes.
Okay. So
No
now
questions?
I'm angulating the tube. Please tilt the table to the other side. Tilt it to that side.
Another word of caution while tilting the tube, when you are trying to tilt, don't push your spinous process too much. Otherwise, if you try to push spinous process may break. So you lose the advantage of having over the top decompression. You want to bend it over the facet. Don't push it medially. Just try to tilt.
Give me the regular section. And so now you can see the base of the spinous process over there.
Yes.
And let us see how this treats us. And you can see the residual ligamentum flavum. So that is the ipsilateral decompression that we have done. Monopolar first. I'll just create this gap there. You know that the upper border of the ligamentum flavum is there, so we don't need to drill more than that. And then, so that is the angle we need to create. So I am already separating the interlaminar space, the ligamentum flavum. Can you see that? The ligamentum space flavum over the interlaminar space. This can be done with a monopolar. So here I can, we have a couple of techniques that we can use. So usually, first thing that we do is drill a part of the base of the spinous process and any residual ipsilateral lamina in order to gain access to the gap between the contralateral internal lamina and the ligamentum flavum. Okay?
So I guess, it must have already been discussed, but, the only difference which I do is I do all the bony works before I start flavectomy because I'm a little scared using burr when dura is open, but I have seen I have always seen you using it very safe, but just for...
Dr. Neeraj, I would be happy if I can change your opinion. So you see the dura is there.
Yeah.
That is the ligamentum. So what I do is you go there. So that is the ligamentum flavum, that is the drill. So you can actually, you're not risking the dura at all.
No, absolutely. I think sometimes while even after doing a bony decompression, sometimes you cannot take a bite with your Carison when you're doing over the top, and you might have to use burr. But major bone work I prefer to do before I have done a flavectomy.
Yeah, yeah. No, that's also a good technique, more safer. So as you can see now, using this drill, I can go all the way, keep going down. So I'll just change the focus. So I think, you see how much deeper we have gone there? And then now, see, the other technique, if there was no bony stenosis, give me a dissector. If there is no bony stenosis, what we can do is, you see, you can easily separate the ligamentum.
Can you see that?
So I guess somebody was asking that, why not to put incision on the opposite side? Now, if you see, there is very only lateral aspect of ligament which is remaining once you have done ipsilateral decompression. So just to remove lateral portion or a lateral recess foraminal part, sometimes, you change your position, you put new incision, go through muscles. That probably takes extra time. Now, this might take another 10, 15, 20 minutes and 10, 15, it's over.
Are you guys seeing that? So we can easily separate
Yes, you may.
the contralateral ligamentum flavum from its attachment to the inner lamina. See, I've gone all the way there. It is quite deeper down, means all the way till the lateral attachment of the ligamentum flavum. Can you see?
Yes.
So if there is no bony stenosis, I think this step is all that is required. But now in this case, there is some amount of bony stenosis. I would like to drill that part as well. Can you take the dissector?
So those who are not doing this, sometimes it looks very scary when you are trying to put instrument on the opposite side. But believe me, as Umesh just showed, it is going at an oblique angle to the dura. So it's very little chance that if you do it properly under vision that you may damage dura. It's much safer than in fact doing in a lateral recess on a ipsilateral side.
Okay. So now, just like ipsilateral upper quadrant, now we are doing the contralateral upper quadrant. The contralateral nerve root is still lower down. We still have to go there. So as you can see, that is the dissector, please. That is the upper edge of the ligamentum flavum. Can you make out?
Yes, Umesh.
So that is the upper edge of the ligamentum flavum. And I have just separated there. Now the entire ligamentum flavum is getting lifted. Can you see that?
Yes, very well so.
Now only that will be left behind is that lateral flange over there, and that will be the upper foramen. Give me an upcut, 2 straight, 2 straight, straight. Okay. So now what you can do, you can easily go there and remove only that lateral flange of the ligamentum flavum. You see how easy it is now to go to the contralateral side under the facet. Now you can easily remove that ligamentum flavum all the way to its lateral border. Are you able to see that?
Yes, Umesh.
Now we can see the disc space.
Yes, it's visible.
You can see the disc space over there, and we are way beyond the lateral border of the dura on the other side. See, the lateral border of the dura is there. The lateral border of the dura is there, and we are way beyond that. So doing a contralateral decompression, especially in this case, is significantly easier than doing an ipsilateral one. So, and you see how, till where we have separated the ligamentum flavum attachment. Can you see we have separated it all the way to the contralateral lateral border. Now we just need to trace this sorry. Suction, please. So you see that is the contralateral disc.
Yes, very nicely seen.
Yeah. So in case if you have an acute fragment, especially, we have cases where we have removed a contralateral foraminal disc from this side.
And if you see the ligament which he has not removed, it's still protecting the dura while instrumenting.
So I'll tell you why.
Ligament is working as a cover to prevent dural injury.
So there are advantages, there are disadvantages, especially, of course, naturally it preserves and protects the dura, prevents any kind of a inadvertent dural injury. But what can happen, what you should be careful, give me a dissector. What you should be careful about is when you put too much pressure like this, it can put pressure on the dura. So that is what you need to be careful. So now we have removed the upper fragment, upper quadrant on the contralateral side.
So that is why surgeon always uses the suction and try to compress so that, surgeon can know that what amount of pressure is putting Sometimes assistant, when he's on the
You mean
other side,
monopolar?
he leans on a table. Sometimes, body forces pulls the dura on the other side. So, and it's very important to use suction in your other end while doing tubular decompression, so that you exactly know how much pressure you are putting, and intermittently you have to release that pressure from the dura.
So now you see there, over there, that is the upper border of the lower lamina there. So what I am doing now, I'm just going, we know that the dura is there, that is the angle there. So all that from there to there is the ligamentum flavum. So what I am doing is I'm just going there till I touch bone. Again, here there is no risk of causing any kind of dural injury with our monopolar, because that is the angle in which we are going. Can you see that? So that is the lower part of the facet. That is the superior articular process, still a little bit deeper, but that is the lower part of the facet. That is the upper border of the lower lamina, and that is where the traversing, contralateral traversing nerve root will be there. Dissector, please. Sorry, use the drill. Excuse me. So now I am just using the ligamentum flavum as a protection. I am just removing the medial lip of the contralateral superior articular process. Okay, so see that I have removed. Now I am just drilling the upper part of the lower lamina. Okay, take this, give me an upcut now, 2. Dissector first. So I'll just make sure before putting an upcut that there are no adhesions there. So now we have to remove that, this portion of the ligamentum flavum, right?
Yes.
Upcut.
Any questions from the audience so far?
So now I am able to catch that. You see, the entire ligament can actually come out in a few pieces.
Umesh, there is a question, will you be addressing the exiting nerve root here?
Sorry?
Will you be addressing the exiting nerve root for this patient?
That depends on the case that we are dealing. If we are doing a decompression in a collapsed disc space with contralateral foraminal stenosis, then yes, depending on the patient's symptoms. If the patient complains of symptoms pertaining to the L3 nerve root in this particular case, then yes, we can do it. But I don't think in this case the disc height is relatively maintained. There is no disc space collapse, and there is no foraminal stenosis per se. So it is predominantly a lateral recess, or even the foramen means entry zone foramen, which can be easily addressed by just a proper ligamentum flavectomy and medial facetectomy.
Other thing which you can do is you can put your ball tip probe
Does
in
that
the
answer the
exiting
question?
canal just to do the indirect way of checking whether you have the root patency is there or not.
So that is why in the presence of foraminal stenosis, our choice of surgery should always be very careful. So usually in the presence of unilateral foraminal stenosis, entry zone foraminal stenosis, so we don't need to actually jack up the disc space. If there is a collapsed disc space and there is a bilateral foraminal stenosis, especially in the mid foraminal zone, then usually those kind of cases require invariably a fusion, restoration of the disc height in order to effectively decompress the foraminal area.
So this is the lateral recess which you are decompressing, right? It's quite tight.
I'm sorry?
The lateral recess what you are decompressing.
Yes. So that is the lateral recess, as I was mentioning. I'm just
I am just removing the ligamentum flavum from the contralateral lateral recess.
So when you have a foraminal stenosis, as Umesh was saying, sometimes you would want to take a bite around the SAP, superior articular process, just to decompress foramen. Those cases you would want to tilt the tube slightly superior and look at the foramen. In fact, you know, extraforaminal disc herniation also can be approached from opposite side. Umesh, you know, one question from my side, you know, I think it would be good for audience if you know, enumerate them. What are the cases where the pathology is on unilateral pathology, but you would want to come from the opposite side?
Unilateral pathology from the opposite side, there are several indications. I think we were discussing that. The
okay, so I was not there maybe.
The configuration of the facet joints, if the facet is too medial, if there is no space in the between the facet and the between the facet and the spinous process, so then probably coming from the contralateral side is useful. Sometimes some patients do have spinous process deviation. When there is a spinous process deviation, that will restrict positioning your tube from an ipsilateral area. In those cases, you may have to come from a contralateral side. Foraminal pathologies, if there is a foraminal pathology or an extraforaminal disc prolapse, in those cases also you need to approach it from the, it is easier to approach it from the contralateral side than from the ipsilateral area.
Umesh, question from audience, what is the docking point for extraforaminal if you are going on the opposite side?
You see, this was the ligamentum flavum. We tried to remove so much from the ipsilateral side.
Yeah.
This was there. That is the junction of the lamina and the superior articular process, and directly above the traversing nerve root. So it's so easy to address this from the contralateral side. Now dissect, please.
So as you can see, our difference in docking.
Contralateral decompression is
you just have to tilt the tube
almost
so
complete.
And
you see the contralateral traversing nerve root there. My dissector is going freely. Give me an upcut 2 mm, please.
You just have to trace the disc.
Take this.
Umesh, in my surgeries, I have always found it difficult to take a bite at inferior lamina, the superior border of inferior lamina.
Yeah. So what I do is I angulate like this. It's if you go like this, it will be slightly difficult. So I angulate like this, go all the way, and then take. So usually, it's like in the axis of the lamina.
Correct. So it's a V shape most of the time. So first decompress the central portion so that you can angulate horizontal and try to decompress it. Is that right?
I'm sorry, I couldn't hear that.
No, I mean, say you go from midline to lateral so that you can do a horizontal angle of your cutoff.
Yes. And most often I actually use a drill.
Okay.
Not rather than trying to use with an upcut. So I'll just focus it. So is it clear now?
Yes.
So you see that is the contralateral pedicle, what I am palpating there.
Yeah, correct.
That is the contralateral pedicle. You see my dissector is going in there, but here it is not going beyond. So that is the contralateral pedicle. Can you see that?
Yes, we can see the bone.
Yeah. So and that is the almost the lower part of the pedicle. So we have done a good decompression on the contralateral side.
So would you be
removing
the SAP which is visible at?
Sorry.
Would you be removing the SAP there?
I have removed it partially.
Okay.
I have already, the SAP was below. This is SAP. The joint line is there.
No, the protruded part of tip of SAP.
This is. No, here?
Yeah, correct.
No, that again depends on whether we are trying to address the foraminal pathology and patient has L3 symptoms.
Okay.
So again, to remove the tip of the SAP, we need to go more superior.
And if it is possible, delegates want to that how you can see the disc in extraforaminal. If you can trace your disc space, just so that you know.
Give me a dissector again. give a regular section. Give me upcut. Give me bipolar. Bipolar. Oh, bipolar. How much is it? Huh? Reduce it to 10. Oh, no. You have any other? Give me a patty. Okay. No, it's okay. This one. No, don't pull this.
Another important instrument is upward facing bipolars for this kind of.
So I think, guys, is it clear? Now we are in the last quadrant.
Yes.
This is the lower end of the disc space. This is, as you can see that is the lower end of the disc space.
Yes, correct.
Can you see that?
Yes.
Is there an acute fragment? Give me a right angle probe. Release this. Take. Dissector. Like this. Give me right angle. Yes. Seems to be a small
acute fragment.
Give me another one, triangled. No, not this. Give me some. Release. Take. Dissector. Looks like an acute fragment. Can you see it?
Yes, yes.
Give me drill. usually whenever I've removed the ligamentum flavum and then it still needs drilling, you can use the suction there. See, I'm using the suction to keep it below, and then I will move the suction and the drill together.
Okay.
So that, it's always, the suction will keep moving the dura. Give me an upcut. Patient has L3 symptom. Looks like it's going into the foramen. Huh?
Foramen appears closed, actually. Foramen appears closed.
Yes. Sector again. Now I think we have a little more space to see what that fragment is. Yeah.
Chronic fragment or acute one?
Now this looks like an acute here. What do you say? Huh? This looks like an acute.
Yeah, that like a
Huh?
loose, yeah, looks like a loose fragment.
Yeah. Give me right angle again. Have another one. Dissector first. Give me a knife. Knife. Give me a disc forceps. You have a small disc forceps? Yeah, give the black one. This is bent. Give the black. This small micro disc. Small. Yeah? Cervical system. This.
Almost removing the foraminal disc now. So if you just use an angled disc forceps, you can remove the extraforaminal portion also very easily from the same approach. Like is plate has come out or what?
Dissector. So we have to be really careful on the contralateral side, because you're never too sure how much pressure you're putting on the dura so because our angle is like this, so we are relatively safe, but again while retracting this, so if I can, now this is the lateral border of the dura. So what I will do is I'll just incise this portion. I'll just incise this. Okay, knife. Knife. Long handle.
So Umesh, what happens if you inadvertently injure dura on the opposite side, lateral border? Would you repair it or would you leave it on the opposite side? And if so, how would you repair from opposite side, lateral border?
No, if it is on the really laterally, means it's on the deeper side. Obviously, you can't do anything there. Means you can't repair it primarily. So usually in those cases, I just use a dural substitute and probably use some kind of a glue.
Okay.
But even if it is even like, I'll show you dissector, please. Dissector. Yeah. So like, just to show an example, if I have a dural tear there, over there, obviously I will not put a stitch, I'll just use this. But until this area, and this is also on the contralateral side, until
Correct.
this area, I think we can take a stitch.
Still it is in the posterior part of the dura, you can remove it. The moment it goes anterolateral or lateral, you tend to use glues and other substitute.
Despite a good quality MRI, at times you can find this kind of surprises, and contralateral discectomy also can be done from opposite side.
Absolutely.
Not as a plan, but in case when you find intraoperatively.
So you have to be continuously on a lookout of.
Like this.
Umesh, that is almost you are into the foramen, right?
Yes, yes. I'm going through the foramen. just trying to create some space inside the disc space. Yeah, I think all these are.
So, Umesh, don't you think those are degenerated stable fragments? Do you always need to remove all of them, or you can leave behind? Someone may argue. What's your take on that?
I'm sorry?
It looks like degenerated stable fragments, you know, they are, so could be chronic also. So would you? Would you
Hi, Dr. Vishal here, Neeraj.
Yes, Vishal.
So I think this is the advantage of going contralateral as well, because you can actually see the disc bang in the foraminal zone under the pars, which would have been impossible to see unless you severed the pars on ipsilateral side, if you were going from that side. So I think this contralateral tube banding, seeing the foramen on the opposite side is possible only with this help of tube going from the opposite side.
So that draws an important point that, you know, you need to be clinically very vigilant, because, you know, same thing can be, you can say, counterproductive on ipsilateral side. Because, you know, if this accidental disc would have been an ipsilateral side into foramen, you may have missed it. So clinical examination and the symptomatology is most important before deciding any plan.
Also, sometimes if primarily this was a case of discectomy, which was like a foraminal disc, I think in that situation also primarily from contralateral side would have been far more productive.
Yes, makes sense.
Instead of going ipsilateral.
Specifically in this kind of patients where there are, you know, facets are, I mean, so the lamina is very narrow and the spinofacet junction is almost non-existent. If you go from opposite side, it makes your life much easier. So my question was, you know, I mean, this looks like the fragments looks like quite degenerated and stable fragments. Would you be willing to remove every time, or you can just leave it? You know, what's your take on that?
I think in the beginning, if it was an intact annulus, we wouldn't have obviously removed it.
I think I would have removed as well.
Yeah, so this looked like an acute fragment. In the sense, I think
But surprisingly, even on retrospectively looking at MRI, I'm not seeing that.
Yeah, even I didn't expect that, but here it looked.
That's the beauty of McNabb's hidden zone.
Give me a disc. Take a bipolar. Even now I feel there is an.
Looks like more medial fragment which is extending rather than laterally.
Give me bipolar. Give me a Pedicle. Yes. Align test. On.
So that's a good idea of keeping a patty over the dura and then coagulating. That's safer.
Yeah, obviously, because otherwise you won't be able to coagulate this safe. On.
These are fine tips which you can be used in any kind of surgery. Like even if you are doing open, that technique would be of help.
Off. Give me an upcut. I think that is where we saw that fragment.
So that is another difficult area where you can get a proper angle. You sometimes struggle to get a proper angle to remove.
Okay. I think Dissector. Now, even now I feel, see that? Vipala? Coagulate that a little bit more. On. So usually, if you have seen the disc on the contralateral side, because you are approaching at a tangent, you are almost seeing it flat. It's actually you have to retract quite a bit in order to see the contralateral disc. And when it is becoming so apparent in these cases, so see it's all the way till there. On, off, on, Yes. So that is, we have seen the nerve root all the way till the mid part of the pedicle. And then when we were coming back, we saw this. So I'll just coagulate it nicely so that we don't leave behind any acute fragments or any potentially acute fragment that can prolapse in the short period. On. Okay. Give me a release. Fix. So we'll just see the nerve root again. So that is the dissector. So that is the nerve root.
Yes.
So again, that is the lateral border. We can see the epidural fat. That is the pedicle there. You can see the bone.
Yes.
That is the pedicle. So we have decompressed all the way. So I think that should be enough. So what do you say, Dr. Rakesh? Is it okay?
Yeah.
Yeah. So again, that release. Yeah. Fix it.
Excellent job done.
Yeah. So again, sorry I took a long time, but the ipsilateral one was the one that was.
It's a really commendable job doing this in a not in your own hospital setup with different kind of instrument set, not your choice of instruments, not your choice of drill bit. Doing an excellent job. Appreciate.
Thank you so much.
You can see. So at the end, you have to confirm. Again, this is ipsilateral side.
Yes.
Decompressed well. You can see that lateral recess and the traversing root there.
I have not angulated the tube completely back. But still we are seeing the lateral border of the dura, nerve root. So, and then it's important that we see the superior part, the superficial part here, over here, because you see these are dynamic symptoms. So when the patient stands and the disc bulges, it is against that junction of the superior articular process and the upper border of the lamina. That is where the traversing nerve root usually gets compressed. So even if you have, that is why even if you are left behind a bulging disc in a lumbar canal stenosis, a hydrated bulging disc, and which has a propensity to bulge more when the patient stands. So if you have removed this portion of the junction of the superior articular process and the upper border of the lamina, it won't get compressed. So that is why you always check for this and here, as well as on the contralateral side and there.
That is why I think position also make a lot of difference.
Yes,
if you keep in a proper lordosis, that more or less resembles the standing position. So sometimes obliterating lordosis may be initially easier, but it's better to have a proper lordosis so that you can decompress in a position which is mimicking your standing posture.
So the principle, it's important that you clear out all the zones, ipsilateral superior, inferior, contralateral superior and inferior. So that would help you to prevent partial decompression, especially in early practice.
Hello.
So So if you just rewind a little bit, you can observe that we have removed the ligamentum flavum completely. So we first saw the upper border of the ipsilateral side, the upper attachment. We made the free attachment of the ligamentum flavum, lifted it, went laterally, identified the dural lateral border. We removed the lateral flange of the ligamentum flavum. That is the one that took long time. And then we went inferiorly. We traced the lower attachment of the ligamentum flavum. We removed that. We drilled part of the upper part of the lower lamina. We made the lower ligament free, and then we removed it, and then came laterally above the nerve root. We removed that part of the ligamentum flavum. So that part of the ligamentum flavum that was attached to the medial border of the superior articular process, the ipsilateral side, we removed it with an curved upcut by coming from superior to inferior. And then we went to the opposite side, contralateral side, the same thing. We identified the superior free edge. We dissected all the way to the lateral aspect of the ligament, and then we went inferior all the way almost till the mid border of the pedicle. We have seen, and we have removed the ligamentum flavum. So I think that is the main thing that we need to take care. Medial border of the superior articular process, the medial facetectomy, as well as removing the ligamentum flavum completely. So most of the cases, if we had not seen the disc fragment, we wouldn't do a discectomy even if there is a bulging disc, even if the disc is hydrated. Usually, even if you do a post-operative MRI after doing a thorough discectomy, it almost looks the same if you observe in some cases. So doing a discectomy is not really required unless there is a acute fragment, and that is what I usually follow. So thank you guys, and thank you for your patience.
Thank you, Umesh. Excellent job. Only disappointment is you did not damage dura, so that we can learn your suturing technique.
Dr. Neeraj, I know that you are praying for the dura.
I still would insist, Rakesh, that if you have time, you should show your video, that dural repair video.
Yeah. So.
Dr. Umesh.
Sorry,
yeah,
I didn't hear the last one.
The question.
One question. I'm Dr. Nimesh. I wanted to know, in a given day, if it's a severe stenosis with already pre-MRI showing literally a narrow canal, you might be anyway thinking that it is a difficult case. Intra-op also you feel in that way. At any point of time you decide to bail out, like which is that particular time you decide? At what point you decide to bail out from MIS?
Sir, so far I have not bailed out of any case. Obviously, the most important thing that is going to help you is having the right instruments. And if there is a difficulty, we should anticipate it pre-operatively. But so far, I think in a case of lumbar canal stenosis or even TLIF, for example, for that matter, I have never converted into an open. Of course, there are some cases where there is a grade 4 listhesis where initially itself we choose not to do an MIS, where we would directly do an open surgery.
Yeah, but that's a different one. Yeah, but after going inside.
So no, only one case of tumor I have converted, but for a lumbar canal stenosis, so far I have not changed. But potential complications, like even in this particular case also, potentially if the second upcut was not available, the upcut that I got, the curved upcut, it would have been really difficult to remove that lateral flange of the ligamentum flavum that is above the nerve root in the lateral recess. And that is something that, naturally the patient wouldn't have, probably would have continued to have symptoms if we don't remove that. So maybe, yes, if the instrument was not available, maybe you can think about, doing something extra for this patient rather than continuing with the same tube.
Okay.
Yes.
Sure. Thank you.
So maybe essentially it is the same
So
thing.
as
You
you
just
see,
try
now
to
the
put more
muscles-
longer incision, use a wider tube. That gives a better access. So it is all
So you
about
see the
access.
dilatation, this one. So once we are coming back, all the muscles are going to fall in its place. So any other questions? Thank you so much. I really thank anesthesia team, sister, brother, and my dear assistant. Okay, thank you everyone. Thank you for your patience.
So one
Thank you
thing
for-
I always do whenever I am doing tubular discectomy, I burned my hand once, long back. We never used to have a backup fixation. And doing one of my MIS decompression, I inadvertently broken the facet. So I had to literally wait for 1.5 or 2 hours till the implant and everything come and convert it. So two things I always do whenever I am doing over the top or any decompression: keep patient informed. I'm going to do this. There are chances that patient facet may get damaged, and I may have to convert into fixation. So there are 2 to 3 things which we need to. Sometimes that is a catch-22 situation kind of a thing. So if you don't have a backup, you have to wait. If you have instrumentation and you have not informed your patient, that is also legally also, because you are doing an extra procedure. So you need to take a prior consent for that. That if that happens, I'll do this, and you should be very clear if you are doing open or if you are doing MIS TLIF. So one thing I always 1% chance, but I had burned my hand at that time. At the middle of the surgery, I had to go out, tell the patient that this has happened. We are waiting for screw, and naturally, nobody likes those kind of situations. So that has happened around 5.5, 6 years back. Since then, I always keep a backup. I always keep my patient informed that if at all this happens. But fortunately, after that, it has not happened. But once I have burned my with that.
How much of facets will you keep as a threshold?
So
for
that
fixation?
all depends on, again, pre-operative MRI, and I in fact do a CT scan for my decompressions also. So more or less, I pre-operatively know how much facet I can remove. Generally, it is said that 1/3 of the facet is fine. Sometimes it is slightly more, because then it is very difficult to determine and define how much is 1/3. So I try not to go beyond medial ledge of the facet, the pedicle, medial border of the inferior pedicle. So I never try to go more lateral than that. Generally, that has been safe with. And then you can use undercuts to remove other things, rather than going more lateral. But one thing, that I have experienced, that keep always a fixation set ready. Otherwise, you will have to leave it in, your patient will come back soon.
Any incidents of parts fractures or anything?
Not so far. I had one spinous process fracture in an osteoporotic patient. Despite exercising all the precautions, a spinous process got fractured. I leave it as such. There's nothing much to do. And 3 months down the line, I got a CT scan of that patient. Spinous process was fused out automatically. But pars fracture has not.
Third case.
So I guess we are not having lunch break here. Whenever lunch is ready, anybody can patch up it and can continue. So we are not going to have a official lunch break, that I was told by Dr. Rakesh. So you can take up plate and can come down. Please.
77-year-old male, low back pain since 10 months, bilateral low limb radiculopathy, tingling numbness since 6 months, unable to stand more than 5 minutes and walk more than 100 meters, back pain more than leg pain. On examination, bilateral posterior superior iliac spine tenderness present, lumbar range of movement restricted and painful, right foot weakness, EHL EDL grade 4, right IL5 hypoesthesia, dynamic X-ray show, L4-5 listhesis grade 1. Cut off.
So any comments based on MRI and X-ray? 2 things most important, when I see this patient, I'll keep in mind. One is patient, as he said, is having more back pain. So somewhere, we have to prepare the patient that, these are probably poor patients they may have back pain post-operatively and they keep nagging at your neck. So that is one thing. Second, if you go back to X-ray, I think there is some vacuum at L5S1. So that segment is also, you need to keep in mind, because S1 is also degenerated with a vacuum. So anybody from the OT, Rakesh, Vishal, can you hear us? Umesh? So anybody from here, you know, how would you plan this surgery? You know, single level, double level, triple level? Hello.
Neeraj?
Yes, Vishal.
Hi, Neeraj. Vishal here.
I need your you know, wisdom and expertise here. You know, we all are confused and we don't know what to do now.
Don't worry, I am here from Bombay
Yeah,
all the way.
I knew, you know,
only
that.
to relieve your confusion.
No, that is why Rakesh has paid for your ticket.
Yes,
So please.
and what I am going to do is take away your confusion and do a surgery called fusion.
And take me to Bombay also.
Yes, and you know, in July and August, I am having 2 posts of fellowship opening also. You can join me.
Okay, how much you gonna pay me?
Don't worry, I'll take care of that. Okay. So guys, welcome to Venus Superspeciality Hospital. I am joining here with my senior colleague, Dr. Luhana, who is giving me a hand for this difficult case. And he's made sure that the most senior assistant remains with the most junior surgeon. You know, so I'm very happy that I already have good assistants here in my hand. And I'm also joined by a very capable anesthesia team. Dr. Ami Patel and team is here. We have the staff here. We have the Globus team, the audiovisual team, and the staff of Venus Hospital. We are going to deal with a 77-year-old male. Can we have the zoom in, please? I'm sure you've gone through the case as presented there in the hall. Can we zoom in here? 77-year-old gentleman with worsening claudication, left more than right, walking distance of less than 5 minutes, abilities of daily living are affected, functionality and disability is on the south side, he is not able to walk more than 5 minutes. On evaluation, a AP, lateral and dynamic X-ray were done, which show to be a dynamic instability at 4-5, a collapsed and stable disc at L5-S1 with some vacuum sign but no obvious translatory displacement at 5-S1, severe facet arthritis left more than right at L4-5 and right more than left at L5-S1. A MRI shows degenerative disc disease at multiple levels. Can we have it here? With a unstable degenerative spondylolisthesis at 4-5, mild lateral recess stenosis at 2-3, mild to moderate at 3-4 and 5-S1. At L4-5, we are able to see a listhesis which is dynamic on X-rays and a small disc fragment which is inferiorly migrated here. I hope you can appreciate that.
Yes, very well so.
On axial scans, can we move the microscope please? On axial scans, it shows a very severe.
The scan is not visible, Vishal.
Yeah, it's just coming up. L4-5, severe
Yes.
canal stenosis and mild to moderate lateral recess stenosis at 5-S1. The plan here is to do a decompression 4-5, fusion 4-5 by doing an interbody discectomy, interbody end plate preparation and cage insertion at 4-5 followed by percutaneous instrumentation in the sequence as discussed. Sister, can you help me by removing these MRIs? Remove them, pull them off. I have just done this one also please. A small pictorial representation of what my surgery is going to look like and the steps are exactly in the sequence how it is going to go. We are going to get our tube docked under Shyam guidance. The one bony prominent landmark that I'm going to use for tube docking is spinolaminar line oblique junction, which is this part, which is the base of spinous process and lamina. This is the one that I'm going to target on Shyam, get my needle here, first dilator, second dilator, third dilator, final dilator and the tube docked here to see a triangle of interlaminar space, spinolaminar junction and the facet joint. The second step after my tube docking is inferior facetectomy, which will allow me to do a direct and indirect decompression of the traversing nerve root, which is L5 in this case, and L4 exiting, which may or may not be needed to remove depending on how it goes. Then inferior facetectomy along with the overhang of superior facet will be resected, and the tubular vision will lead us to view the traversing nerve root and the disc space, following which a discectomy, box annular cut and interbody fusion will be done. Interbody fusion will be done by preparation of the interbody area in the area where inferior facetectomy is done, following which the graft which is locally harvested from the lamina and inferior facet will be inserted, following which a snug fit cage will be inserted in there, following which a contralateral decompression will be done on the opposite side as beautifully demonstrated by Dr. Umesh as of now, and subsequently after obtaining a true AP and true lateral. The importance of true AP and true lateral is to have a complete osseous placement of the screws where the tip of the screw will not cross the midline of medial pedicular line unless and until it has crossed the posterior vertebral line. This is that one tip that you must carry home, to have a complete osseous placement of guide wire, come tap, come screw, that the tip of your Cook's needle, your guide wire and your screw should not cross the medial pedicular line unless and until it has crossed the posterior vertebral body line. For very obvious reason, because the medial border of the pedicle will be crossing the posterior vertebral line only after you have entered into the vertebral body. So in the same sequence we are going to follow up. We are going to be using globus implant here, and the tube that I am going to use is Pitker carbon fiber 22 millimeter fixed cylindrical tube. I have drawn some lines here, if you can please focus here. The lines depict nothing but, can I have a marker? A midline, a midline which is purely by clinical feel, a line which is 1 centimeter lateral on either side, a line which is 2 centimeter and a line which is 3 centimeters on the either side. The line which is 3 centimeters away from midline should be ideal for placement of pedicle screws, whereas a line which is 1 centimeter away from midline should be ideal for putting in your tube for decompression. But we are going to be doing both. We are going to be doing decompression and we are going to be doing fusion by percutaneous instrumentation. So somewhere in middle will be my incision. At the site of incision, I have got a needle placement and I have got a Shyam picture taken there. This needle is for two things. One is to localize my level and also to allow me to localize the spinolaminar junction, and I'm going to be using infusion. I'm going to use saline infusion here to give me a primary dilation of muscles already. This will allow me to get a dilation of the muscles directly in there. Can I have another glove, please? Can we show the picture there on the Shyam? So you will be able to see where my needle is going to be docking there. Can you see the Shyam picture, please? The Shyam picture. That Shyam.
So Vishal, any particular stress on positions if you are having listhesis or anything, or routine position?
Sorry?
The position. Points for position, if you are having listhesis, you would want to probably recreate lordosis.
Yes.
Any change in position, then decompression?
In patients with low-grade spondylolisthesis and in all patients with discectomy and decompression, I always use vertical bolsters which allow me to maintain normolordosis for the spine, because that's the position I would want the whole spine to be fixed in. Whereas in patients with high-grade listhesis, in those situations I use a horizontal bolster, one on the chest, one on the pelvis, so that I have the possibility and flexibility of hyperextension of the hips as required intraoperatively to reduce a high-grade listhesis. Here in this case I have used vertical bolsters, 2 parallel from the shoulder to iliac crest. We have used general anesthesia, but for last 2.5 years I have been doing these surgeries under spinal/regional epidural anesthesia, doing awake spinal fusions in all my lumbar spine cases where 1 or 2 level decompression/fusion is required. In this case, we have used general anesthesia. I just asked my anesthetist to give me a blood pressures of 100-110 systolic, and also we have just used tranexamic acid to reduce the bleeding. The peak high pressures are less than 20, making sure that the abdomen is free. And as you can see on the C-arm, my needle is bang on the spinolaminar line, just 1 to 2 centimeters lateral to the spinolaminar junction. Can you appreciate that, the needle placement? Neeraj, can you appreciate that, the needle placement?
Yes, yes, we can see.
Yeah. So this, as you see, the angulation of my needle on the surface is pointing towards contralateral side, whereas I can easily have access to directly on the facet. Can you shoot, please? Shoot, please. AP. Can you see that? So yes. I can have access on the facet joint. Shoot. And I can have access to the base of spinous process. Shoot, please. Can you see that?
Yes, we can.
The another thing you would want to appreciate is that it's a true AP view of the disc, which is absolutely mandatory for any MIS instrumentation/fusion procedure to go well. This also allows me to get my tube in there, bang in line with the disc. Can I get a saline? Okay. Now I am going to infuse saline there. This is plain saline without xylocaine sensoricaine. Okay, picture here. And this needle is allowing me to feel the bone. This allows me to dilate the muscles. And this is an additional measure for hemostasis without actually requirement of xylocaine or adrenaline. Almost 10 cc.
Various styles of docking.
Mop.
Does it differently, does it differently. Now Dr. Vishal does it.
Shoot. This helps me to know my exact site of incision. As you can see, this is on the 2 centimeter lateral line, and the size of incision is 2.5 centimeters. I don't shy away from cauterizing the vessels because I feel that hemostasis, if not achieved now, can be a trouble at later time. The blood can trickle from the lateral aspects of the tube, and to me, the only 2 enemies of MIS. Can I have the lights on, please? Cautery not working. Chalo. The only 2 enemies of MIS is overhang of muscles obliterating your view, forcing you for blind bites, and bleeding, which can force you to have struggle intraoperatively in handling of the tissue. So after hemostasis of the subcutaneous vessels there, I can appreciate the fascia, and a facial incision will then be taken. Yeah.
So Vishal, would you put a liberal facial incision, or
sorry?
The facial incision, would you put a liberal facial incision, or you would restrict?
Oh, no, absolutely from corner to corner in line with the skin.
Yes, because in my experience, I felt that whenever you put a smaller incision and too tight on the tube, those patients are having more post-operative back pain. So maybe half a centimeter more of a facial incision wouldn't harm your patient. So I personally feel that you should be slightly liberal in putting your facial incisions in these patients.
So these are the dilators with markings like any other system. There are various Indian and MNC systems available. Here I am going to use a carbon fiber tube with serrations and markings, allowing you to choose the right depth. First dilator 7 millimeters goes in the same line, and the first thing that we do is to feel, and this is wending to feel right from first dilator, not only superior inferiorly but also mediolaterally. You tend to feel the base of spinous process. Shoot, please. And the first thing that I can feel is bone. Shoot, please. Shoot, please.
There is a different system here. Dr. Vishal is using AP view.
Yes, AP view, because I am using AP view because I want the angulation will allow me to decide how much over the top and contralateral I want to do, whereas placement of the tip of the dilator will allow me to see for interlaminar space. Shyam picture दिखा देंगे please. Shyam picture उनको दिखा
So
देंगे.
Vishal, one question, you know, when you are doing same procedure at alpha S1, Vishal?
Yes, Neeraj.
If you are doing this procedure at alpha S1 and sometimes, you know, iliac crest doesn't allow too much maneuverability.
Right.
So what do you do? Tips for that?
I'm yet to face a problem with that because your incision usually can be within 4 centimeters and the iliac crest tip or PSIS lies quite lateral.
Yeah.
You know, so usually this incision will come within 5 centimeters of midline, allowing you enough maneuverability of the dilators there. Can you see the Shyam picture there?
Yes.
And shoot, please. As you see, my tube is going to get docked in such a manner that I'll be able to see the spinolaminar line, interlaminar space, and a bit of facet joint. Okay, surgical field on camera, please. As you see, the length here I am getting is 45. I'll look for a 50 millimeter tube. Length or the depth of the tube is 50 millimeters. And while doing so, I'll ensure that the iobane drape doesn't wax in, which can easily happen while you slide in your tube inside. 2250 is the tube length. And the handle of the tube, Umesh keeps it medially. Some surgeons like to keep it one way. I always like to keep the handle inferolaterally. So I am on the right side of, left side of the patient, and this comes towards the inferior greater trochanter. Open it. Right. One AP picture, please. Okay, and lateral picture. Lateral picture, please. Table up, please. If you can appreciate, little up, that just by positioning the listhesis is completely reduced. Shoot, please. Can you appreciate that, Neeraj?
Yes, we are able to see that.
One thing that we have to ensure is that in some cases where there is severe osteophytes on the facet joint, the base of the tube may not be sitting on the bone and may be hanging and sitting on the tip of the osteophyte. In those situations, a lot of muscle may creep in, and that's why you have to push the tube all the way down to the bone and lamina so that you are able to get the tube docked on the lamina. And second, it should be in line with the disc so that your cage doesn't go into the vertebral body but inside the disc there. Okay, can the Shyam go out? And now I'll get my microscope in, surgical field. Okay, microscope can be pulled in, please. So this tube, the final dilator, works like a wanding instrument which will allow me to wand contralaterally, ipsilaterally, superiorly for exiting nerve root, inferiorly for the traversing nerve root to do foraminectomy. Okay, can we take away this? I have already touched the head. This one also. This, can you take this away? Table tilted away from me a bit, please. And this light I will want away. ये इसको अवे ले लो. नहीं, but ये touch कर दिया already. Table tilted away from me. Go away. Push the microscope to me, please. Push. Little more. Microscope on. My interpupillary distance is 67 millimeters, so I'll adjust the scope to 67 millimeters interpupillary distance, and I'll see the maneuverability of my scope. Long cautery tip available already? Perfect. Long cautery tip coming in my hand. Okay, microscopic view on the camera, please. It's already there. Perfect. So just to orient you, this is the orientation part, which tells you are always inferolateral on the handle. Even if you get lost at any place, this is inferolateral. So, medial, lateral left, superior head side, inferior foot side or L5 side. My tube is docked, as said on the Shyam, on the spino-lamina junction. And this musculature is purely because my tube here is sitting on the facet due to severe facet arthritis. Now, where do I start cauterizing? I'll start cauterizing in the superior medial corner, because that's where the bone is always there. Inferior medial corner is the interlaminar space, so cautery should not be running there. I'll zoom in a minute. While doing this, I am also feeling for bone so that I am not running by any chance into interlaminar space. And as expected, there is very severe arthritis there of the left-sided facet joint, resulting into facet subluxation. This muscle damage can be reduced by using anatomical tubular cages which have beveled edges as per patient specific and level specific angulation of lamina corresponding to the facet arthritis, allowing the tubes to sit on bone on all the sides. I use carbon fiber cylindrical tubes purely for the reason because I use lot of cautery to achieve hemostasis. The only thing that I feel is troublesome to me and actually takes a lot of attention from me is bleeding, and that's why I try to have as minimal bleeding as possible by using hemostasis right from the skin, fascia, muscle level to all the way to the bone with use of cautery. So my cautery is running anti-clockwise here, starting from superior medial quadrant of the tube, going to superior lateral quadrant, running inferiorly downward. Remember, you should never pull this muscle with your disc punch because all these muscles have tortuous vessels, and once they rupture because of your pulling maneuver on the muscle, they can retract back beneath and under the surface of the tube, and it will become extremely difficult to catch those vessels which have retracted beyond the reach of the tubular vision. And that's why do not pull any part of muscle or soft tissue unless you have cauterized and dried it off. That's synovial tissue. Can you appreciate the osteophyte? That's the there.
Yes, yes.
That's lamina. That's the inferior facet, as you can see in the movement, and that's the superior facet. Somewhere here lies my joint line. And this is the synovial tissue from the facet joint. So this surgery is easier than what Umesh did because here I have less factors to worry about. I don't have to worry about the capsule while decompression. I don't have to worry about the pars because it is determined to sever and take away the pars totally. And I am not worried about dural and neural retraction because I am going to be landing in the foraminal area where retraction of neural tissue is almost nil. Now I am trying to expose the interlaminar area where my first forward will start going in. First bite of the forward will start going in. You can see and appreciate that the lamina lies at a depth, whereas the osteophyte will not allow the tube to go all the way deep down. Can I have a final dilator, please? So that's the spinolaminar line. I want to see a little more of it while I can see the facet joint here. This is the superior facet of L5. That's the inferior facet. The first bite is the most difficult and you should plan it absolutely well because the moment you get your bite, the maneuverability of your forward becomes very, very easy. Final dilator, please. Getting my final dilator to see a little more of me, a little bit. Yes. Can we have patient tilted a little away from me? Yeah, away from me, please. Go away. Now, these maneuvers that we do with the table pose a risk to the patient unless the patient is tied and secured to the table. Otherwise, sometimes patients can shift, the bolsters can shift, And that's why your assistant pre-operatively and intraoperatively helps you to prevent the destabilization of patient while these tilting maneuvers are happening.
So I only do slightly differently here. As you said that you will be using your Carrison now to remove the facet.
Yes.
I only use a drill, create a channel. And
Sorry?
I use a drill, the burr.
Oh yes, yes. So there are various ways of removing the inferior facet.
Correct. So create a channel and from just osteotomize the facet.
That's right. That's right. So I generally avoid using osteotomes for inferior facetectomy and drills for inferior facetectomy for two reasons. Because the amount of bone that we get is any which way is limited. So by using drill, I may actually lose upon the precious bone here.
Yeah, so we don't crush the facet. We just create a channel so that it goes easily and it's slightly quicker.
Yeah. So here, as you see here, that's the soft area of interlaminar space. Disc punch, disc punch, disc punch, disc forceps, disc forceps. So we'll clean the interlaminar space, and as you see, all the osteophyte. That's the osteophyte there. This is the osteophyte. Has closed the interlaminar space totally, but because I have got my tube little more medially directed, we can actually see some amount of interlaminar space, and that's where exactly my first bite forward is going to come, allowing my forward to bite the whole bone and still preserve a lot of bone there. So because I have burnt and charred all the overhanging muscle, as you can see, this is very important. As I was emphasizing that the two enemies of MIS, one is bleeding and second is overhang. This is overhang. Even 1 millimeter, if my diameter of the tube is 22 millimeter, my base of the tube should be seen 22 millimeter. Even 1 millimeter, if the muscle overhang is eating up, it is reducing my view by almost 5%. 1 millimeter out of 20 millimeter, if it is eaten up by overhang of muscle, almost 5% of my vision is being eaten up, which can easily be taken care of by use of cautery, liberal use of cautery. This cautery with metallic tubes can sometimes create skin healing issues, but with a carbon fiber tube, it usually is very safe. And that allows me to have a complete visualization of the whole lamina that I have to do. So the inferior facet is seen, the superior facet overhang is seen, the interlaminar space is seen, the osteophyte is seen, and I can now start doing my inferior facet. And that's the spinolaminar junction, spinolaminar line, inferior facet, superior facet, and the osteophyte down there. So that's first bite at the base of the spinous process, and we start working. Please keep all the bone. Do we have number 4 and number 5? So I already have enough space for my number 4 and number 5 to walk in. Bone wax of McDonald to keep ready. I may need it any time. And that's not only going linear, but also widening the trough. You cannot dig your own well, and that's why you have to widen it at every stage. One bite up, one bite lateral. One bite up, one bite lateral. And as I said, this is a simpler surgery than what Umesh did, because here I don't have to worry about half the factors which Umesh was worried about of saving the pars and capsule. Here I have to sacrifice the pars and capsule. And that's the inferior edge, which I'll take care of it later. The whole idea of doing laminotomy is to release the ligamentum flavum from the undersurface and have access to the dural tissue. How much laminotomy is required? We had a debate this morning. In a disc patient, you can actually do a flavotomy where you incise in the flavum and go inside in the epidural space. But in a patient with decompression, you have to actually detach the upper extent, the lower extent, and the lateral extent of the ligamentum flavum, because the ultimate culprit in a degenerative canal stenosis is ligamentum flavum hypertrophy, and all of it should come out. Superiorly, how do we ensure whether it is superiorly released or not? you start seeing some amount of blood start trickling the moment you see that the superior aspect of ligamentum flavum is released, as I will show you now. Can I have McDonald?
So Vishal, what is your extent of articular process removal? I mean, would you go all the way up to the isthmus, or how much would you remove?
So, very important question, Neeraj. I will remove as much as is required to release the ligamentum flavum from the superior lateral corner where it is the highest placed. Narhook? Narhook? Can you appreciate the fat hernia from the superior edge of ligamentum flavum?
Yes, we can. So my point about, how much I remove it, sometimes, it depends.
That's the release.
Tentatively what size of cage I'm going to put, because if we are going to put, say, about 12 cage, or it might require more extensive removal of articular process and isthmus along with the SAP removal. So that's a very valid point that, we need to remove as much as it is required, and sometimes pre-op planning also help in deciding how much inferior facet and isthmus you would remove.
Niraj, how much size of cage usually?
Sorry?
What is your usual size of cage?
Usual is, I think, I have never put a cage less than 10 since last so many years. Rarely I go for 14, but yes, there are cases where I have gone for 14 size also. But I think, since the time, we are more and more focusing on the segmental lordosis, I think since last 5-6 years, what we are doing, we try to go slightly higher and one size lesser cage. So supposedly, easily I am able to dilate up to 14. I would prefer to put a 13 size cage so that I can compress posteriorly and can give a better segmental lordosis in this patient. Umesh, any?
So what I am doing here is going and tracing the border of ligamentum flavum, and as you see, going lateral along the superior border of ligamentum flavum. Can you see that? The first glimpse of dura is already seen. Can you appreciate that?
Yes, very well.
But I will not remove the ligamentum flavum unless until my whole inferior facet is out. Can you see that?
Yes.
And this process will continue laterally in the foraminal area till the whole of ligamentum from laterally is also taken care of. This punch. Now you can appreciate the extent osteophytes which are covering the joint.
Yes, they are covering osteophytes.
The inferior facet out. Please make graft of it.
Important to do a complete facetectomy. That while sitting in a cage, you don't retract the traversing too much.
That's right. That's right. Very important.
Rakesh, you are not clearly audible.
Rakesh sir?
Yeah, hello.
You were not audible, yeah. So my cautery is going further lateral to, when I remove the facet, I'll go this lateral that I can actually reach the lateral border of the superior facet, all the way up to here. Number forward. As you see, I have continued to go in the foraminal area, and this I will continue till I see the release of ligamentum flavum laterally, all the way there in the area. Because that's where the whole ligamentum flavum will be released, and exactly that's where the exiting nerve root will be seen. The endoscopic guys will call it the superior border of Cambin's triangle.
Shall you always try to see exiting?
Never, unless I am sure clinically that this patient has symptoms of exiting nerve root also. Otherwise, never. If it is seen, अपने दर्शन खुद दे दे तो ठीक है. दर्शन लेने जाने का नहीं.
Rakesh, I always see whenever there is a lytic listhesis, because more often than not, I have found that yes, you can regain foraminal height, but still there are a lot of fibrous tissues which might be compressing. So in a lytic listhesis, I always see exiting root. And that probably gives me some peace of mind that, while putting larger size cage, using my instrument, that I am far away than a foraminal region. So
I have reached the lateral extent of the foramen, And lateral extent of, can I have the bipolar my side, please? Can you appreciate the whole extent of ligamentum flavum from medial all the way into the foraminal area? Put switch to my side, please. This is the only place where often we find bleeder. Otherwise, it's a very pretty bloodless surgery. Right. What is the alarm like? May not need that. But I must acknowledge one thing, that more than learning how to do surgery, from Dr. Luhana, what I have captured here, I am at his wonderful center. He's made state-of-art center here. It's Venus Superspeciality Hospital. I was just asking him that how did you start and when did you start? And I must appreciate his entrepreneurial skills, which I think most of us lack right at the time when it is needed. Like there will be many guys who will be watching these surgeries on how to do surgeries. The problems come where to do surgery, how to optimize the financial benefits out of it, how to enhance the surgical care to patients while having the independence of the professional. I think Dr. Luhana has to take a class for all of us on this. Yes. And I'm really looking forward to meeting your partners as well. So we all need to learn, all the fellows, particularly young guys, how to start a MIS practice, how to set up a nursing home.
Vishal, Rakesh is ready to provide consultancy for your setup establishment in Bombay.
Oh, I wish I had that kind of money, man.
Oh, no problem. Rakesh will invest. Don't worry.
Yeah, for that I'm ready. So as you can appreciate, nerve hook, please, again nerve hook. So the whole ligamentum flavum, right from the most medial, this was the place of base of spinous process. We have released it here, all the way into the foramen. Lateral, here, till here, is released. Can you appreciate that? Now the moment you have released this, please don't pull it out, because the moment you pull it, it will bleed, and that's why you just keep it there. Keep it there. We will bring this sheet of ligamentum flavum after our second and third part of release gets over. So we have released superiorly, we have released medially, now we release inferiorly here, and then we release the superior articular facet overhang, because this is the area where I have to put my cage. So this overhang of bone has to go away. And so now my second part is to release inferiorly. So we will release the ligamentum flavum inferiorly here. This is the place where in severe canal stenosis, there are dural adhesions and the nerve root, traversing nerve root will be lying there. And that's why this release has to be extremely cautious if you don't want to have any dural leak here. So this is that part where a maximum number of dural leaks would happen. So I have released, this is the medial facet now. Nerve hook, I'll show you, I have released it inferiorly. That is the inferior release that has happened. You can see the fat herniation. Can you see that? Yeah. So the inferior release is done, medial is done, superior is done. Now we have to do lateral release and superior articular facet. This sheet of ligamentum flavum is giving us dual protection of preventing bleeding and also to the neural structures. मेरा सामान आ जाए तो मुझे बताएंगे ना please, whenever my instruments are here. Have you taken burr? Huh? Okay, no worries. No, it's okay, it's okay. So when you have sagittally oriented, depth of this forward bite, this depth has to be larger than the sagittal length of the facet to have a good bite there. We'll use a 5 mm osteotome if required. Gradually, the ligamentum flavum is being released. I am working at the overhang of superior articular facet. 5 mm osteotome, please. So the whole ligamentum flavum is being released, but I have to take down this. Yes, please come. Yeah, perfect. And I must compliment Dr. Luhana for having wonderful set of instruments he's got. Everything that is required for MIS. So you have to ensure that you remove the overhang of superior articular facet bit by bit. If I osteotomize too much, I will actually enter into the superior wall of pedicle, compromising the stability of the L5 left-sided screw. And that's why osteotomy should be done in a very conservative manner. Come, this punch please. And this removal of the overhang of superior articular facet is very important for two reasons. One, it allows you access to true transforaminal root. Otherwise, you will go your cage from here, resulting to retraction of the nerve root, causing paresthesia and post-operative battered nerve root syndromes. And that is why this removal of the superior articular facet gives you access in the true transforaminal area, number one. Number two, it is this part where the hidden ligamentum flavum is lying, which has to come out. Can you appreciate this part of the ligamentum flavum? Particularly in patients with exiting nerve root compression, this is that portion of the ligamentum flavum which has to be taken care of to prevent recurrent symptoms and residual symptoms. Meanwhile, while we are working on this, a generous request to all the members who are watching this physically and virtually to come and attend the annual conference of Minimal Invasive Spine Surgeons Association, which is scheduled in Pune this year. The Pune Spine Society and Minimal Invasive Spine Society of India is organizing this annual conference where you'll get to see many more flavors of minimal invasive spine surgery in greatest possible detail with star-studded faculty, and that's in November, right sir? 15th to 18th November. The details are available. You guys can contact either Dr. Neeraj, Dr. Umesh Srikantha, who are also in the scientific team. There is a plethora of live surgeries, endoscopic and MIS, a wide variety of deliberation by national and international speakers, hands-on workshops, and much more, apart from gala camaraderie that you will see there. So now I have done enough amount of superior articular facet resection, and my inferior release has completed the medial release. Can you appreciate that? This whole sheet of ligamentum flavum can now be pulled up like a sheet, which will expose the dural tissue. And as you see, this whole thing is released. It just walks out. And while I tease this ligamentum flavum, I also ensure to see that while this, there is no dural movement, because any band like this, if you pull out violently, you may actually create a dural injury. We're pulling out the ligamentum flavum totally and reaching out exactly lateral, very lateral to the lateral border of traversing nerve root. And this part is the more vascular part of it. So when you pull this out, ensure that your bipolar is ready. Remember that while using bipolar, be extremely cautious in the superior lateral quadrant, because that's where the exiting nerve root is, which is this quadrant. Don't blindly go and burn here. you may actually injure your exiting nerve root. Blind biting and blind burning is not allowed. And if you are not able to see anything, don't use bipolar, use patties. Can we have patty, please? As you can see, that's the exiting nerve root. Can you appreciate that? Yeah, let's go. So my first patty is always lateral in the foramen because that's where the bleeders come in epidural space. The moment you pack your first patty there, your bleeding becomes half. Another patty, please. Wait. So this takes away my exiting nerve root away from my site. Before I put my patty, I will show you the exiting nerve root, which I don't want to see, but it is giving darshan.
Vishal, that exiting route has come to take your darshan probably.
Wait. Yeah. Sorry?
Exiting from for the
Oh, yes. Luhana sir ke hospital mein. Can you see, appreciate that? Anyone
Yes,
there in the
yes,
hall?
yes.
Sab so gaye. Neeraj?
Yes.
I can see you eating, concentrating more on food. Umesh, what are you eating, man?
Umesh is, starving.
I was awake during your surgery. You can't sleep and eat during my surgery.
I guess, you people were, doing something nasty yesterday night. You may not be hungry, but Umesh seems extremely hungry. And I'm sure Rakesh treated both
That's
of you
the
very
patty
well.
gone in the axilla, one in the foramen, and one in this area. So this all will make my field absolutely bloodless. Can you please catch up on the thread there, please? No, somebody will have to help me. And one patty in the traversing area. Remember, in a chronic case, this has to be very soft because there may easily be adhesions, as you can see here. Nerve hook. Yes. This is the adhesion. Can you see that? That adhesion has to be taken care of. Before you pull it out, it can be a vascular adhesion. Nothing. So what you are doing, visualizing, is the disc, and this is the femoral area from where my cage will migrate inside. Again, overhang and bleeding. Jab dikhe tabhi maro. Whenever you see the bleeding and overhang, you have to take care of it then and there. Never wait for another 5 minutes. So you have released it. And the disc is right in front of me. Brother, my instruments are here now. Mere instruments aa gaye? Okay. And now is the time for doing discectomy. So step 1 and step 2, as written on the board, is over. We have docked our tube, we have done an inferior facetectomy, and we are now proceeding for discectomy. And what the specific instruments that you would require for interbody fusion are pukas, chisels, disc shavers, dilators, and curettes. So you have to have these ready. Come, ready, brother? I am ready here. Yeah, 50 number knife or 11 number. 11 number or 15 number knife. So that's the traversing nerve root, which is compressed already. The exiting nerve root, again decompressed already. And we, as discussed and planned, we do a box cut. Box cut. The sharp edge of the knife always moves away from the dural sac and away from the exiting nerve root. I always use both hands when I deal with my knife there. It's extremely important to have a complete control on your knife. It's a disastrous instrument. You can actually create irreversible damage if you have uncontrolled use of this instrument. Careful, brother. This punch, please. And I have some pukas. ये thread को थोड़ा सा tight रखेंगे क्या ऐसा? Yeah. Come, this punch, please, brother. Perfect. And can you show me the pukas from my set, please? Receive. And I'm inside the disc. So before I proceed any further, number 3 forward please. I will do a proper box cut of the annulus. Unless you do that, you will have a constricted opening of the annulus resulting into improper disc space preparation or cage and shavers moving into the vertebral body. That's okay. मुझसे ज़्यादा गरम कुछ नहीं है. I'm the hottest.
Sir, watching, I was saying this that for the calcified medicine.
Yes.
Rakesh,
Sir, आपका आवाज कम आ रहा है पता?
Rakesh, you are not audible.
Now, there are various companies which have expandable cages where you don't have to really create a box cut in the end plates and you have to be less worried about the exiting nerve root irritation. Globus per se has an expandable cage where you can expand your cage from all the way 9 millimeter to 16 millimeter, and they are coming up with another variant where 18 millimeter expansion can be done, right? Globus team? Yeah, this punch. And they are beautiful expandable cage which allows you to prepare the end plates without creating a bigger entry point.
Expandable cage, there will be very little bone graft into the cage.
Yes. Yes.
Are there fusion rates?
No, in fact, Dr. Luhana, your concern is right, but it has been studied that the fusion usually happens around the cage rather than inside the cage. So no matter how small a graft we have, I think if you can pack it around the cage, anterior to the cage, I think that suffices. Agree, Dr. Luhana?
Yeah, fine. Important that when you are doing a TLIF, put a lot of bone graft ventral to the cage, so the fusion occurs across from ventral.
Yeah. Pukas now. Mera wala pukas dena. Yeah. So now I have been using these for almost 13 years now. These are pukas of various diameters, 7, 9, 11. They are blunt edged in the front and on the sides. These are just dilators. Various companies have it in various sizes. How to determine whether optimal disc space preparation has happened? I think that's very subjective. And this is very subjective. It is more driven by feel rather than any objectivity. And I am not very fussy about using a very large size cage. I would rather use a cage where my puka has determined slight amount of distraction between the two vertebral bodies.
Optimal size of cage is important. Either too small or too big is a problem.
Can I have number 3 forward, please?
Well, I guess
Number three,
I
number
always
three
tell
forward,
all my
Sada.
patients that 100% recovery.
Please, number
never
3 forward,
comes. So
Ranjan.
back pain is, everybody knows it's an enigma. There are chances,
Yes,
high
thank
chance
you.
that this patient would improve in back pain. But 100%, I don't think that we can promise the patient that 100% back pain would go. For a stenotic patient, we always say that your walking distance would improve, your standing time would improve, your radicular pain would go. But I always counsel and take a written consent for my patient that expect 10 to 20% of residual disabilities, numbness, occasional pains and all those stuff. But this kind of instability, I think back pain is fairly prognosticated that it might improve significantly.
Wash to me now. And company pukas then come in. Start with number 9. Yes, please. So with the help of my nerve hook, I would now feel the grating sensation. Nerve hook, please, brother. Brother, nerve hook, please. The grating sound of bone is something that is a very helpful feedback. Nerve hook. It's a very essential feedback to tell you whether you have done enough or not. Yes. The bone is also asking, bas ho gaya, mere ko chhod do ab. A good amount of, and I am pretty deep anteriorly on the opposite side. There is a reverse angle curate. Do you have? Mere set mein? No, not these, not these, not. Idhar do. Mera set kidhar hai? Curate. Okay, no worries. So there are these various curates of different type. The reverse angle curate, they help you punch any central fragment. You can use this. You can use this to have push the subannular fragment there. Particularly in patients with central disc or contralateral disc fragment, you can work with this. Come, this punch, please. You see? Okay. And then box curved curates. I am not very aggressive with these. I generally like to do it only if I feel that there is any cartilage left. But here I am very sure that we have done adequate end plate preparation. So not really keen to be very aggressive with these curates. They can be double-edged swords, sometimes can breach the end plate, resulting into a cause of subsidence. Wash and company pukas, please. Company puka, number 9, please. So we'll start with number 9, and where I feel that the rotation of the puka is up, is tight, is scraping the end plates, that's where I'll stop. Number 9 mm, going in easy. That's what I expect. I expect this will be approximately 12 mm size. Number 10, easy. Number 11, that's number 11. Again, just touching the end plates without scraping it. I am easy. Number 12.
Vishal, something is coming in way.
Number 12.
Vishal?
Yeah?
Something is coming in way. We are not able.
Okay.
Okay, yeah. No, there was some cover.
Is it better now?
Yeah, now the handle is visible. Yes.
So 12 is just enough. You see the distraction, can you appreciate that?
Yes.
So this is the amount of distraction. Few millimeters is what I would want, not more. Anything more, see I am pulling it up and it is not walking out. So if my 12 mm has a snug fit there, I think I am good with this. Sometimes if this also rotates free, I will rather prefer a 13 then. But I am not going to put any further puka into this, because the more pukas I put and rotate, the more loosening will continue happening. So what cage size do we have? I think I am good with 13. I'll take 1 millimeter more than the puka that rotated inside. And I'll require a nerve root retractor now. No, only 12, yeah. And this is the area of annulus that I will want to remove now, because my cage can otherwise damage the end plate if I don't remove this, and this constricting part can be a problem. So nerve root retractor, please. Luhana sir, I'll need your help. Yeah, this is the one. Sir, I'll need your help. Just hold for a while, please. Number 4 forward, please. Yeah. Number 4 forward. Punch. This is the only time when my retraction comes up. Okay, give me a funnel now with graft. So I have enough box created now for my cage to walk in. I generally tend to have, okay, can relax there. I generally tend to rotate my cage, so I'll have a narrow entry and a broader breadth. I'll show you how to have a snug fit. Okay, perfect. Come. Get me a funnel now. No, don't pack. Don't pack. We have to show. Okay, जो है उसको रहना. Yeah. What we use is a funnel. Another very important aspect of funnel is that the trocar of the funnel should never be more than few millimeters, not even 1 millimeter more than the base of the funnel. Why? Because if the trocar of the funnel, for example, if it ends here, this is going to go and lie on ALL. And if this comes all the way till here, 3-4 millimeters, you will actually be breaching the ALL, resulting into your graft going into the retroperitoneal space. So as you see, this goes and rests on the ALL, and we have chosen a right size and right type of funnel, and we are going to be putting in graft. Come, graft coming in. Graft. Brother. Would you like to see how much graft we have got? There is some more than this, which is more than adequate. And what we are going to do is, hold this. The placement, come. Graft, come, brother. 13. Come.
13 by 22?
Yes, 13 by 22. As you see, I am punching the graft in I'll want to ensure that I am not punching it anterior to ALL, all this. And that's why a soft punch of the graft while holding the funnel up is very important. Particularly in patients with infective spondylodiscitis, this one control on your funnel is extremely important because ALL is breached there, and any attempt to punch in a lot of graft or no control on the funnel can actually lead to retroperitoneal spread of the infection. Okay.
Even
So you can see the angulation of. Yes, Umesh, please.
Neeraj here. The same thing applies when you have a collapsed disc and you try to open it too much. Sometimes, just ALL snaps, and you need to be very careful while putting grafts, putting cage, because graft may also migrate anteriorly.
True, very important. Such a wonderful point it is. In a patient with very collapsed disc, please don't try to jack it up too much. The more you jack it up, the more chances that you will have a subsidized cage very soon. So my graft is packed inside now, and now my cage would come in. While I push my cage, two things that I ensure is nerve root is retracted at that one point in time, and also these patties have to be secured because sometimes these patties may walk in with the cage and result into problems. So this patty has to be secured on the other side, upper side, and ensure that there is a smooth space for the cage, because while the cage goes in, you are actually walking blind. And that's why before your cage walks in, you have to ensure your nerve root is secure. Dr. Luhana is giving me a hand there. Some cage ready. Yeah. This is the only time where my nerve root is retracted by manual metal instruments. The cage that we are using, the height is 13 millimeter, but the breadth is narrow. Can you see? So I will get a breadth in there like that, and then rotate it by 90 degrees. Come, hammer. And the moment my cage walks in inside,
why you are operating, that
I'll get my nerve root retractor away first. And even before I rotate,
there are two ways. One is you
the
try to
first thing
restore
that you
equal
ensure
height as the
is
above
to have
does,
final placement of
or
cages.
you are just want
Have a
to
look at the
open
patties,
foramen. You
whether
can
your
just,
patties are
8
secure or
9 to
not.
10 millimeter is
If
more
your
than
patties are
sufficient.
secure,
Because if you
that's
go
the
larger,
time
there
you
are
may want
chances
to
that it may sink in.
punch it
But
as
more
far
often
as
than
you
not,
can.
when you have
and
collapsed
rotate it.
disc, the end plates are so sclerosed that you can very easily check
And
it
the
open.
rotation allows me vertical distraction of the vertebral body. And see, my cage is not fit in there. And once I have achieved this 90-degree thing, further hammer it. Okay, before I withdraw the cage handle, is check to see cage is rightly anteriorly placed or it is slightly posterior towards the nerve root. So step 3 will be over if the cage is rightly placed, and then step 4, which is over the top, will be done then. Can we have the table tilted back to neutral, please? Remember, our table is tilted almost 30 degrees to other side. Go further, go further, go further, go further, go further. Okay, perfect. Table up, please. Up, up, up further. Okay, brother, shoot please. No, up, down, 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 down. Wait, down, 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 down. Further down, further down, down. Okay, perfect. Go towards up. Perfect. Shoot please. Yeah. So as you see, the cage is, the posterior line, metal line of the cage is yet to go in. Can you appreciate that? And we punch it further. Shoot please. Little more, but remember we have a lot of graft there. Shoot please. And this is a 13 millimeter cage. Shoot please. Okay, I think I am happy with this. Luhana sir?
Yeah,
a little more?
Little more, yeah.
Little more. Okay, shoot please. Yeah, I think a lot of hammering is happening. And that's when, okay, can Shyam, this picture please, surgical field picture. and the cage is inside. Okay. Can microscope come in back, please? And this is the time you can see how angulated my tube is. I can actually with this itself do a over the top decompression, but I'll have little more wanding. Table tilted back away from me, please. And we'll do over the top contralateral decompression. Okay, go away from me, further away from me, further away from me. I'll need little bit of gel foam now because I want my patties to come out.
Vishal, finally, can you show us the AP view as well, just to confirm the cage position?
Little bit of gel foam, please.
Vishal?
Yeah.
Once you are done, maybe
Sorry?
one shoot in AP. Once you are done, you know.
Yeah, I'm done.
No, one shoot in AP.
One shoot in AP. Yes. We'll show you. The moment I'm getting.
Yeah. Whenever you are done with your.
I am 200% sure we are already crossing the midline. Nerve hook, please. And now we will work on the dorsal surface of the dural sac. This is the plane that we have to go, and that's the ligamentum flavum. This is the midline where the ligamentum flavum was released, right? So now final dilator and gel foam. The one patty that comes out first is this one, the traversing nerve root, which will show you that the traversing nerve root is free. Can you appreciate that?
Yes.
Quite well retractable. Now at this stage, right at this stage, before even I do a opposite side decompression, why is this important to remove your patties? Is because you don't want to leave a graft fragment which could have just gone here and there. And also, a contralateral decompression requires an absolutely hemostatic field. You don't want to see any bleeding while you are dealing with the nerve roots on the opposite side. And that's why achieve hemostasis at this stage. Right? So my one patty is out and my final dilator goes in 19 millimeter. 19, इससे एक छोटा वाला. Sir, I need a hand from you. Yes. From 19 millimeter. Yeah.
Vishal?
Okay. Yeah.
When you have such a significant size, larger size of cage, how much would you depend on indirect decompression on the opposite side?
नहीं समझा मैं क्या बोला?
You have put 13 mm cage, so how much you would depend on the indirect decompression on the opposite side?
So, you know, for me, indirect decompression is meant for patients who have mild to moderate symptoms. For example, if this patient had 100:40 symptoms on left versus right, I would actually not do too much of fiddling on the opposite side if I have used a large size cage. However, if the symptoms are in the ratio of 50-50, both sides equal, I would surely want to do a direct decompression on the opposite side. I would not rely solely on indirect methods, particularly when I am already doing a decompression. It is only a minute of job. Like you will see in 5 minutes our contralateral work will be done. As I said in the morning also, contralateral decompression is the easy part of the decompression. Ipsilateral part is difficult. And in this case, that ipsilateral part is also easy because you are already taking down the facet. So I made a plane there. Can you appreciate the plane?
Yes.
And we have to work in that plane. Can you see my nerve hook has already gone there. And this is the same plane that I will be working now.
So in a lytic listhesis, when there is exiting root compression,
yes,
then you depend on indirect decompression.
That's
Here
right.
A lot of ligamentum flavum hypertrophy, lot of facetal arthropathy. In that case, contralateral decompression is important.
You know the shoulder of the nerve root is here on the left side. So you exactly know shoulder of the nerve root on that side will be there. And we are already able to see that. Can you appreciate that? Yes. And that's the superior edge. And all this is happening under the spinous process. Under the spinous process. Can you see the constriction of ligamentum flavum here?
Yes.
That's what we are going to remove. And as I said a while ago, that if there is severe canal stenosis, it is this edge which can result into dural injuries. So you have to be like doubly cautious when you're dealing with the inferior portion of the compression side or the superior edge of the inferior lamina.
So another important point for delegates looking to the suction which Vishal is using, make sure those who are using drills and burrs, try to use separate suctions, because sometimes when you use the same suction that had the edges, and when you try to swipe the dura with that suction, you may actually damage your dura. So keep suctions which you use with the drill separate from the suction what you use for dura.
And the suction tip, you see there is a hole here.
Yes.
When your suction tip is sitting on the dural sac, the hole cannot be closed. Otherwise, the suction will have a pressure necrosis and the nerve rootlets can just suck in there. So my hole, if you see, I have removed and working like a retraction, and when I am away from dura, that's when I use my finger. So this mobility of controlling the hole there and the pressures is very important.
Another important aspect is here predominantly it's a ligamentum flavum stenosis. In that case, you can do it with punches like Dr. Vishal is doing. But if there is predominantly bony stenosis, like in a previous case, the drilling is very important before taking out that ligamentum flavum, as Dr. Umesh Srikantha demonstrated.
So Dr. Luhana has been kind enough on me to give me a simpler case, as I have been telling him since morning.
Well, excellent surgeon makes it look easier, Not that easy.
Vishal, how often you do opposite side facetectomy in patient?
Opposite side facetectomy?
Yes.
Only when I have a patient with high-grade listhesis with very severe osteophytosis. Because those are the cases where I would do bilateral tubular facetectomies, bilateral disc space preparation before my screws come in. I don't want to put my implant under stress. And that's what, very, very rare. But I don't remember when I did it last. So extremely rare, extremely rare.
In fact, Vishal,
in fact, in those cases where there is, as I said in the morning, severe facetal arthropathy, high-grade listhesis, I have a very low threshold of converting them to open.
So we are doing, our retrospective analysis of cases very recently where we started doing bilateral facetectomy for alpha S1. We have noticed, still we are probably reviewing it, but we have noticed that it gives better lordosis when you do bilateral facet. So it's like a Pontes.
Oh yes, I agree.
So alpha S1 nowadays I have started doing bilateral facetectomy to give a better lordosis.
So in all alpha S1 or any selected cases?
No, all alpha S1.
So you do bilateral tubes and bilateral?
Yes. Alpha S1 we always do bilateral. 4 or 5 depending on how much lordosis I want, because I think that's one of the most important thing these days to prevent your adjacent segment, prevent back pains, future problems. So I try to, assess pre-operative lordosis, and if I feel that it's not coming, I sometimes go intraoperatively also opposite side and try to do release, do facetectomy and get a better lordosis.
So if you see, I am already lateral to the lateral edge of the dural sac.
Yeah.
And these are the vessels, I will not disturb them, and I will go in this lateral recess area, which is also the medial facet on the opposite side. Again, no blind bites, unless you see, don't bite it. And we'll take this forward inferiorly to make a added foraminotomy. Bipolar. Can I have a patty? So one thing that I have learned from Umesh, I will practice it today. I'll get my patty before using a bipolar. Okay, gel form. So I think I'm done on the other side. Naruk. So we'll see from the shoulder. That's the shoulder. That's the disc and the nerve hook walking there. Luhana sir?
Yes.
Yeah. My nerve hook is touching the pedicle on the other side.
Yeah.
See? This nerve hook is touching the pedicle.
Yeah.
Here is the foramen, the opposite side.
Yeah. So bilateral decompression done. Perfect. Cage placement done.
So my contralateral nerve root is seen well. Gel form, tiny piece. And I will.
So opposite side hemostasis is one of the most important thing because there is still constraint of space because of lamina. So never leave behind any bleeding vessels, specifically contralateral side. Vishal, how often you use hemostatic agents?
Forward number 3. Sorry, hemostatic agents, I keep it very often. I mean, it's always there in my bag. Even now, I have a pack of Flow Seal with me. Always. But you are never 100% sure of bleeding in spine surgery.
Absolutely.
But how often have I used it? Rarely.
I use quite often, specifically contralateral, because I feel more safe not to use bipolars on the other side.
Yes, very true. I rarely use it. In fact, on ipsilateral side also, it is said that the less bipolar you use, the less neural edema you will have.
Exactly.
For the very obvious reason that the venous flow of the nerve root is not disrupted.
Dr. Umesh,
but I think
nicely demonstrated contralateral hemostasis. Use a patty over the root and then.
Absolutely.
Oh yes.
Absolutely.
Plus, I think neurosurgeons have a better meticulous hand when it comes to hemostasis. We orthopedicians are lousy.
I think looking at your surgery, you look like a neurosurgeon.
Sorry?
Yeah, you look like a neurosurgeon when I look at the surgery.
Oh, I'm so humbled to hear this. आज आप मेरी तारीफ करो मैं आपकी. Anyway, so wash. Yeah, so I think my surgery is done. We are able to see both the extents of the nerve root. We will now evaluate the decompression part. We will see and cross-check the cage, and then we will see both the nerve roots, hemostasis, if there is any loose graft fragment, whether patties are completely out or not, and then our tube comes out to ready for percutaneous pedicle screws. Enough. So starting with our cage is quite well contained by end plate. I push it and see, and it's not moving. The nerve root here is quite free. The nerve root there is quite free. I can feel the pedicle on opposite side. I can feel the pedicle on this side. The exiting nerve root is here. We will one by one, gel foam cap ready please. One by one pull out the patties. Sometimes you pull out the patty and patty may break and come out. Sometimes half the patty may come out. So what I do is bring out patty, spread it out and ask my assistant to see whether the spread of the patty is equal to the other patties or not. So never use patties of different size. They should all be of same size. And patty should come out fully compared to other patties should be same. And whenever you bring out patty, remember it's going to bleed. So be ready with your gel foam and another set of patty.
Would you leave behind gel foams or you will remove it later on?
Sorry?
Gel foams you would leave behind?
Oh yeah, I have no qualms about it. Yeah, it's such a tiny gel foam that I'm using. Okay, enough. I'm able to see a bleeder. So only active bleeders will be taken care of by bipolars. All the other oozers will not. Come out. Okay, perfect. So I have the green signal to pull my tube out. The beautiful part of the tube pulling out, I'll show you later. Come, get me a Cook's needle, please. Cook's needle. Cook's needle. ऐसा वाला कैन्युलेटेड कुक्स है क्या? कुक्स छोटे हैंडल, इससे लेंथ में छोटा नहीं. This is the smallest. So what I do is, under vision, I will put my first. As you know, this is the pedicle. We all know this is the pedicle. That's the superior wall of pedicle here, and there's the medial wall of pedicle here. So my entry point for first will be here, reducing the amount of radiation, and that's why. इसको ओपन करेंगे, इसको. Yes, पूरा खोल देंगे. As we pull out this tube, the muscle and the fascia will just fall back. But before I do that, I will want my first screw to be secured. Patient tilt to my side, please. This reduces the amount of radiation. Yeah, to my side. To my side. My side. Come more. Okay, perfect. So now we use the Jamshedi to get our first guide wire for the L5 screw under direct vision. Okay, hammer. Yeah. Hammer. Go. No. है क्या? Cook's needle है क्या? Cook's needle. Sorry. Cook's. है? So I generally like to use my Cook's needle. It's a little more sharper than what I have right now, but these are also very common. White with the green this. Okay, some guide wire coming in. Serrated inside. Always put the serrated portion of the guide wire inside to have a feel of the bone catching it. And my tube, as you see, as it comes out, you will see the muscle. So somebody was asking about dural leaks. If dural leaks happen, do nothing. Allow the muscle to fall back and cover it up totally, as you can see here. Right? It just falls back. There is no dead space at all. Okay. Come, Shyam coming in. Shyam, scope out. Scope out, please. All the patties away from the field. इससे छोटा गाइड वायर है क्या? गाइड वायर smaller than this? Okay. Come, AP view now. All my screws go in AP view. We go to the step number 5. आप करोगे? Take away. AP view, please. Now, if you remember, the incision for screws has to be 3 to 3.5, sometimes 5 centimeters lateral to midline. Whereas here our tube has gone 2.5 to 3 centimeters. So almost 1 centimeter lateral to the incision of the tube should be the incision of our screws. Otherwise we will not be able to get a good angulation. Okay. Come, AP. Shyam picture. An angle, brother. Now there comes the importance of true AP and true lateral views. Come, pull to me. Umesh, Neeraj.
Yeah, Vishal.
Can you see the position of the cage now?
Yeah, it's perfect. It's perfectly in the middle.
And this guide wire has gone bang in the center of pedicle, and I'm not crossing the medial pedicular line, or medial pedicular border has not been crossed, right? Like we discussed in step number 5 of the TLIF. Okay, get straight, brother. Straight. I want to put a screw in L4. If you see the L4 here is not true AP. So before I put a screw in each vertebrae, I want a true AP of each vertebral space. Come, Cook's needle. Yeah. Needle. यही दे दो, जब तक जो है वही दे दो. नहीं दीजिए आप ही दे दो. हाँ जो है वही दे दो, जो है वही. Same. Okay. Shoot please. Now as you see, the image on Shyam is a true AP for L4. Shoot please. The placement of tip of the Cooks has to be at 9 o'clock to 10 o'clock quadrant, and it should go towards 3 o'clock quadrant, 12 to 3 quadrant. Shoot please. So I have got a good hook in the pedicle entry point at 9 o'clock, and I'll slowly keep going till the tip of the Cook's needle starts touching the medial pedicular border. Now it has already started touching the medial pedicular border. I will want little less angulation. Shoot please. Shoot please. Shoot please. Yes. Shoot please. Position करेगा. Shoot. हाँ सारे. Position का view ready. और ले लीजिए तो ले ले. Shoot. Shoot please. Local है जापर में. Local gradation है. Local. Shoot please. Okay, it is touching the medial pedicle line. I will want to see at this stage if I have crossed the posterior vertebral body line. Lateral please. If I have, then this is a safe entry. If I have not, that means we are quite medial and we'll have to revisit.
Vishal.
Yes.
Would you want to enumerate on advantages of this bevel tip Jamshidi or your Cook's needle, which a pointed sharp point?
So bevel tip will allow you to slide the guide wire more in a particular direction. I generally use a far sharper needle, which is like a needle. Yeah, see, I am already in the vertebral body. That means it is absolutely safe. Can you appreciate that?
Yes.
Yeah. Come guide wire. So for the AP and lateral of that level, you exactly can imagine that your from that side. However, this needle is yet just touching the posterior vertebral body line, the L5. Shoot, please. Hammer. Okay. Okay. Shoot, please. Okay. So it is stable. I'll accept that. Okay. Come, AP again. Load, load. And skin knife. Correct. So here you see my skin lines tell me that I have to be at least 4 centimeters away. You see that? This is 4 centimeters away. I would rather want 1 more centimeter away. 1 centimeter lateral to the shadow of lateral pedicular border. If my finger doesn't goes in, that means my incision is small. And that's why my finger should be able to go in to tell me that my screw will easily walk in. Show this, show this. Brother, show this. So the breadth of the incision. So please, yeah, my finger, the finger breadth is the minimum breadth of the incision that you should be able to give. Okay, AP again. AP, Shyam picture again. Shoot, please. Yes, hammer, please. Come. I'll hold it, you hammer. Okay, shoot, please.
Shyam picture on main screen.
Okay. Shoot, please. Yeah. Remember, all this is happening under radiation. Everybody in this OT is wearing lead apron. And it's very, very important for all of you to keep yourself protected. Surgeons who do more than 150 cases of MIS surgery, be it endoscopic or microscopic Shyam guided fixations, percutaneous, guide by, or mixed cases where orthopedic nailing, interlocking is also involved. 150 cases in a year pose you at a risk of developing cancer 17% higher than general population, which is not a small incidence. By doing more number of MIS cases, probably your patients may be happy, but I am sure your family will not be happy to see in the fag ends of your year. So, and young girls and young boys, they would also want to know that the infertility rate of surgeons, load karo, infertility rate is almost 23%, and that's why when you are young, of course MIS lures you, and you should do MIS, but be self-protected. Do not get wary from using a good lead apron, a good bismuth apron, both for gonadal and thyroid shields, and of course a good lead apron and a sheet is very important. Shoot, please. That's where the role of navigation comes into picture. That by using navigation, the amount of radiation to the surgical team comes down to bare minimum. As you can see again, it's a true AP view. You can see the end plate of L5 absolutely parallel. Shoot, please. Okay, hammer. Hammer. Dhire, dhire, dhire. Dhire. Very gentle hammering, because osteophytes, hai na? So the osteophytes can prevent you from getting a good hold at your right entry point. Shoot, please. Shoot, please. Yeah, hammer. Shoot. It has entered into facet joint. See? Facet joint. Shoot, please. Shoot, please. Okay, shoot. Okay, hammer. Slow hammers. Huh? Just have an engagement first and then we'll marry it. Keep going, keep going, keep going, keep going, keep going, keep going. अभी थोड़ा हाथ जोर से कर. Okay, shoot please. Perfect. Yeah. Shoot please. Perfect. Yeah. Now I'll converge. No, heavy hammer. So this AP view hammering can continue, advancement of needle can continue till, shoot, till the tip of the needle is away from the medial border of the pedicle. And this hammering can continue for 20 millimeters, never more. Come, guide wire. And this is the point you would want to have a lateral view coming in picture. Come lateral, brother. And if all my 4 guide wires, which are satisfactory in AP, look satisfactory in lateral, I would then start tapping and getting my screws in. Come dilator, 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 and tap. Yes, please shoot. So my Cook's needle is looking fairly well placed and the guide wire is just entering at the posterior vertebral body edge. Come, tap. No, I don't want 40. So I usually don't like to tap more than the entry of the pedicle, which is almost 20 millimeters from the point your tap touches the bone. Shoot. Just enter into the pedicle and that should be enough. Shoot, please. Shoot. So I have just crossed the posterior edge of the vertebral body. Hammer. Now, guide wires are the enemies of MIS surgeons, and that's why you have to have at least one friend of yours to tackle this enemy. And one friend is your associate who gives you a hand to control the guide wire at all points in time. It should not move anterior, it should not move posterior, it should not get withdrawn. And pull it out from the surgical field as early as you can. Come, shoot please. So the moment your screw touches the posterior vertebral body, shoot please. Just pull it out. That's when I would want to pull it out. Shoot please. Shoot please. Shoot. And we keep the tulip of the screw just at the place. कर देते हैं कि पहले इधर कर देते हैं. चल डायलेटर. Does your screw walks in through this? No, I don't think it does. No, through this, no. So how do we reduce the number of shoots that are required is by counting your turns. If you know that by counting your turns 12 times it walks 15 millimeters, you just rotate 12 times, don't shoot. You don't have to shoot every time. Just count your turns. This was a Korean technique described by Fukushi, and they are the guys who have promoted this, that count your turns so that the amount of radiation required reduces. Here I am using a 6.5 millimeter, 40 millimeter length of the screw. Another point of importance is that the tulip of each screw, of the two screws, it's okay, let go. Tulip of the two screws should be lying absolutely in level with each other. And 12 times gone, so this should be out. Shoot, please. Shoot, please. Yeah. Load another one, please. Dilator. Yes, in a while. You have to show that, right? Again, the guide wire. By this time, you are distracted. You are so lewd by putting in screws that you tend to forget that the requirement to control the guide wire is supreme at all points in time. You cannot get distracted and your attention go away from guide wire at any point. It can dodge and create problems at any point of the surgery. 11, 12. Shoot. So 12 counts, you see I will be in the buttle body. See that? Already in the buttle body. Hammer. I'll get my guide wire little walk in. Hammer. This guide wire will walk out. Anyway, let's see if it does. Shoot, 12 turns in. So my guide wire can walk out. Shoot, please. Yeah. थोड़ा सा oblique दिखाएंगे please. Shoot. Shoot, please. Okay. Some dilators again. Some tap, please. Some screw coming in. Rod measurement mechanism ready, please. $640 mm again. 5, 7, 9, 11, 12. Shoot, please. See, never wrong there. Pull the guide wire out. Artery, hammer, pull the guide wire out. So this is the time when my screw starts touching the posterior vertebral body line. I'll always get my guide wire out. Sometimes guide wires can migrate in while your screw is advancing inside, creating an anterior perforation, sometimes vascular injuries, sometimes visceral injuries, intestinal perforations. And remember, if by any mistake your guide wire perforates the anterior vertebral body, and you don't have to pull it and get the same wire inside. It might have just had an inadvertent intestinal injury, and you should just discard that guide wire. Shoot, please. Shoot, please. And now we will measure the length in the field, surgical field view. Different systems have different mechanism to measure the rod length. Here it is showing 50 millimeters as it has a gradation on this. It shows a 50 millimeter length. On the left side and on the right side also 50 millimeters. Now there are mechanisms of rods coming from the top. There are mechanisms from the rod going from the side. There are rod mechanisms going within the tulip of the screw, and there are mechanisms which run directly down where there are open tulips. Every system has a completely different mechanism of rod insertion. I would recommend to play with these instruments before you wash up for the surgery. Intraoperatively, it can not only be a matter of irritation, sometimes you may get stuck if you are not well versed with the armamentarium that you have. Rod to rod. Yeah, here na. कब से join किया Globus? Last 10 years. I started using 14 years ago. So this rod, 15 millimeters, how does it function is, you just open the tulip and it straightens itself. Right? That's how the rod goes in. Even by mistake, don't open this golden sleeve, neither in the rod holder nor in the screw holder. These golden sleeves have to be removed only and only after your rod has been placed well, because the moment you release it, the rod may lie loose there and be placed suboptimally, and you may have to fiddle around. Okay? Touch, pull, rotate. Light, please. Light. Can we have the top light coming in? You have to ensure that the rod engages the second tulip, and this can be visualized directly. And also there are instruments to ensure coming. ऐसे पकड़ना tulip. नहीं इधर से नहीं, ये वाला हाथ. Okay, come. And this instrument, come, allows you to understand whether a rod is in or not. Here I can see the rod is in, and because both the lines are above, that means you know that the rod is in. The two lines, the circles that you can see, if the two are above, that means the rod is inside. However, if one is above, that means this is falling further down, and both are not. Now you secure your rod inside the screw tulip. Okay, Shyam, please, shoot please, to see if the rod is scapulared or corded. Okay, that's perfect. Show that image. Come, Ini. No, I don't want to tighten at this point fully. पूरा टाइट कभी नहीं करने का. पूरा टाइट किया तो ये रॉड ऐसे उठ जाता है. And then you disengage the golden one first. Turn the tulip back. And get it. The rod is inside. This also works like a reduction device when you have a grade 1 or 2 listhesis. But like Dr. Neeraj mentioned, that in high grade listhesis, you better do a release because your stress on the implant can be immense. Okay. I'll want a compressor here. So one tightened fully. and the other one used for compression device. Yeah. And save this image there. Okay, now we'll compress further. Shoot. See that? And that shows 5 degrees of lordosis added just by compression mechanism. And that side our work is done on the left side. Okay. Take that. And the compression device can come out now, and the tulips can come out too by opening the golden one. The same thing will be repeated on the right side. Some rod. No, I don't want. Hold these two together here. No. Okay, rotate this one. Coming. Okay, छूट गया. Rotate now. No. So if you see, the rod has become straight but has not engaged the superior screw, not yet, right? So this is what I was telling, that you have to confirm whether you are engaging the other screw or not, both by direct vision and also by the instrument that is provided. Not yet. Shoot. Yes. Hello. The rod is disengaged. Artery. इधर ही है. No, we have it in front of our eyes. Otherwise, it becomes a struggle at times. Come again, get engaged, please. This time, make it tight, please. Can table go down? Catch here. Here. Push. Perfect. Yes. Sit. Confirm. Perfect. Kamini. Take on Shyam, please. Shoot, please. Perfect. So generally I don't like to compress on the contralateral side for two reasons: that if there is a subclinical foraminal stenosis, if I compress on that side, it may become a symptomatic foraminal stenosis then. So compression only on the side where your exiting nerve root was visualized or where the foramen decompression was done. Horizontal. Hold. Okay. Come, camera facing this side. Okay, come. Shyam shoot one AP, one lateral, and then we see the surgical wound. Shoot, please. Okay, show that picture. Shyam picture. So our lateral shoot is there. Completely reduced, lordotic, L45, centrally placed cage with good amount of disc space preparation. Save this image. Save this image. And come AP. And just a ruler then a ruler. Tape measurement. Yeah, come AP, come to me. Okay, shoot please. Okay, save. Done. So our surgery is over. AP and lateral views, centrally placed cage, quite well distracted.
Excellent.
And we'll see the surgical wound. Can the cameraman show the surgical wound? Come near. Okay, Shyam can go away. Shyam can go away. Ruler. Just a ruler. Do you have ruler? Tape. Measuring tape. No worries. Come, cameraman. Come here. Come, show the surgical field, please. So the length, come nearby, Shyam can pull away. Can the cameraman come here? The total length of the incision, 25 millimeters on one side and 2 wounds of 1 centimeter on the other side.
Excellent, Vishal.
Thank you. Thank you, gentlemen. Any questions? I will be happy to be around.
Any questions from the audience? So
Good,
there were a
good.
few questions. One was, what is your average size of cage?
Average size of cage, I generally don't like to use anything more than 13 millimeters because of 2 reasons. One, the only place where a cage more than 13 millimeters is justified in my books is a young guy with above and below discs being more than 14 millimeters, which is a very rarity. In elderly gentlemen where there are multiple level disc degeneration, if you use that one segment to jack up the whole segment, the chances of you having subsidence or adjacent segment degeneration is very, very high. And that's why my average size is never more than 11, 12 mm. So if it is 12 mm, I am very happy. But having said that, it is never pre-decided. It is always an intraoperative decision that which size of distractor and pucca is giving you that grating sound and where does the end plates distract by few millimeters during your pucca distractions. However, if you overdo it, a bigger size pucca may still go may still give you grating sound, but you would have breached the cortical end plate and cancellous bone will be there giving you a feeling, pseudo feeling that you are snug fit. So it's a very subjective balance, and I'm sure every surgeon will have made their own protocols about this.
Vishal, one more question. If you have damaged the end plate to the extent that you are worried, what would you do?
So the damage to end plate is never full end plate damage. In an end plate, the damage would be a certain part of the end plate. That is what you would want to analyze. If you noted, I used my nerve hook to feel the cortical end plate. If my nerve hook is poking in that area, I know that I have breached the cortical end plate and it is going in the cancellous area. So my cage placement in that case will never be towards that point. I will rather have eccentric cage placement either this side or that side, or I will actually use a cage with a bigger footprint rather than a narrow footprint. Like in this case, I used a 22 millimeter. I would rather use a bean-shaped cage where the damaged end plate part is circumvented by the normal end plate. So this is something that we need to understand, that don't allow the footprint of cage to be sitting in the damaged cortical end plate area. Otherwise, you are making a recipe of subsidence, cage migration, implant loosening, and a lot of back pain as well.
So in a porotic patient, I think around way back, I had actually put one cage inside the vertebral body. I hammered the cage inside and took a shoot. The entire cage was into the vertebral body.
Can you take down
to that extent, we have damaged end plate.
Oh,
the only option was we retrieved the cage. I did a facetectomy on the other side, used a facet bone, just packed it on that to give support and put the cage from the opposite side. So if you have significantly damaged your end plate, you have to go on the opposite side. You need a solid foundation above and below if you want to achieve a good fusion. With more end plate damage, there are higher chance of, although a cancellous bone is exposed, but still higher chance of having pseudoarthrosis.
Yes, yes. Yes, thank you. Thank you, Dr. Luhana. Thank you, everyone.
Thank you, Vishal and team.
Sister, one patty is here. Patty count mein hoega.
Vishal, wait, one question is coming.
Yes, patty count mein. Yes, Neeraj, I'm hearing.
The pedicle screw placement, the IITV positions and whatever the 4 guide wires, many more rotations up and down.
In thoracic spine, he's asking.
Thoracic spine.
So rule number one, never be shy to convert a MIS surgery into an open surgery. What are the chances where you would want or you would be forced to convert a MIS into an open? There are a list of such conditions which you all know pre-operatively. Unless you have not planned it well, you all know which cases should not be done pre-operatively. One of them is a poor visualization of pedicles either in AP or in lateral view, which very frequently happens in a very obese patient, in osteoporotic patients, or in patients where S1 pedicle is not visible due to severe facet arthritis.
Right.
So before you commit yourself by doing a tubular placement and you have done decompression, always in an AP and lateral view, even before you wash up, ask your associate or yourself or your nurse to do a AP and lateral view in true AP, true lateral images. Try to see whether the visualization of pedicles is enough to get good pedicles through instrumentation or not. If for any reason you feel that I am not able to visualize, despite good angulation of Shyam, positioning of the patient head high, tilt one or other side, correcting the rotation, playing with Shyam, despite all your maneuvers, if your true AP and true lateral imaging is not able to tell you about the detailed visualization of pedicles, please don't do it MIS. You will land up into bigger problems. Your screws will never be evaluated whether they are intraosseous in the pedicles or they are lying and hitting the nerve roots. So one condition where you should always restrict yourself from doing MIS is poor visualization of pedicles in AP and lateral, and that should be pre-operatively.
Number 2, you are operating on the same side, doing foraminectomy and decompression and then compress that area. Do you distract on the opposite side?
So that I have never done that. If I feel that my pukka creation, my distraction with the help of distractors is not able to generate the distraction in the end plates, that means by just having 2 screws on the other side and distracting it will only lead to screw loosening sooner than later. And
Right.
that is why distraction or using implant forces to reduce elasticity or implant forces to distract it is something that is not recommended. At least I don't follow it. I don't practice it.
Do you use any antibiotic in wash from the beginning?
Never. Unless there are surgical site infection is a completely different chapter. Only patients who have proteinuria, uncontrolled diabetes, or are very high risk candidates for infection, like patients who have generally undergone an abdominal or urinary surgery in last 6 months, only those patients I would do a betadine wash rather than a normal wash, but never a vancomycin wash unless the patients have frank proteinuria pre-operatively along with very high risk candidates.
Being a neurosurgeon, we are very much worried about the CSF leak. So we put the fascia skin, we make a flap-like position always.
Yeah.
During the exposure, not on the same line of incision. So even if there is some accidental sometime happens, then it may have a good coverage.
True that. I agree with you, sir.
For the input. So we have small case, next one. Then we have 1 hour question answer session.
Yes,
you, Vishal.
thank you,
Excellent
Dr.
demonstration.
Luhana. Thank you.
So Ankit, we go ahead with the next case.
So today last case, 66-year-old female complaining of low back pain since 1 month. History of fall 1 month back. Unable to walk and stand without support. On examination, lumbar midline tendon is present. Lumbar range of movement restricted. Neuro intake. X-ray. Initial X-ray. 1 month back. So further collapse. L1 osteoporosis compression fracture. CT scan. MRI.
MRI showed L1 compression fracture with a significant collapse, and in a 4-week follow-up X-ray showed significant further compression.
Initial X-ray and 1 month after.
So here you can very easily see there is significant intravertebral instability if you compare with sitting and lying down X-rays. So it's opening up when you are, the vacuum is slightly opening up when you're in a sitting and lying down X-ray compared to sitting. There is probably a Kamal sign vacuum inside. Rakesh, you are taking us through the case?
The L1 compression fracture, elderly, osteoporotic.
Your voice is very, very, very muffled.
Just a moment.
Hello.
Hello.
Yeah.
Can you hear me?
Yes, now it's better.
So L1 compression fracture on 4-week follow-up. There was no clinical improvement, significant back pain. Dynamic X-ray in lying and sitting showed opening up a fracture. So we decided to go ahead with a vertebroplasty. So just wanted to make sure that people see vertebroplasty here. Very easier procedure. So because of short of time, we already began vertebroplasty here. Hello.
Yeah. Go ahead.
Yeah.
Go ahead, Rakesh.
So the entry point is as similar as pedicle screw that has been demonstrated in a previous surgery. So come here.
Oh, the cementing is already done.
Yeah, already done. Anyway.
Okay. You are taking us. Okay, you are taking us through the steps.
Yes.
Okay.
So basically, you enter into the pedicle with a Jamshedi needle EP view, and you go at least 2 centimeters inside and make sure that you are in that round pedicle hole. Then you take that. Make sure that you have crossed the posterior vertebral body. Then
Your voice is breaking, Rakesh. Your voice is breaking. The collar mic was better.
So once we are satisfied with the position, audible?
Yes, much better.
Yeah. So once you are satisfied with the position, then we mix a cement and then fill it up in a 1 cc syringes. Hello? Can you hear me?
Yes, yes, we can.
Yeah. So once you get the proper toothpaste consistency, you inject it 0.5 cc by 0.5 cc. So like this is the needle we use. So filled it up 5 syringes. One syringe I use to keep to see consistency. So once it becomes like a toothpaste consistency, I injected it. Inject 0.5 cc, take a shot. Inject 0.5 cc and take a shot. Make sure that there is no extravasation. Maximum amount I use is 3.5 to 4.5. So here we finished it. We did 4 cc of injection. Surgery is done under local anesthesia so that we make sure if any adverse event occurs. Shyam, you please.
Dr. Rakesh, so when are the cases when you will use single needle, and this is single needle?
So I use yes, monopedicular entry, single needle.
Yeah. So when would you choose a single needle and when would you choose a double needle, and would your entry point change when you are using a monopedicular approach?
So in your monopedicular approach, entry would be coming from more lateral, and you make sure that your tip is in midline so that you go on both sides. Initial practice I was using bipedicular approach, but with time almost all cases now unipedicular approach. And they don't make any difference in the coverage. Like here we have used unipedicular approach, but on Shyam AP view you can see that it's completely filling up as the same you see in bipedicular approach.
Yeah, it's actually a very nice filling.
Yeah, thank you.
And yeah, sorry. You can
important
continue.
is don't be overzealous, don't use too much of cement, and timing is important. So whenever that consistency is thick, toothpaste consistency, at that point you have to inject so that it would prevent extravasation.
Which are the cases where you will use a fixation? It's a question from one of the delegates.
So the fixation I would use this is like an intravertebral instability. Whenever there is intervertebral instability, like patient with a neurological deficit, patient with a significant kyphosis, when I get lying and sitting X-ray, significant change in a kyphosis, in those patients you have to augment it with a hybrid procedure it's called. I augment it with a cement with a percutaneous 1 above 1 below fixation.
And what is your take on using a balloon kyphoplasty versus a vertebroplasty?
Yes. So balloon kyphoplasty versus vertebroplasty. Kyphoplasty is very expensive. Vertebroplasty is a cheaper option. Theoretically, more extravasation rates with a vertebroplasty, but in my practice, I don't see any difference. So I do preferably vertebroplasty. I don't use kyphoplasty. Any more questions?
If intraoperatively in such cases, so if you feel that there is any extravasation into the disc space, like either superior end plate or most of the times it is superior end plate, so would you like to do anything in those cases, or you would just leave it and observe?
So if it extravasates into disc, it doesn't cause any problem. So you can leave it behind. In fact, there are some papers they do discoplasty. So extravasation into disc is not to worry, but either you stop at that point, or if it happens at initial stage, you change the tip of the needle and you try to inject at other place.
Any other questions? Any other questions from delegates?
Yeah, thank you so much.
Thank you so much, Dr.
Hello, Rakesh bhai.
Yeah.
This is Maulik. What are the immediate steps in case of spinal canal extravasation? What we have to taken care is okay, but there can be accidental extravasation. So what are the further necessary actions?
So this is one thing that has to be absolutely avoidable and should be avoided. So the one thing is you should not be inject in hurry. Make sure it's a proper thick consistency like a toothpaste. Second, you take a shoot at every 0.5 cc. So even if it is extravasating, it is very little amount. So you can see the screen, the filling is predominantly in an anterior and middle part of vertebral body. As soon as you see that your cement is coming in a posterior one-third or one half of vertebral body, you should stop it. And if it happens, I had one incident when one orthopedic surgeon did a vertebroplasty and I was called, and we did patient had complete paraplegia, post-op it was detected, and we went ahead, did a posterior laminectomy and drilled out that cement. By that time, that cement was very, very hard and it was a very, very tough time. So this is one complication which is absolutely avoidable and has to be avoided. Very difficult when it's happened.
And one more, sir. Whenever we use cement, the cement column will lie into the needle, and it will look appearance of the stick-like appearance in pedicle, cement, leftover cement. So how do you avoid it?
Sorry, say again. Didn't get it.
There will be the bone cement which is in the cannula will remain to the track. So how do you avoid it?
So once you inject your cement, you try to break that cement consistency with the connecting with this needle. So you put a stillet back into it, try to rotate it, bring it out little bit, and make sure that that cement would not be getting back into the track. Okay, thank you. So we have 15 minutes tea coffee break, and we meet again with all faculties with a question answer session. You can talk or discuss about any queries or any questions you have. Thank you.
જઈ લેજો વાત હવે એનું કામ પતી ગયું છે એવું છે એનું પતી ડિવાઇસ
हो गया जी
Check. Check.
Hello. Yeah. Good evening. Yeah, just focus attention here. So we had good interactive session. We had a lot of discussion during surgery. But if we have any more questions, we have a small session of question and answer session. I invite all three faculties here. Dr. Umesh, Dr. Niraj, Dr. Vishal. Any burning questions?
Yes, sir. No, in fact, the fun of having your incision placed laterally lies in the fact that through the same incision you can have decompression tube and also screw tulips from the same incision. Not only the skin incision is same, but also the facial incision remains the same. However, there are instances where you may have to take a separate facial incision, because invariably, particularly in cases when there is a broad lamina, like today all three cases that we did had a narrow lamina. They were like kissing facets, where the facets are lying very near to the spinous process. But there are situations where the lamina is so broad. So in such a broad lamina, your tube cannot come from so lateral, whereas your screws have to go lateral, and your tube comes medial. But if you try to put a screw from this same facial incision, you may not get a good convergence, and you may actually end up either perforating the nerve root, or you may actually end up perforating the facet joint. So those are the only cases where you see on pre-operative imaging, if the lamina is broad, if the facet joint to spinous process distance is more than 2 centimeters, then skin incision still remains the same, but facial incision may be little different, and tube may come from a medial facial incision and screws may come from a lateral facial.
As long as possible, you use the same skin incision for the same side.
I'm yet to remember any case where I have to put a second skin incision for putting in my screws. I never for that. How about you, Umesh?
Well, it's right. Especially, skin incision, very rarely it is required. And more often, what happens is when we are putting the screws on the contralateral side, I think those will be angulated significantly more than the ipsilateral side. And maybe more than with 2D navigation, with 3D, what we have realized is that our screw angulation actually has increased. We are more angulating it more medially in a 3D system, when we use a 3D navigation, as compared to what we were doing when we were using a 2D navigation or with just a 2D fluoro. And this especially what Vishal told, most of the cases nowadays, we are using separate facial incisions for putting the screws, because our screws are coming from a much lateral to medial angle and much lateral to medial direction, whereas we can't use the same direction, same angulation to do the decompression work. So we need a more medial facial incision. So most of the times. So, and the second implication of this is earlier when we were putting the screws through the same facial incision, we don't have to put a dilator. We don't have to dilate when we are putting a screw, especially for the lower vertebral body. But nowadays, because you are using a separate facial incision, it also means that we are using a separate transmuscular tract. So in most of the cases, we have to use the dilators for putting the screws, whereas earlier for the lower vertebral body, we could just directly tap it and put in a screw.
I worry and concern for people who are going to be using more number of 3D navigations, or for that matter, very convergent screws which look beautifully and amazing on X-rays and CT scans. The concern is today, I'll give you two hypothetical situations which are going to be very, very common. A patient who's undergone a normal, what we did, like a 2D fluoroscopy guided TLIF, 5 years down the line, this gentleman will develop adjacent segments. He will develop adjacent segment stenosis, which will require surgery. And in that situation, whether we do a MIS surgery, for example, it was L4-5, and there is a 25% possibility that this patient will come back to us for L3-4 adjacent segment stenosis. If my screws are how they are, it will be a simple job to revise these screws, because what I need to do is only put 2 screws in L3, remove this rod and connect the rod, and the job is done. Now situation 2, where you have put in convergent screws in O-arm. Convergent screws in O-arm comes from almost 10 centimeters away from midline, and now you develop L3-4 listhesis or L3-4 stenosis. how are you going to remove that rod? You will not be able to do it in a MIS manner. You will have to do it in an open manner. And imagine the amount of muscle retraction that you will have to do both ways. Despite this, you will have to put upper screws L3-4. How will you connect this unless until you do that also in the O-arm manner and get the rod connected?
So I strongly disagree. Your entry point on the skin is lateral. Your entry point on the pedicle is the same. So you are not entering from the transverse process and then going into the pedicle and then this one. So your entry point on the pedicle is the same. That is at the junction of the pedicle and the facet. So only your angle is different. You are approaching this from a more vertical trajectory, whereas you are approaching it from a more lateral to medial trajectory. So if you see the rod actually is in the same vertical plane, whether you come from a lateral to medial direction or you go with a vertically, straight screw.
So a screw, Umesh, that's O-arm related like that, and a screw that you put here. These are connected with rods. Move these rods. You have to actually go lateral.
O-arms also.
So does that mean O-arms lead to early revisions? Because O-arms have been in place for the last couple of years only.
No, we have done it. We have done it, before O-arm I was using a 3D CM. So O-arm is now only since 2.5 years, but before that we were using a 3D CM. So during that also we have revised. But I'm telling
so
you
you do it MIS? Revisions also
yes,
MIS?
Yes.
So you put the same incision, you go and remove the ini, dissect it, get your tulips of the screw, like the globus ones, you clamp it, and then you put the globus screw in the same O-arm manner, and then you get the rod in.
Correct.
And this you can do through this tiny 1 centimeter incision.
Means for an for an additional screw you put a separate incision.
For removal of this rod you can do it through.
Yes. So we have done it because again for this you can use it as a navigation. I have a video if you are not able to believe it. But
so this is professional stunts, better done by professionals only. For lesser mortals like it is almost impossible unless you really connect the two incisions together and you really take the facial incision and to go into that plane, protecting the muscle, to open the innies and get the rod out, it requires fair amount of muscle dissection. And that's my point. That the amount of muscle dissection required for revision of these convergently placed screws is not less than morbid. So this is one concern that comes to my mind who use O-arm guided fairly convergent screws or 3D C-arm guided fairly convergent screws. Even in those cases, my recommendation is please try to have your screws placed more straight. Unless you are already looking at a terminal surgery for a adult scoliosis.
So now,
well, I guess the cases what Vishal is narrating, where extreme oblique convergence comes, they are not very common patients. We get CT scan to almost all our patients who are getting fixed. I feel that yes, I agree there are 25 to 30% L4-5, where specifically 5S1. They are quite obtuse, very very convergent screws, and I may foresee those issues probably in future that I might have to realign those. But majority of Indian patients are not so convergent if you look at the CT scan. So my opinion will be between both of them. I will not choose the side here.
Okay, so my question is like a lot of new technologies coming in. Transforaminal endoscopy, interlaminar endoscopy, UBE, MISs with tubes, OLIFs. So for a newer guy who is into prior practice, what is your take? What they should learn, how they should learn, how incorporate those things into practice?
True. So my same thing to continue. What do you see like the future for the endoscopy spine over the MIS spine?
Well, I guess endoscopy, I would say, is a part of MIS. Everybody agrees to that. World over, the literature is very clear. Whether you specifically when you do discectomies, whether you do a traditional microlumbar discectomy, you do a tubular discectomy, you do transforaminal, you do UBL, I think results more or less same. The thing which has changed is probably the persons who are sponsoring the events. They have probably created a market for endoscopy, and patients are asking that sir, do you do endoscopy? So somewhere we have to fall into demand, but I make my patients very clear that results, irrespective of technology, eventually are same. In fact, we have Very recently, there is one study published in Lancet, and it's a 10 years follow-up of different MIS technologies, and they have concluded that, in fact, beyond 3 level, if you do this MIS TLIFs, probably it is slightly inferior than open one. They have not considered this OLIFs and all those things, just strictly MIS TLIF, because amount of muscle dilation, amount of muscle dissection you are doing. So MIS TLIF, current literature, what they say is up good or equal up to 3 levels, beyond 3 levels, slightly inferior than open. So if you are not going interior, OLIFs and DLIFs and all those stuff, then I think, better to convert into open rather than going for MIS TLIF. As far as this decompressive aspect is concerned, choose the treatment you like. I think future is for the patient is same. We have to fall in by demand for the patient. Patients are coming and asking, sir, do you do endoscopy?
So that is the issue. Like here in Tier 2 city, if you are doing MIS surgeries in spine, like I'm also a neurosurgeon and even the ortho side also. So in Bombay, like Tier 1 city, do you face this issue related to the endoscopy? Because even here also people are coming and asking us for the endoscopy.
So we need to understand what is the exact definition of endoscopy and what are the boundaries that we are pushing. There are 2 aspects to it. One is literature, science and scientific evidence behind it, and what is the market and marketing forces behind it. And if there is a smart patient, he will understand that what you are doing as a tubular microendoscopic surgery is, in current scenario, more scientific, better, reproducible, particularly when it comes to fusion surgeries. Let's compare a scenario where you have to do a decompression for a 4-5 by either a tubular microendoscopic like what you saw today, and second, the same case you have to deal with endoscopically. And case 2, where you have to do a MIS TLIF fusion like this here, whereas you have to do the same endo fusion for a L4-5 in this case scenario. Now case 1, where you have to do only decompression, has endoscopy got any better advantages clinically, radiologically, cosmetically, or evidence-wise? The answer to this is straightforward no. Can you sell it like an endoscopy? Of course, the name microendoscopy gives you the marketing forces to sell it better, right? So what you are doing, you are not forging it. You are not telling that I am going to do a microendoscopic procedure and you are not doing microendoscopy. While you are doing microendoscopy, you are selling it microendoscopic. Unfortunately, when it comes to endoscopic surgeries, the reproducibility of these procedures is fairly low. Can you do a osteoid osteoma of C2 by using endoscope full UB? Cannot. Can you do a cervical decompression with endoscopic? I think 1% of the total endoscopic surgeons will be able to do it, whereas almost 95% of tubular surgeons can do a microforaminectomy using a tube. So the reproducibility, the applicability of tubular microendoscopic surgeries is any day better, applicability is better and wider. Coming to fusion, there is no doubt in endoscopic surgeons' mind also that the current format of endofusion, current format, is less beneficial because of lack of availability of instrumentation related to cage insertion. Percutaneous instrumentation remains the same. Cage insertion, the instrumentation that is currently available is suboptimal compared to what it is in microendoscopic tubular techniques. For example, we were talking about a 14 millimeter and a 15 millimeter cage. Is there any system which gives you access to 14 millimeter cage in endofusion? They are very limited. There are. I'm sure you will vouch.
I'm inserted 13 kgs.
I'm talking about 15 millimeters.
I don't see any need of 15 posterior.
Exactly. That's what we spoke about. What I'm trying to say is that in current format, the applicability, the reproducibility, and the benefits of endofusion in current format are surely not matching the MIS TLIF. That can be done multi-levels, 3 levels. There was an era when endoscopic surgeons used to say that we do it under local anesthesia. Now even that benefit is gone. The most renowned endoscopic surgeons are doing be it transforaminal or interlaminar under spinal or general anesthesia. So that benefit is taken away. Fusion remains on a better side with microendoscopic technique. Applicability is better. wider, reproducibility is better, and the cost involved is lesser. Learning curve is less steeper. I would not say lesser, but less steeper. Having said that, 95% of MIS surgeons today are learning endoscopy for whatever reason, be it that seems like the future, that seems like the market forces, that seems like the patient demand. For the newer generation, the message is very simple. If you are not the amazing in your field, if you don't have a wider armamentarium for the patient to choose from, you will lag behind. So on one hand, you have to know about open surgery. On the other hand, you have to know about all the aspects of minimal invasive spine surgery. There is nothing called a niche endoscopic spine surgeon. You can do it, but unless you have something in the form of percutaneous pedicle screw instrumentation techniques learned, a good endoscopic surgeon is also trying to have a gray area of learning instrumentation techniques. Correct me if I am wrong. Instrumentation techniques, percutaneous instrument techniques.
Yes, we can do that. I mean,
yes,
endoscopic. Absolutely.
That's what I'm saying. So we are learning it. On one hand, endoscopic surgeons are rising towards a common path. MIS surgeons are also going to a common path, and open surgeons also have to merge into this common path. And this common forum will have to be like what I call Amazon forum, Amazon aggregator of all the armamentarium. So your armamentarium, you should be aware. Dr. Luhana has brought this afternoon, he was telling me that he's brought a 1 CR instrumentation set for endoscopy. He started doing endoscopic surgeries. Neeraj has been doing it for quite some time. Umesh has been doing it. I am yet to learn it. I have attended courses on endoscopy. I started putting in needling. I have started, procuring some basic instruments. So I'm in the phase of evolution of endoscopy. On one hand, in current format, I believe that tubular surgeries are better, probably because I know them better. I can reproduce results. The applicability is bigger and wider in my hands with clinical advantages which are no less than endoscopy. On the other hand, I am also in the process of evolution to learn so that tomorrow I still have that amazing armamentarium of different kind of surgeries in my hand. And young guys, you don't learn it, you will be left behind. You will surely be left behind. Because you have to learn things to fight us, to fight the third generation of spine surgeons, and then the second generation, and then the seniors, first generation.
So that is what I was saying, that market forces are, probably we, Rakesh, we all have reached to a stage where we can tell the patient that don't worry, it's equal. Benefit, I'll do it in a tubular way. So patient might trust it, but somebody who is young, safety is something, they make it similar with the endoscopic surgery, most of the patients. So young surgeons who are coming in, if they don't offer endoscopy, there are chances that patient would want to go to a probably senior surgeon. So every young generation, probably I feel that has to learn endoscopy.
Your take, Umesh?
The fall of any branch starts when too many people take it up. Because the moment too many people take it up for the sake of competitiveness, for the sake of making it available in my hands, that's when the exact fall of a particular branch or sign starts. Because it's what we call the Lord's happiness phenomenon, where too many people are offering it. So the same patient has 5 different people to do the same surgery. The cost will come down, the earnings will come down, the names will come down. You would want to do it less and less. You would want to innovate it, or the indications will extend. That is how endoscopy has probably earned bad name, which tubular surgeries probably have not reached there. There are so many endoscopic surgeons who are doing it for extended indications of back pain, acute discs, which are bound to get better. आज ऑपरेट कर दो वरना दरवाजे तक दूसरे के चला जाएगा, वहां वो कर देगा, यहाँ पे घर पहुंचते पहुंचते ठीक हो जाएगा. So unless until the basic principles remain the same about selection of patient, no branch will survive the test of time. And this is the primary message that we all should take home, that your counseling has to be truthful, principle based, patient selection based. Your technique can vary depending on how comfortable with a particular technique you are.
Yeah, thank you. So Dr. Umesh has to leave early, so we'll felicitate him. So thank you, Umesh, for sharing your expertise and demonstrating an excellent surgery. Dr. Deepak Joshi, please felicitate Umesh Srikantha. time to felicitate Dr. Vishal Kundnani. Dr. Nikhil would felicitate Vishal Kundnani, who had been very interactive and showed an excellent demonstration of MIS TLIF. Thank you. And Dr. Neeraj Vasavada, who demonstrated excellent MIS discectomy. Dr. Umesh Patel felicited Dr. Neeraj Vasavada. So with this, we will come to a conclusion, and time to say thank you to MISSAB, who gave me an opportunity to organize, and SAG, who gave us platform to organize this, and then our sponsors. Globus was a major sponsor who sponsored it with a huge amount, as well as implants during surgery. Apart from the Globus, we had Sun Pharma, we had Medtronics, we had SK Enterprise, Aspen, Intas, Viltis Pharma. Thank you all the sponsors. Thank you all the delegates who came in and attended very enthusiastically. Dr. Anup Thomas came all the way from Cochin, so we appreciate all the delegates. It was an excellent audio-visual. Thank you, Utkarsh and team. It was a very well demonstrated event. Thank you. It was I would also thank Anubhuti Event Management, who had managed it really well. I also thank my colleagues, Venus directors, as well as our anesthesia team, our staff, admin, everyone, as well as Royal Orchid. Thank you all. It was a great day of learning. And at the same time, I would say that to all the delegates, if you have any more questions or in future after going home while doing a case, you need any guidance, you can contact any of us, and we would be happy to guide you to take this MIS further into your career. Thank you.
कोई पासवर्ड નથી આપણે
No problem.
કશું જ નથી કોઈ પાછું